DCIS. Size is usually not a very good criteria, but it can be more than 2 mm in DCIS. Myophthalmial markers are ADH, while it's present only in the periphery in DCIS. And 5-6 marker can help us to diagnose, while the proliferating Ki67 index is, of course, high in the in situ carcinomas. So why do we need to talk about these tumors? UDH and ADH can just have follow-up and then close monitoring, while cases like DCIS, if we diagnose DCIS, yes, these patients, they have to go under particular surgery or treatment. Next is about the papillary lesions. What do we do if we get this kind of lesion in our slide, on our slide? You can see papillary structure, though the photo is not very clear, but we can see the papillary structures. WHO has classified this papillary lesions of breast into this category, which I have listed here: intraductal papilloma, diseased papillary, encapsulated papillary carcinoma with without invasion, solid papillary in situ with invasion, and intraductal papillary adenocarcinoma with invasion. So I have some of the cases that are going to focus these lesions again. So there are 3 cases here. Any insights? Dimagma? All of them look very encapsulated. All of them look papillary. So what may they be? Are they the same lesions or are they different, as WHO has said? Let's talk about the first lesion. This one is encapsulated and shows complex branching fronts, papillary fronts, and it's lined by, and high power view, it's lined by the epithelium and the myoepithelial layers. And in IHC, the P63 was positive in myoepithelial cells. Yes, this is just intraductal papilloma, benign. Second case, yes, this is also encapsulated, has complex branching fronts, and is also lined by layers of epithelium and myoepithelial layers, but has focal cellular atypia, and P63 highlights the myoepithelial cells in the fibrovascular core and in the periphery. So what do you think it is? Yes, it is DCIS papillary. The third case, it has also a well-circumscribed lesion, and it is also papillary, but it has low to intermediate grade cellular atypia. Few mitosis were also observed, and myoepithelial marker were totally absent in this case. So this is encapsulated intraductal papillary carcinoma. Yes, the first one, intraductal papilloma, second, diseased papillary, and the third one, encapsulated intraductal papillary carcinoma. This is another case, case number 4 from Nepal Cancer Hospital, 46 years female, left breast lesion, and we received a true cut biopsy. You can see here, there is the fibrous stroma here, and you can see the papillary lesion. While going into the high power view, we can see there are proliferation of these atypical cells, but we cannot appreciate the myoepithelial cells, which was later confirmed by CK56 negative. These tumors were diffusely positive for ERPR, and Ki67 was pretty high. So this is papillary carcinoma. Again, we have a conclusive morphological and IHC features here. This is intraductal papilloma, DCIS papillary, encapsulated papillary carcinoma. As you can see here, the architecture, it becomes more and more complicated with more atypia. The myoepithelial markers are positive in the intraductal papilloma, while absent or maybe plus minus in disease, but can have only in the periphery, while it is absent in the papillary carcinoma. This I got from the internet, the approach to papillary lesion of the breast. If we have any papillary lesion, so what do we start from? We start from myopithelial staining in the lesion. If it is uh, positive, then it is papilloma or intraductal papilloma. If it is incomplete or absent, then it's papillary carcinoma or DCIS. If it is only in the periphery, of course, it is DCIS. If it is absent, then we go for intracystic papillary carcinoma. Since we can, similarly, we can also go for basal keratin markers. If it is positive in solid areas, then it's papilloma with florid epithelial hyperplasia. While it may be variable to negative, then we have to think about papillary carcinoma with or without neuroendocrine differentiation if they are positive. So why subclassify these papillary tumors of breast? Can't we just say it's papilloma or just it's benign or malignant? No, because as we subclassify these papillary tumors, the treatment plan of the patient varies a lot. So if it is IDP, can have just follow up. Intraductal disease, papilloma with disease or papillary disease can go for surgery, while encapsulated intraductal papillary carcinoma or invasive carcinoma has to go a more vigorous surgery like taking out the sentinel lymph nodes or the whole axillary lymph nodes. And prognosis accordingly is poorer if you go towards carcinoma. That is about papillary. And next is about the spindle cell lesions. How do we approach if we have spindle cells in the biopsy specimen? I have 4 cases here from Nepal cancer. This first case was 44-year female with right breast lesion, which shows stromal differentiation and a proliferation of the ducts. The second one is 40 years female with left breast mass but with more leaf-like structure. Third one is 27-year female with left breast mass with atypia, cellular atypia. And the fourth case was 24 years female, right breast mass with spindle cells, atypia, and many mitosis. So the first one is fibroadenoma, second, benign phyllodes, third, borderline, and fourth, malignant phylloides. So these are some of the IHC markers that can help us differentiate these kind of lesions. The Ki67 is usually very less or almost absent in fibroadenoma, while it's increasing in benign, borderline, and malignant phylloides. P53 is negative in fibroadenoma, weak positive in benign phylloides, focal variable in borderline, and very strong positive in malignant phylloides. 34 is positive in benign conditions. EGFR is very diffusely positive in malignant phylloides. ERPR is positive in epithelium and negative in stroma in all these cases. So ERPR is a kind of prognostic marker rather than diagnostic marker in these cases. So if age is more than 50 years, stromal overgrowth is very much, diffuse mark atypia is present along with necrosis and lots of mitosis. Of course, it goes towards malignancy. Hence, the recurrence rate and distant metastasis is very frequent. Therefore, we need to clarify which of these tumor is the exact diagnostic lesion of the breast. This is the last part of my presentation, and here I'm going to talk about the rare tumors of breast lesions. Well, I haven't included the very common tumors like intraductal carcinoma, invasive carcinoma, or lobular carcinoma because we come across them very frequently and we can see them very frequently. But since my topic is about very rare diseases and difficult diseases, so I haven't included that in my presentation today. But what about the rare tumors? We don't see it much and it's more difficult. See, that's why it's more difficult. And studies have been very less in these areas. So we need to identify these tumors too so that we don't miss it. This was 40 years female with right breast lesion, a female who came to Nepal Cancer Hospital again. And under the microscope, we could see that these proliferating atypical tumor cells in a myxoid background and some focus with lobular pattern. On high power view, we could see that these cells were very, very atypical, very pleomorphic, and some had this eosinophilic cytoplasm with many, many mitoses. And yet, in another area, we could find this keratin production, eosinophilic keratin production by these tumor cells. ISC was done, and we could see that P63 was positive with GATA3, and ERPR HER2 was negative. Hence, the diagnosis was established as metaplastic carcinoma with squamous cell carcinoma differentiation. Another rare tumor, 75 years female, left breast mass was presented to the Nepal Cancer Hospital, and we could see the many, many mucines at the background, floating tumor cells in between them. And these tumor cells were atypical and had lots of mitosis. So this usually occurs in older women. As you can see, our case was also an old female. And mucinous component, more than 90% of the tumor has a favorable prognosis. So it's better to diagnose mucinous carcinoma. This is one of the case, I think this is my second last case here. This is one of the case which was published by our friend Dr. Mausami and her friends in clinical case reports. This was a case of 18 years female, rapidly increasing left breast mass. And under the microscope, again, we could see lots of squamous cell, atypical squamous cell with areas of necrosis and inflammation. While doing IHC, these tumor cells were positive for P40. Hence, it was diagnosed as primary squamous cell carcinoma. So before diagnosing it as primary squamous cell carcinoma, everything was worked out. All the CT scans and PET scans were done. And it was confirmed that there were no other lesions of squamous cell elsewhere in the body. So these tumors are very aggressive. They frequently relapse, and they have the high mortality rate. So it's very, very important to diagnose and identify these kind of lesions. I think this is my last case. This is again from Nepal Cancer Hospital. This was a case with invasive ductal carcinoma of breast with neuroendocrine differentiation. Painless right breast mass in a 52-year female. And you can see the microscopic picture here. The neuroendocrine features were also found along with the invasive carcinoma elsewhere in the specimen, along with mitosis and necrosis and inflammation. And while looking at the IHC, these tumor cells were positive for CK, focally positive for INSM1, CD56, and the GATA3 was negative, Ki67 was pretty high. So this was invasive carcinoma with neuroendocrine differentiation. These kind of tumors have very poor prognosis than invasive carcinoma alone. So when we deal with invasive carcinoma in our regular life, in reality, we have to regross and see more sections, more representative sections, especially in the large biopsies, so that not to miss these kind of neuroendocrine focus. And these rare tumors, there are very little studies, as I already told you, there are very little studies done in these areas. We need to know more about these cases so that we can identify and read about them more. So this is one of the field of research for every one of us. Hence, to wrap up and to conclude my presentation, possible solutions. So what to do? What are the solutions and tips for diagnosing these kind of challenging breast lesions? We have to carefully evaluate overlapping histological features. Morphology is the base after all. Judicious use of ISC markers as diagnostic tool. Recognize rare subtypes. And if we have very limited material in biopsies, of course, we can go and ask our clinicians or the interventionists to give more and more tissues, as tissues have always issues for pathologists. But what we can do from our side is that we can make as many separate blocks as possible for different ancillary tests. For example, we received in one bottle like 3 or 4 Trucot biopsy specimen, then we can make like 4 different cassettes, 4 different blocks, so that we can use one for HE, another for IHC, and another for molecular, and so on for other ancillary tests, so that we don't lose the tissues once and for all. We can also avoid deep cuts unless needed to save the tissue for ancillary test. If diagnosis is very frank in the first cut of the slide, then we may not ask for more deep cuts. We may preserve these specimens for future for other ancillary tests. We can also make cell blocks out of FNAC materials to add up as one extra block. We sometimes get Trucot biopsies and FNA material for cell block too. So if I have like 4 blocks of Trucot biopsies, I will have one more cell block. That means I have 5 altogether blocks that I can use for my ancillary test. Stay updated with changing diagnostic criteria. Of course, we have to be updated how old you are. Combining histomorphological, immunohistochemical features and clinical radiological correlation can ultimately increase the confidence of diagnosis. So this is a teamwork. It is not just a work of pathologists, interventionists, or clinicians. It has to be a teamwork. We need to have a very good specimen. We need to go through all the HE slides and IHC slides and do a judicious use of IHC and moleculars and come to one particular diagnosis. Please get up. It's end of the presentation. Thank you.
Thank you very much, Dr. Vanita, for a very excellent presentation, highlighting the way forward to manage challenging cases in our daily routine. Thanks. Thank you very much. We'll have the
Thank you,
questions
sir.
at the end of the session, please.
Thank you.
Now our next presenter is Professor Dr. Anju Pradhan. Anju Pradhan, please. Dr. Anju Pradhan is a professor in Department of Pathology at BPKIHS, Dharan. And today she'll be presenting on the topic, A Walk Through the Endometrial Histology in Abnormal Uterine Bleeding. Please join me in welcoming Professor Dr. Anju Pradhan. The stage is yours.
Thank you. Thank you.
Respected chairpersons, my seniors, colleagues, and the future pathologists, a warm good morning. Today, we are going to take a brief walk through the endometrial histology in abnormal uterine bleeding. Before I read out the objectives, I would like to put out a disclaimer that I have not been formally trained extensively beyond my PG in the endometrial biopsy, but while the world, the scientists have come together, the camaraderie shown to overcome the oncology, my attention was grabbed in the daily biopsies that we receive from the women who suffer from abnormal uterine bleeding. 9 years ago, while I was being trained for GI and liver pathology in Geneva University, I came across few books that was about endometrial biopsy, and then my curiosity began. So let's walk together with me through this path. And my objectives today is to distinguish histologic patterns seen in endometrial biopsies in cases of abnormal uterine bleeding, specifically due to ovulatory dysfunction and due to iatrogenic cause, which is the exogenous hormone. To relate these patterns to the Palm-Cohen classification system of AUB given by FIGO. And these are my presentation overview. FIGO has defined abnormal uterine bleeding as bleeding from the uterine corpus that is abnormal in all the terms takes away from the regular menstrual bleeding, that is in regularity, frequency, duration, and volume, and occurs in the absence of pregnancy, so in non-gravid women. And it has been classified into two broader categories, that is the structural and the non-structural. Under the structural, we have PALM, polyp adenomyosis, leiomyoma, malignancy, or hyperplasia. And under the non-structural, we have coagulopathy, ovulatory dysfunction, endometrial cause, iatrogenic, and not yet classified. It is not to the scope of the presentation today to cover them all. Therefore, I'll be covering the ovulatory dysfunction and the iatrogenic causes. And this is how they are given mnemonics, where you see on the right side column. There are a few more definitions to go through before we start. That is the acute abnormal uterine bleeding, and it is the bleeding that occurs in non-gravid reproductive aged women with bleeding of sufficient quantity to require immediate intervention to prevent further blood loss. And chronic is just the opposite, bleeding that is abnormal in duration, volume, frequency, and has been present over the past 6 months. And there is, whenever we see cases of endometrial biopsy, we have to keep in mind whether it is a menstrual bleeding or the non-menstrual bleeding, which we called in the past, and it is now called as intermenstrual bleeding, which is bleeding between clearly defined cyclic and predictable menses. We all have heard this term and reported many times, dysfunctional uterine bleeding, and clinicians have used the terms menorrhagia in the past, and now these are the discarded terms by the FIGO. And the terms that replace them are the abnormal uterine bleeding and heavy menstrual bleeding, or HMB, for menorrhagia. The gynecologists concerned, when they send us the endometrial biopsy, what do you think they can be? Anything comes to your mind? Oh, give us the report fast. Well, is there any organic or structural lesion like hyperplasia, polyp, carcinoma, pregnancy, inflammation, and so on? Are there evidence of active or old bleeding? Is there evidence to suggest abnormalities in ovulation? And that is the majority cases that we get. Is there evidence of hyperplasia or carcinoma? Now, as a pathologist, what kind of information do we seek from the clinicians? What do we ask them? Because we know that most of the time the requisition forms are as blank as a white slate, right? So what information do we seek? What comes to our mind? Thank you, Dr. Vanita. Yeah, definitely the last menstrual period, the menstrual date, types of bleeding, like I mentioned, menstrual or intermenstrual bleed. If the patient has taken any hormone, how many of you ask the patients or the patient party, have you been taking pill? Please do not utter this word pill in future. This is my humble request. Any type of hormones taken and any imagings of the uterus. There are 9 histologic features of the glands and stroma that defines the phases of the endometrium, and we know that right and left, prolly and secretory, but also tiny duration of interval and the menstrual phases in between, right? So we especially look into these 2 areas, glands and stroma. And what do we see there? We see the shape and size of the glands. We see whether the activity is there or not. the glandular mitosis orientation of the nuclei, whether they are low columnar, single, pseudostratified, or really stratified, like in carcinomas and hyperplasias, and the vacuolization, various kind of vacuolization. And we have to be very, very particular in identifying the localization of the vacuolization within a gland and even the entire glands present in that particular biopsy. And also the glandular serrations with the luminal secretion. And in stroma, we look at the edema, the compactness, the mitosis, pre-decidual changes, or the surface decidual changes, and infiltration by granular lymphocytes. And now we come to our term, the topic, abnormal uterine bleeding. There is a hypothetical question to you all. A 42-year-old female with complaints of irregular non-menstrual or intermenstrual bleeding, and this is what you see under the microscope. So what would be your diagnosis? How many of you say proliferative? All right, trying to keep up with the time. What we see here is lake of hemorrhage, and there is glandular and stromal breakdown. Do we have a pointer? Oops. All right. So on the superficial part, we see condensation, compactness of the stroma, and then we see that the glands have also compacted. All right. Visible? All right. So these are the compacted glands I'll be showing in the next slide. So here we go. The first thing that we see when there is a glandular and stromal breakdown are the apoptotic debris. Glandular or stromal, we see these apoptotic debris. And the next thing that we are going to see are the stromal blue balls. These are the compacted and detached stromal balls. Then these balls are capped by the surface epithelium, or more commonly by the eosinophilic epithelial cells forming a syncytium. You can see lake of hemorrhage in the background. And there's these eosinophilic cells. These are the eosinophilic syncytial change of the surface epithelium. Previously, they used to be called as papillary syncytial metaplasia, papillary syncytial changes, or the surface syncytial change. And the term papillary and metaplasia has been discarded. And nowadays they are called as eosinophilic syncytial change. This is a result of focal irregular breakdown, a degenerative or regressive alteration, and not a true metaplastic transformation. Hence the term eosinophilic syncytial chains. And they at times form papillary configuration, and they are not because they are papillae, but they pile up into a small papillae-like folds which are infiltrated by neutrophils, and their bland morphology, and especially the indistinct cell borders forming syncytium, and hence the term syncytial. And on these superficial blood vessels have fibrin thrombi. The other features of glandular and stromal breakdown are features of chronic bleeding. They are the hemosiderin deposits, the foam cells, and stromal hyalinization and fibrosis. I would like to point out to all the residents here, foam cells are not the macrophages, but these are the stromal cells which become foam-like appearance. And when you see in pap smear, cluster of endometrial cells, and you see them engulfing the neutrophils. And it is, again, not the macrophages, but the stromal cells that engulf the neutrophils. Sometimes you also see hormonal changes. To summarize the glandular and stromal breakdowns, we already said that the apoptotic debris are seen both in glands and in the stroma. In the glands, there is this papillary this is the older PowerPoint that I sent. So I'll replace this by the eosinophilic syncytial change and not the papillary syncytial metaplasia, glandular crowding, and the stromal collapse into stromal blue balls, the apoptotic debris, fibrin thrombi, and so on. Now, there is one important thing to understand the glandular and stromal breakdown, which we also see in the menstrual endometrium. And the common findings to them are the stromal collapse and the nuclear debris at the base of the glands. And sometimes we get to see the stromal blue balls and the fibrin thrombi in menstrual endometrium. But rest of the features that we just enumerated are present only in the abnormal bleeding and are absent in menstrual bleeding. Now, walking through ovulatory dysfunction, AUBO. This is frequent in perimenopausal and perimenarcheal women. We usually don't give attention to the perimenarcheal females. And to a lesser extent to women of reproductive age, and it is a manifestation as a combination of unpredictable timing of bleeding and variable amount of flow, and hence AUB. The causes can be numerous, ranging from endometrial causes, endocrinopathies, to extreme exercise. And it occurs either due to a lack of ovulation following follicular development, that is the anovulatory cycles, or due to luteal phase abnormalities. It is a reflection in ovarian hormone production, variation in ovarian hormone production. That means imbalance in the endogenous hormone production. So AUB, there are two types of bleed because of AUB-O, estrogen on one side and progesterone bleed on the other side. The estrogen bleed are the proliferative endometrium with glandular and stromal breakdown, disordered proliferative endometrium, and I'm sure you all are happy to hear these words, atrophy. And in the progesterone bleed, we have irregular secretory endometrium, irregular shedding, and abnormal secretory endometrium with breakdown of unknown etiology. So let's start with the estrogen bleeding. Again, another hypothetical case here, 48-year-old non-gravid female with AUB, intermenstrual bleed, negative hormonal history, no structural lesions, and this is what we see under the microscope. Proliferative glands and features of breakdown. What is your observation? Proliferative endometrium? No. It is proliferative endometrium with glandular and stromal breakdown. So this, again, is an ovulatory cause. It is one of the most common endometrial biopsies we receive in perimenopausal women. And another important thing I would like to tell that in non-structural lesion, postmenopausal bleed is not included. The other in the perimenarcheal adolescents and also some in the reproductive women. And there is increased risk of hyperplasia or carcinoma in these kind of etiology. So an ovulatory cycle occurs when a cohort of ovarian follicles develop, but the ovulation does not take place, does not lead into the luteal phase. So the corpus luteum does not develop, progesterone is not produced, and the follicles produce estradiol, which will give out signals for the endometrial growth. And there are a lot of proliferative glands happening. And the growth is stopped by bleeding, which happens either due to estrogen withdrawal bleeding or the estrogen breakthrough bleeding. Whatever the cause, there in the microscopy, what we see are the actively proliferating glands, augmented glandular toxicity, and features of glandular and stromal breakdown. And some of the estrogen-related epithelial changes like ciliated cells and eosinophilic cell change. Differential diagnosis, exogenous hormone, that is the estrogen, inflammation and polyps. You should take a complete history for the exogenous hormone, all the features of chronic endometritis to rule out, and features of polyp. When proliferative endometrium shows features of glandular stromal breakdown, it is not proliferative endometrium. Combined with the clinical history of AUB, it suggests an anovulatory cycle and hence PE with the breakdown. Another case here, hypothetical, a 56-year-old non-gravid female presented with AUB, irregular and prolonged bleeding, and all the negative hormonal history and non-structural reason. What you see are proliferative glands with focal abnormal glands reflected by dilation and branching. What do you think? This is the diagnosis that we all jump into, right? This is the disordered proliferative endometrium or persistent proliferative phase. Now, chronic ovulatory cycles will lead to abundant proliferative tissue, and it will lead to mild degree of disorganization, focal crowding, glandular dilation, branching, and there is a proliferative phase that is neither normal nor hyperplastic. And this disorganized pattern is what we call disordered proliferative endometrium. And disordered proliferative endometrium should be reported in a tissue which is intact and has well-oriented fragments. Differential is simple hyperplasia, where you get extensive tissue and a diffuse abnormality which is not seen in DPE. And extensively fragmented tissue are disrupted by the procedure and contains many detached proliferative endometrium. We should stick to proliferative activity and not disordered proliferative endometrium. Another hypothetical case, a 38-year-old female with AUB, negative hormone history, no structural lesion. What we get are those scant tissue with strips of endometrial surface epithelium, detached glands, scant stroma, and features of breakdown. What do we do? Order for step cuts. And even after that, we don't get further tissue. We say, not sufficient tissue, repeat biopsy. Absolutely not, because we have to consider atrophy in a reproductive aged woman with premature ovarian failure. It is either idiopathic or due to radiation or chemotherapy for malignancies. And this is what we get. Strips of surface epithelium, detached glands, and areas of hemorrhage with features of breakdown. Now, coming into progesterone bleed, I'm speeding, keeping in mind the time we have. Progesterone-related bleeding, which is called luteal phase abnormalities. It is a sporadic disorder of the reproductive and perimenopausal woman. Right. Sorry, let me go back. The corpus luteum is insufficient. The luteal phase happens, but the corpus luteum is insufficient in luteal phase abnormalities, either regresses prematurely or failing to produce an adequate amount of progesterone to sustain the normal secretory pattern. And it gives to ovulation, so secretory changes develop, but not enough to fit into any of the physiological progression in the luteal phase. The endometrial pattern does not correlate with any date of the normal luteal phase. At one end, glands will show secretory changes, yet lack marked toxicity and secretory exhaustion and lack predecidualization in the stroma, while on the other hand, there is hypersecretory pattern and lack of predecidual chains. And we can get foci of breakdown. And please do not consider them as secretory endometrium. The etiology and frequency of abnormal bleeding associated with luteal phase abnormalities are not well understood. These disorders are sporadic and do not persist long enough to permit clinical pathological correlation, and hence less studied and ignored. And these are the cases we often get. So the first one is irregular secretory endometrium, and the irregular secretory pattern we get, one is a DPE-like pattern but with secretory changes, and the other one is random secretory glands with vacuoles, subnuclear, supranuclear, secretory exhaustion, and anything. The next one in this progesterone bleed is the irregular setting endometrium. This is, again, persistent corpus luteum, and, sorry, the old slide. And again here, the most common finding we get is a mixed pattern composed of secretory and proliferative endometrium in one tissue. And this is what it looks like: secretory gland surrounded by edematous and proliferative gland surrounded by compact stroma. The last one in this category is abnormal secretory endometrium with breakdown of unknown etiology. And here again, we get abnormal secretory activities. The tortuous glands, stroma is dense and completely lacks edema or pre-decidua, and the endometrium cannot fit into any of the luteal phase endometrium. And we see features of glandular stromal breakdown. Now, quickly moving towards the abnormal uterine bleeding eye, that is the iatrogenic, which includes the exogenous hormone. There are various reasons why hormone therapy is given to a patient. And the first thing that we see here is birth control. And I've been requesting, persuading, and shouting at my residents not to ask the patient, are you taking pill? Please avoid this term forever. Delete this term from your mind forever. My humble request. Please take proper history of exogenous hormone types. And very quickly, I can see you standing. I'm very quickly moving forward. And these are the hormones that are given to patients. And we also have a hormone given for certain breast carcinomas and so on. The hormone, the doses, and the duration of the therapy influence the appearance of the endometrium. Clinical information regarding these hormone uses will help us reaching to correct diagnosis. Estrogenic hormones are used in perimenopausal or postmenopausal women to treat symptoms of menopause. And the patterns we see under the microscope are exactly the pattern that we see in proliferative endometrium with features of breakdown. The only difference that we need to make here is ask the patient whether the patient has been taking estrogenic hormone. If yes, we'll diagnose as estrogenic pattern, changes due to estrogenic hormone, and not PE with breakdown. Progestins are helpful in managing ovulatory disorders, where irregular non-cyclical endometrial growth results in abnormal bleeding. And these are the three patterns we see. Decidua is the term used only and only for gravid endometrium, pregnancy endometrium. But there's another place where we use this word decidua, and this is when we see under the microscope decidual pattern given by progestin. And the second is secretory effect, and the other one is inactive or atrophy. And in decidua, we see massive decidual chains, decidual endometrium. Usually polypoid, but we don't get polypoid history in the imaging or during the surgery. Glands are predominantly inactive, and very few of them might show marked secretory changes. Otherwise, the stroma shows massive decidual change, and there are vascular ectasia. And the second pattern is secretory pattern, where you will see abnormal secretory glands. And there is vascular ectasia. And when you see the history, when you get the history of progestin intake, then please refrain yourself from reporting the luteal phase abnormalities. And the last one is the inactive or the atrophic effect by the progestin. Again, sparse tissue, glands are small, inactive, and they are not coiled, variable amount of stroma, and so on. Now, to summarize my presentation, FIGO classification has tried to avoid all the terms that did not give out accurate guidance for the management and the treatment, therefore has classified AUB as PALM coin. PALM is the structural, coin is the non-structural, and histologic evaluation in AUB requires thorough clinical context of all the histories that we want to take, like bleeding pattern. Please take hormonal history. Please avoid the term pill. Delete this from your mind, I'm repeating again. So common patterns include glandular stromal breakdown in cases of AUB, and these are the two things that we discussed, O and I. And these are the Conductor, have you ever been to an orchestra? The conductor gives direction, and all the musicians, what do? They play as direction given by the conductor. And these are the conductors, the endogenous and the exogenous hormones, and they give direction to the glands and stroma to go their ways. So takeaway message, endometrial biopsy remains a critical tool in evaluating abnormal uterine bleeding. While the world is coming together to defeat the oncology part, please do not ignore the women who come with abnormal bleeding. And these are, the ratio of these women are greater than those who come with the malignancy. Understanding the histologic patterns in conjunction with the clinical context will help us reach an accurate diagnosis. The PALM-Cohen classification helps standardize the approach and guide management of this patient, and a meticulous correlation of morphology with hormonal and clinical history is essential for a meaningful interpretation of pathology. Therefore, endometrial biopsy from a patient with AUB, do not put these words in your histopathology report. No pathologic diagnosis, no significant pathological findings, or descriptive. Unacceptable. And in my experience, proliferative phase endometrium and secretory phase endometrium in our histopathology report of women presenting with abnormal uterine bleeding is unacceptable. Let's cover the area that is in between the left and right as proliferative and secretory endometrium. These are my references, and the slide that I've kept about empathy is not here. This is my old presentation. Let's be empathetic to the woman presenting with bleeding, and let's focus on the changes that we just heard. Thank you everyone for your attention.
Thank you, Professor Pradhan, for your nice presentation.
Okay, as the last presenter of the first session, I would like to welcome Dr. Karishma Malla, a distinguished consultant pathologist and associate professor, currently serving as head of Department of Pathology at Paropakar Maternity and Women's Hospital. Dr. Malla has received advanced training in transfusion medicine, gynecological cytology, and laboratory quality standards. With over 2 decades of clinical and academic experience, she is a frequent speaker at national and international conferences. Let's welcome Dr. Karishma Malla. You have the floor, Dr. Karishma Malla.
Okay. So, good morning and namaste to the respected chairperson and all pathologists and students present over here. First of all, I would like to thank organizing committee for organizing this gynecology and breast pathology national conference. And I would like to thank Dr. Siva and Dr. Abhiman Jha for coordination. So I'll be talking on the prevalence of cervical cancer and role of P16 immunohistochemistry in a tertiary care center, that is the Paropakar Maternity and Women Hospital. Starting with cervical cancer is a significant global health issue affecting women worldwide, one of the leading cause of morbidity and mortality among the women. Over 500,000 new cases are estimated globally each year. Globally, incidence of cervical cancer is fourth most common cause of cancer among the women, and it's also the fourth most common cause of cancer-related death among the women globally. But in Nepal, incidence and mortality of cervical cancer is little higher than that of the globally. Annual incidence of the female with the cervical cancer in Nepal is 2,168, with 13 number estimated death each year. That means in each day, there are 4 women are dying with the cervical cancer. So incident of cervical cancer in our context is it's the second most common cancer in female, but it's the first most common cause of cancer-related death among the women in our country. This study analyzed the incidence and prevalence of cervical cancer at Purpakar Maternity and Women Hospital over 2 years period. Immunohistochemistry ISC is crucial for diagnostic and classification of cervical cancer. P16 ISC is commonly used in cervical cancer cases. Cervical cancer is most common malignancy of female reproductive system, primarily associated with the persistent infection by high-risk human papilloma virus. The disease progresses through well-differentiated sequence from the precancerous lesion to the invasive carcinoma. And these are the multiple risk factors that causing the cervical cancer. And human papilloma virus is one of the most common cause of leading to the cervical cancer, and it's a double strain DNA virus infected cell, particularly of transformation zone of the cervix, leading to cellular dysplasia and then to the carcinoma. HPV 16 and 18 are high-risk HPV, which is responsible for more than 70% of cervical cancer in the female. This HPV virus enters through the microaberration in the cervical epithelium, and virus infect basal keratinocyte of the cervical transformation zone, and it remain in the epithelium and initially cause transit infection. Normally, most of the HPV infections are cleared by the immune system within the 1 to 2 years. In some cases, persistent infection with high-risk HPV lead to integration of HPV DNA into host genome, disturbing normal cell cycle. This is a picture showing the virus oncogene E6 and E7, which is responsible for the degradation of the P53 and the RB gene, which causes a genomic instability, leading to uncontrolled cellular proliferation of the cell. There are several tests and investigation done for the precancerous cervical lesion and also the cancerous lesion. That includes pap smear, which include conventional pap smear as well as liquid-based cytology. Another one is molecular level, that is the HPV DNA testing. Other is a colposcopy and biopsy is a gold standard test for the precancerous and cancerous lesion. Immunohistochemistry P16 and Ki67 help to subtype the tumor as well as see the prognosis and the aggressiveness of the tumor. This is a WHO classification we use to interpret cervical lesion. Immunohistochemistry P16 is a tumor suppressor protein that regulates G1 to S transition of the cell cycle. In HPV-associated cervical carcinoma, the E7 oncogene of high-risk HPV degrade the RB gene, leading to loss of negative feedback and upregulation of P16 expression as a compensatory response, result in diffuse progression of P16, which is hallmark of the HPV-driven neoplasm. These are the various patterns how P16 is seen in the slide. If the staining pattern is diffuse, strong, nuclear, or cytoplasm positive, then it's a block positive, usually interpreted as a high-risk HPV-associated lesion seen in SCIL as well as squamous cell carcinoma. Or there is focal or a patchy stain which is non-specific, or the low-grade lesion may be seen sometime in the LCIL. A negative stain which is interpreted as a negative HPV independent lesion with a normal lesion as well. These are the various pictures of P16 staining in the slides. Negative staining doesn't stain for the nucleus and cytoplasm. There's a focal staining of P16 is also seen, and also the patchy to block stain of P16 are seen, and strong diffuse positive with the covering the all lining epithelium are also seen. P16 pattern, so different pattern of staining in different cervical tumor. That is, if the squamous cell carcinoma and the adenocarcinoma associated with HPV infection show a strong diffuse P16 positive, whereas the adenosquamous and neuroendocrine tumor, HPV associated, it shows a diffuse positive. But in gastric type of adenocarcinoma, which is HPV independent, and clear cell carcinoma, and serous and other mesonephric carcinoma, which show the negative P16 pattern. And if P16 is block positive, that will give a well response to the radiotherapy and immunotherapy. And if P16 is negative, that is HPV independent tumor, it's more aggressive and require different treatment strategy. Ki67 is a nuclear proliferation marker that is expressed in actively dividing cell and absent in G0 cell, widely used in cervical carcinoma to assist the tumor proliferation and aggressiveness. This is the picture of Ki67. In case of normal or the some reactive changes, usually Ki67 will stain for the basal layer, but in case of precancerous lesion, this Ki67 will stain for the whole thickness, and it's the nuclear stain. Ki67 expression in cervical lesion in normal cervix basal layer may show the Ki67, and at CIN1, lower 1/3 of the epithelium show the Ki67 expression, where CIN2, it show the lower 2/3 of epithelium with expression of Ki67, and in CIN3, it show the full thickness staining with Ki67. Ki67 differentiate benign reactive changes from dysplastic or the neoplastic lesion, help classify CN grade based on the proliferative pattern, and co-testing with the P16 with high Ki67 index will very useful to diagnose SCIL as well as in carcinoma. But P16 positive with low Ki16 may suggest a transient HPV infection. High Ki67 index means more than 50%, which is associated with the poor prognosis, high tumor aggressiveness, and recurrent risks. Whereas low Ki67 index, which is less than 20%, may indicate slow growing, less aggressiveness tumor. These are the FIGO classification used for cervical carcinoma, but we use TNM staging for the cervical, for the interpretation of cervical cancer in our setting. There are different modalities for the treatment of cervical cancer depending upon the stages of the tumor. 5-year survival rate in stage 1 is 90%, and stage 2, 60 to 80%, stage 3, 30 to 50%, and stage 4, less than 20%. Our study is a retrospective study done at Purpakar Maternity and Women Hospital, and study period is 1.5 years to 2 years, and data collected from the histopathological record, and data extracted are patient age, tumor types, and ISC marker, and incident of cervical cancer carcinoma, and its histopathology subtype was analysis, and it's a descriptive type of study. And we get around 112 cases of cervical cancer were documented. Most common subtype was squamous cell carcinoma with HPV associated, and other carcinoma of cervix also detected. Most common specimen we received was a cervical biopsy, and most common age group was 40 to 50 years, and P16 positive was key marker for HPV-associated squamous cell carcinoma. Most adenocarcinoma also stain for P16 positive. This is a graphical representation showing the age distribution of cervical cancer, and most common type of specimen that we receive in our institution was the cervical biopsy. And most common type of tumor we had is squamous cell carcinoma with HPV associated, and other tumors are also noted. And most of the carcinoma case is P16 positive, and we do have few negative cases as well. Most P16 staining show the diffuse and strong block positive. We do have patchy and the negative P16 staining. This is the picture showing H&E stain, showing the cervical carcinoma. And this is the P staining, which shows diffuse and block positive. And prevalence of finding of our study was high prevalence of squamous cell carcinoma among the cervical cancer cases. Majority of tumor are HPV associated, confirmed by P16 ISC positive. Most affected age group was 40 to 50 years, indicate midlife disease burden. Most common specimen we received was the biopsy, and P16 immunohistochemistry showed strong block positive in a high-grade lesion. We do have limitation of our study. It's a retrospective study, single center study, and short duration study, and incomplete follow-up of the patient was noted, and limited access to the accessory testing. And we do faces challenges like lack of awareness to the patient with different type of testing, and affordability, infrastructure constraint, and shortage of trained manpower, and lack of national IC guideline for the reporting. So I would like to share some of the thing that national is giving to decrease the burden of cervical cancer in our country. So Nepal has set to target to achieve at least 90% coverage in 3 prevention service by 2030. That includes primary immunization of the girl with HPV vaccination. Secondary prevention means it's screening to the 90% of the women with the age of 30 to 49 years with PIA and HPV DNA testing, and tertiary prevention to the all women who are positive, 90% women who are positive with the cervical lesion. And these are the various type of vaccine which are available in the market, but Nepal government is giving a bivalent with the single dose, because it's the efficacy, lots of study has shown the efficacy is similar to the multiple doses. So with our experiences and knowledge, we do recommend it something to the institution as well as the nation, that we are using bivalent. We can also start with the new nonavalent that's covered more high risk SBB. And we are implementing, we are forcing to give even a pap smear, and HPV DNA should be included in the screening protocol, and expanded diagnostic facility that upgrading of regional lab with ISC, so that and providing minimal charges to the ISC testing as well. So key take home from this study is cervical cancer remains the most prevalent gynecological malignancy in our country, and most of tumor are HPV associated squamous cell carcinoma, and P16 is surrogate marker for high risk HPV cervical carcinoma. KI67 provide proliferative index, helping to grading dysplasia as well as guiding therapy. And IC is essential to distinguish between HPV associated and independent tumor. And we highly recommend that IC should be performed in all cases of cervical carcinoma for proper subtype and the treatment plan. These are my references. Thank you for your attention. I would like to thank Dr. Saurav for helping me for this presentation. Thank you.
Thank you very much, Dr. Karisma Mallavaidya, for a very nice presentation on the role of P16 immunohistochemistry and its prevalence in our cervical cancer cases. Thanks a lot. Now, I would like to open the floor for questions to the four esteemed speakers, Dr. Seema Pradhan, Dr. Banita Gurung, Professor Dr. Anju Pradhan, and Dr. Karishma Mallabaidya. Please raise your hands for the questions and the mic will come to you. Yeah, it is very surprising to see no questions in the beginning of the session. In the afternoon, it could have been a bit understandable, but not now. Okay, so as we went through the presentation today, we saw, yeah, oh, there's a question. Yeah, how nice.
I would have appreciated, good morning. I would have appreciated if our young colleagues came up with some questions. Since there are no and the chairperson is little unhappy, I thought I'll take forward one comment and a question subsequently. This is to Dr. Anju, Professor Anju. Where is she? Anju? Okay. First of all, let me really congratulate you on your wonderful apprehension of such a vast topic. I love that topic, and I think I'll love you throughout the rest of my life because you took up such a topic which is, I think, neglected to some extent these days, and which I keep telling all my colleagues, especially since the blue books have dominated the scene. So I agree with whatever you said wholly, but there's just one thing that I wanted to ask you. I think you mentioned very categorically that disordered proliferative endometrium. Oh, I wish every slide was a disordered proliferator. I'm so relieved when it's there. And you said that you should not make that diagnosis till you don't have proper, the glands are totally intact and the stroma is really well seen. I'm a little doubtful there because these specimens, after all the hormones that are pushed in by the gynecologist and a biopsy done in the end, we really deal with very fragmented and bloody specimens sometimes, where I do report it as possibility of a disordered proliferative endometrium based on some granular reduplication and budding, all that. So I do report it, and then I give a comment. So what is your take on it?
Thank you, ma'am, for your question and the appreciation. I feel great and elated after that. As for our experience as well, we do that, but I don't know from where I started feeling passionate about endometrial biopsies, and every articles and standard textbooks say that DPE should be reported if there is a well-oriented tissue. That means the surface epithelium. Always, I did not put this in my presentation due to constraint of time. Endometrial biopsies should always have surface epithelium, and we should see a significant amount of both the layers of the endometrium, the superficial and the functional layer. And DPE, because is a constellation of both normal proliferative glands as well as these few abnormal glands. Therefore, we should be able to see both of these. It lies in between normal proliferative endometrium at one hand and the hyperplasia at the other hand. Therefore, we have to make sure that no abnormalities are seen in other fragments of tissues. Therefore, because
I fully agree with you, but maybe this is the situation where you haven't given hormones.
Yes.
Maybe we have to educate our gynecologists on it.
Yes.
But our situation is very different. I don't know what your experience is, but as a last resort, a biopsy is done after they've pushed in everything, and then the patient has not responded. So I do report on these biopsies, actually. And another thing that I really like about your presentation is that you have mentioned in your reports when it's a very distressing patient and you report not to report it as a proliferative endometrium or secretory that absolutely gives no information and clue
Exactly.
and the way forward with the patient. So we should not, we should refrain from using those terms in abnormal uterine bleeding. A proliferative endometrium secretary, it's very frustrating.
Very, very frustrating.
Yeah.
My residents know that. So even in hysterectomy specimen, we get to see a lot of changes that we just discussed. And residents usually come with either proliferative or secretary, and if they don't get anywhere, then they come with TPE, which is really not good. And also, they miss out on the endometritis, which is not a very common cause of AUB, but a very common cause of infertility. And endometritis is usually missed by the residents. So, beyond the
Because they
scope of today's
concentrate so
presentation-
much on the blue books and it's demanding
Yes.
changes.
Yes,
That's
ma'am.
true. Thank you so much.
Thank you, ma'am. Thank you for sharing your experience. And honestly, we do the same. Thank you, ma'am.
Thank you very much for the question and the exchange, nice exchange that went through. Yes, now, is there any more question? Yes, one more question, please. Yes, Dr. Anil.
Okay, so I'd like to ask Dr. Karishma. So the staining for the KI67, I've also used it, and it's quite helpful, especially when we're trying to figure out if it's when we're using the older system, CION 1, 2, or 3. So it was very useful, as you showed in the immunohistochemistry. I also went through some papers, and I find it useful. So I just wanted to ask you, do you do it on a regular basis, or are you limiting yourself to the difficult cases, the KI67, or do you do in all routine cases?
Actually, we recommend it to all the patients, but because of it's a financial burden, and if they agree upon that, then we apply for all the cases.
Can I comment? I'm so
Mm,
sorry
yeah.
to speak so
Yeah.
much. Dr. Karishma, it was an excellent paper, I agree, but I just want to talk about this KI67 proliferation index. The FIGO has not in 2023 endorsed it as compulsory while doing, but they have endorsed on P16. Why do you think this is so? And
Useful for for subtype of the histology type of the cervical cancer. So it's mandatory because the P16 positive also, so the treatment modality is more good for the immunohistochemistry and other things. Whereas if the P16 is negative, then it's more aggressive tumor. It has been shown like that. That's why I think the P16 is compared. KI67 is prognostic marker. So we just say that it's a prognostic marker, and most of the study has shown its result as well as, but some of it doesn't. So it doesn't give any value to the I mean to the patient. So I think for that reason, KI16 for HPV associated cervical tumor, that I think P16 are more giving emphasis by the things. Or
thank you. I think you are right there. And I have a little addition to that. That's because KI67, this is for the whole floor, I guess. KI67 actually has not been standardized in the cervix. That's one reason, like KI67 elsewhere in other tumors too, especially the breast, many. There's no standardization. The ESMO guidelines have a different cutoff. Then you have the CAP guidelines who have different cutoff. So even cervical lesions, I think the cutoff is not defined. So is there any cutoff that we would agree in Nepal? Have we standardized it? Because different studies say more than 50 cells percentage in the basal layers, some say 5% in the superficial layers. I think this is one reason that we haven't been, the FIGO guidelines have not endorsed it like the P16. So this is a point for all of us. Standardization is always a problem with KI67.
yeah, that's why I have mentioned in that challenge is that we don't have a national IC guideline for the thing. So we do faces that challenges, but I think in the future, we'll have our own guideline for that.
Yeah,
so
so
that
I'm not very sure when we report on KI 67 how correct we are or not. But P16, I agree. The block positives are very straightforward, the negatives are very straightforward, but the ambiguous morphology that we encounter every now and then, I don't know how we take that.
Thank you,
so
ma'am.
much.
Yes. Okay. Oh, there's one more question. Yes. Dr. Pragya. Okay.
Good morning, everyone. I'm Dr. Pragya from Nepalganj Medical College. My questions are very simple to Karishma ma'am and then Anju ma'am. To Karishma ma'am, you just mentioned that your commonest malignancy was squamous cell carcinoma associated with HPV. How frequently did you observe poilocytosis did you correlate with poilocytosis giving you HPV positivity in PCR or something like that?
Polycytic changes in histopathology.
In the cytology,
Cytology. Cytology, that's we do give like LCL and all those things for the colocytic changes. But how often that I think we really see, most of the time we see colocytic type of changes in the reactive cytology feature. We do see the colocytic change for LCL as well, but we don't see that much of colocytic changes for SCL and all those things.
like previously we were taught that coilocytosis and HPV DNA should be positive, but there are papers that they are not positive.
No.
So how frequently, we have done papers in our part, so
Yeah.
that's what I wanted to know.
We do see, but not frequently. Yeah, that's the story.
Very low, it was a
Yeah.
very low sample size, ma'am, just 30. We
Yeah.
had 3 positive, coilocyte, 3 positive with DNA positive. Discordance, yeah. They have papers. What percent, ma'am?
Thank you.
10%. Thank you, ma'am. Thank you.
That brings us.
My next question to Anju,
That-
ma'am. Anju Pradhan, ma'am. She's not there.
That brings us to the close of
Boss,
this
thank you.
first session because we are very short of time. Sincerely thank you to all our presenters for their insightful contribution and to our chairperson for skillful leading the session. Truly appreciate the time, effort, and expertise. There will be the poster evaluation between 10:40 to 12. So all the poster presenters are requested to stick by the poster forts. And I also request the judges to carry out their evaluation. I would now likely to invite our chairperson to present a token of appreciation mementos to our speakers. I would like to invite Professor Dr. Sivaraj Kesi to receive the memento on behalf of Dr. Deborah Dillon. Dr. Seema Pradhan, Dr. Vanita Gurung, Professor Dr. Anju Pradhan, Dr. Karishma Mallabaide. Please give them. Please give them a big round of applause.
Thank you all speakers for your excellent and informative presentation. I would now likely to invite our Professor Dr. Bidur Bosti to present a token of appreciation, a memento and certificate to our esteemed session chairperson, Dr. Rajesh Pant and Dr. Sailesh Pradhan. Thank you. Big. Thank you so much, sir. Now I will announce the names of our new lifetime ACPN member who will be receiving their certificates. I would like to invite ACPN Vice President Dr. Rakesh Pathak to present a certificate. ACPN को chairperson. Dr. Pooja Khadka. Dr. Pooja Khadka. Dr. Bipesh Acharya. Dr. Namo Buddha Sake, Dr. Subhana Acharya, Dr. Ekta Dital, Dr. Anita Simkhada, Ankita Simkhada, Dr. Rosin Thapa, Dr. Bekina Pradhan, Dr. Anita Bhandari, Dr. Rituraj Baral, Dr. Manjila Basnet, Dr. Vishnu Pokhrel. Thank you so much. Please join us for a tea break. We'll resume shortly with our next set of academic presentation. Please join us for a tea break. Yeah, yeah. Oh, so many things. I know, bro. Right. Dr. Manjila Basnet, Dr. Misu Pokhrel, Dr. Subarna Acharya, Dr. Ekta Dital, Dr. Bipesh Acharya, Dr. Namo Buddha Sake, Dr. Rosin Thapa, Dr. Bekina Pradhan. You serial wise.
Mic check. Dear delegates, we are now starting second session, so can you please come inside? Live life as if you were to die tomorrow and learn as if you were to live forever. Namaste and welcome back to all the honorable dignities, learned delegates, seniors, juniors, and my dear colleagues. It is truly a matter of privilege to stand before such a distinguished gathering today. We are delighted to have you all here for what promises to be series of insightful and thoughtful provoking presentations. Allow me to introduce myself. I am Dr. Pooja Khadka, and it is my honor and privilege to be hosting this session. Now, without further ado, we are entering the second session, which will be co-chaired by two of the Nepal's most esteemed pathologists, whose expertise and contribution has been instrumental in shaping the field. Introducing Professor Dr. Gita Sayami. She is a renowned pathologist serving as a chief consultant and head of pathology at Hams Hospital. She is a former treasurer of Nepalese Division of International Academy of Pathology and has published widely in renowned journals. Her areas of special interest is cytopathology. Please welcome her with huge round of applause. Joining her is Professor Dr. Mamata Lakhe, a senior consultant pathologist who is affiliated with Medicare National Hospital, Sukra House of Diagnostic and Wellness Center. She earned her MD from prestigious JIPMER, India, and has authored numerous scientific papers in respected journals. She is a passionate academician for more than 25 years, having worked as head of department in BPKHIS and KMCTH. Please welcome her with huge round of applause. We are grateful for your presence and would like to request to honor the chair. Over to you, ma'am.
Good morning. I would like to invite you all for the second session of the ACPCon today. And I think with the consent of my senior chair, we decide that the end of after every session, we'll have a very short question and answer session. What I noticed in the first session was because it was just the speakers and speaking, I think the crowd at the back got a little restless. I really believe in an interactive session. So we will have a short question answer session at the end of every speaker, I repeat. And without much ado, I would like to invite the first speaker of the session, Dr. Deepa Nebnani, who is a senior pathologist with over 22 years of experience. She has done a fellowship in uropathology from St. GS Medical College and KM Hospital, Mumbai. She is a clinical marketing lead for Siemens, Healthineers, and also NABL technical assessor. She will be talking about niche gynecological assays for infertility, pregnancy, and breast cancer. I invite you on the stage.
And the opportunity to speak today. Before I begin, I want to highlight the significant contribution of East-West Group operating in Nepal for the last 44 years. East-West Group is the authorized distributor of Siemens Healthineers solutions, providing end-to-end support for equipment, assays, consumables, after-sales support, and even building technical competence. So my topic for today is niche assays for gynecology for infertility, pregnancy, and breast cancer. So the journey to motherhood is one of the most precious and rewarding experiences for a woman and her family. The prenatal journey maps the pre-pregnancy phase and the pregnancy phase with the 3 trimesters. So in the pre-pregnancy stage, we offer AMH to assess the ovarian reserve. In the first trimester, free beta HCG and PAPE, along with the PRISCA software that incorporates algorithms to generate various risks, and the PRISCA software has been recently upgraded to include a number of new features as well. In the second trimester, we have preeclampsia biomarkers for mothers that present with increased blood pressure, and also we offer maternal screening tests in the second trimester, importantly for neural tube defects as well as for other trisomies. So most reputed labs need AMH in their immunoassay menu for two clinical utilities. One is assessing the ovarian reserve, and the second one is assessing the ovarian response to IVF. So AMH is produced by the primary, secondary, and antral follicles by the granulosa cells. Importantly, this AMH is produced independent of gonadotropins. So AMH levels do not fluctuate with the day of the menstrual cycle, which is a big advantage. The antral follicles are then potentially recruited by the action of FSH. So from a pool of primordial follicles, one mature follicle is released every month. And after the egg is released, the remaining follicle becomes the corpus luteum. So with the advancing age of a woman, the number of primordial follicles continue to reduce. So the primary, secondary, and other antral follicles also reduce, and so does AMH. So AMH gives an idea of the number of preantral follicles, and FSH plays another important role. FSH is telling how much effort is required to kick in the maturation of the follicles. So if a woman has low AMH with high FSH, it implies that the success of IVF may be not as good. Now, the antral follicular count is currently the gold standard method for directly estimating the ovarian reserve. The antral follicular count, it is manually done directly counting the number of antral follicles in both the ovaries. The total represents the fertility potential of the woman. However, although this AFC is considered the gold standard, it is imperfect because it has a number of cons. Firstly, the technical expertise of the sonologist is critical, and so is the quality of the sonology equipment. Additionally, in women who have undergone previous ovarian surgeries or those that have ovarian cysts, which is quite a common condition, and also in obese women, these conditions obscure the visualization of the ovaries, and the antral follicular count may not be very accurate. Also, the antral follicular count needs to be done on day 5 of the menstrual cycle, and it only gives information for that specific cycle. And it's also an expensive test. So which is why AMH comes into the picture and is preferred by most of the obstetricians. Now, there are a number of studies that compare head-to-head AMH with FSH and also their correlation with AFC. So for example, in this particular graph, you can see the AMH declining with age, FSH measured on day 3 of the menstrual cycle increasing with the age, and antral follicular count numbers decline with age. So the authors conclude that the CNM AMH levels strongly correlate with the AFC counts, and they have highlighted it to be more reliable than FSH. Also, there are a number of studies have been performed in recent times. This review by R. Fleming concludes that there are several advantages to AMH, including objectivity and convenience. And it went ahead to say that AMH, in fact, may become the gold standard soon. Now, women who have delayed the decision long enough and are having trouble conceiving naturally, ARTs or assisted reproduction technologies are used for childbirth. So understanding IVF is important to understand the ovarian response claim. So this particular slide is an overview of the steps that occur in the IVF process. Step 1 begins with the evaluation of ovarian reserve of the woman. So the AMH and AFC will be measured. A detailed medical history is taken, and the partner is also interviewed. And basis that, the IVF cycle is planned. The second most important step is the ovarian stimulation with medications. Why? Because we want more than one egg to mature. We want more eggs to be harvested and to increase the success for pregnancy. And then, as you can see, the fertilization happens in a petri dish, and the embryo is allowed to grow in the lab for a few days, and then it is implanted into the mother, or it may be frozen and implanted at a later date. So what is AMH actually telling us is it's predicting what would be the chances of a good ovarian response. So with controlled ovarian stimulation, wherein medications are given, one can expect varying levels of response. So there could be a high response, an optimal response, or a low response. So high response is characterized by the presence of more than 15 oocytes which are developing at the same time. This also poses a threat to the health of the expectant mother. She is more prone to develop OHSS, which is ovarian hyperstimulation syndrome. And in very severe cases, this can prove to be fatal as well. And on the flip side of it is the low response, which is defined as up to 4 oocytes developing in the ovary. And here, of course, the risk is failure of the IVF cycle. So the optimal response is anywhere between 5 to 15 eggs which are developing in the ovaries. Now, what do the guidelines say? So the ESHRE guidelines, which are the European Society of Human Reproduction and Embryology, they state that both AMH and AFC are very good to assess the low and high ovarian response. And they both have high accuracy in this regard. And they go on to say that the prediction of ovarian response categories by AMH alone is also reliable. So coming to Siemens AMH assay, it has both the claims and covers the intended use for assessment of ovarian reserve as well as assessing poor ovarian response to controlled ovarian stimulation. And the assay now has 2 enhancements. So the first enhancement is a 1:2 automated dilution on board, because what was seen earlier was whenever the result was greater than the upper measuring limit of 24 nanograms per ml, the lab had to send out the test to another lab. Now it's it's the discretion of the lab to reflect and get an absolute value that can be reported. And the second thing is that the limit of blank, limit of detection, and limit of quantification all have been reduced. So that means the assay becomes more sensitive and the AMR is also increased. So the AMR limits now are from 0.013 to 24 nanograms per ml. If we look at the clinical performance of the 2 claims, so the first claim, which is for assessing ovarian response, so the sensitivity that the assay offers is excellent. It's 90.5%, which is higher than what our competitors are offering, which are to the tune of 88 point something. And this is, of course, very critical because we don't want to miss any woman who has a diminished ovarian reserve. For the clinical performance for the second claim, which is assessing ovarian response, so there was a multi-center study that was done, and our assay was compared with another automated assay in the market, which has been there for quite some time. And what we observed was that the positive percent agreement and the negative percent agreement of both the assays was 99.2% and 95.2% respectively, which is a very high level of concordance and gives confidence in reporting these results. Now, I want to bring your attention to 2 recent published studies which compare our AMH assay with other automated AMH assays in the market. So the first study compares our Centaur Analyzer AMH with, let's say, I'm calling them assays X and Y because I'm not allowed to take their names in this forum. And what is interesting is that this paper was published in November 2024 in Endocrines, which is a flagship journal of the Endocrine Society. And the co-author is Dr. Robert Christensen, who is the ADLM president. So that's a pretty big name to have as a co-author for the study. And what the study showed was method comparison results. There was a strong correlation between the Centaur AMH assay and assay X. You can see that there's a slope of 1 and a correlation coefficient of 0.909. But Centaur and assay X compared to the Y assay, the slope was pretty high at 1.41. And the correlation coefficients were poor, 0.77 and 0.75. In addition, when the clinical performance was assessed, comparing AFC results versus AMH, the Siemens Centaur and SA-X sensitivity and specificity were comparable, while the Y-SA sensitivity was an outlier at only 77.3%, while for us this stands at 90.5%, and that's a substantial difference. in order to know which is this essay, why, we have the published papers present in our booth. There's also a second publication. This one looks at the Italica Analyzer AMH and compares it with X and Y assays, and also an ELISA assay Z, and published in January 2025 in Clinical Biochemistry journal with a sample size of 127 patient samples, and the same results are obtained. The Y assay shows significant biases, probably because it underwent a reformulation in the year 2023. I also want to highlight that the AMH is important in the early sexual differentiation and development of the fetus. So, Mullerian duct is the embryonic structure that develops into the female reproductive tract, and AMH presence causes regression of Mullerian ducts in the male fetus, so that the Wolffian ducts develop into male reproductive structures. So in a male infant, AMH is a marker of testicular tissue. So pediatric endocrinologists use AMH to address challenging questions related to disorders of sexual development, that is DSDs, in male infants with ambiguous genitalia. Also, undetectable levels of AMH is highly suggestive of anorchia or gonadal dysgenesis. AMH has also been used to aid in the differential diagnosis of undescended testes. And along with testosterone, AMH can be used in the diagnosis of precocious puberty or delayed puberty in adolescent males. So it does find a wider application. Next, I quickly want to go over to the preeclampsia biomarkers, PLGF and SFLT1, which are uniquely present with Siemens Healthineers. What is preeclampsia? It is one of the hypertensive disorders of pregnancy. It's a multi-system disorder typically affecting pregnant women greater than 20 weeks of gestation and sometimes even up to 6 weeks after delivery. And it is characterized by new onset hypertension, proteinuria, and in the absence of proteinuria, there is evidence of significant end organ dysfunction. So why do we need a diagnostic test for preeclampsia? In obvious cases where the presentation is as per definition, it's not required. But in many of the presentations, it's not. The diagnosis is not very obvious. And then there are a lot of women who are developing gestational hypertension but not preeclampsia. And in this group, the test is extremely important to reassure them that although their blood pressure is rising, it's not preeclampsia, it's only gestational hypertension. And then women who have other chronic medical conditions such as hypertension, diabetes, or chronic kidney disease, making a diagnosis of preeclampsia is very, very challenging without using specific biomarkers for preeclampsia. Also, the disease burden is quite large, and unfortunately, the exact mechanism of the disease is not well understood. So in the absence of preeclampsia biomarkers, what obstetricians do is they will continue to measure the blood pressure, presence of, and see the presence of proteinuria, and also monitor the signs and symptoms after admitting the mother, which is quite tedious and difficult, and there are a lot of hospitalization costs that can be avoided. So how is the result reported? The ratio is the SFLT concentration divided by the PLGF concentration in picograms per ml. The ratio is unitless and it is to be reported to the nearest whole number. So if the cutoff is greater than equal to 38 in the gestational age from 20 weeks to 35 weeks plus 6 days, the interpretive remark would read an increased risk of developing maternal fetal complications or preterm delivery within 2 weeks. And of course, the results need to be correlated with the medical condition and other reports for the mother. So for Siemens, SFLT1 and PLGF assays are available on Italica, CI 1900 and Centaur, and it can be consolidated with the AMH assay. If we look at evidence-based guidelines that recommend use of preeclampsia ratio, so these include the UK NICE guidelines, German, Austrian, and Swiss societies of obstetrics and gynecology, and the European Society of Cardiology. When we looked at the clinical performance from 24 clinical sites, what we observed was that the negative predictive value was 95%. What does this mean? This means that if a woman's ratio is under 38, for the next 2 weeks, this rules out in 95% women the possibility of developing preeclampsia. And this is a big aid to obstetricians. Siemens Healthineers also has a complete breast cancer menu. This includes the classic tumor marker CA15-3, but I want to focus on something that is more niche, HER2-neu. So HER2-neu targeted therapies are only used if a patient's cancer is determined to be HER2 positive. Serum HER2-neu is not approved for diagnosis. HER2 positivity is determined by IHC, looking at excess cellular expression, or by identification of HER2 gene amplification by one of the three in situ hybridization techniques. So HER2 targeted therapies, pardon me. So HER2-neu is used for follow-up and monitoring of patients that have metastatic breast cancer whose initial serum level was greater than 15 nanograms per ml. Serial measurements of HER2-neu in serum is done, wherein rising trends imply, of course, disease progression, and greater than 20% decrease implies a therapy response. I quickly also want to mention that we have Fetal Medicine Foundation approved free PETA HCG and PAPE assays for maternal screening on the Centaur and Italica analyzers. The Immulite platform, which also has other esoteric immunoassays covering multiple disease states, offers first and second trimester maternal screening assays with excellent performance. And I want to just round it up. This is my last slide. Our testosterone assay is CDC certified. Our automated androstenedione assay aligns very well with LCMS, which is not available with many of our competitors. Our assays have no biotin interference. Our prolactin has minimum macroprolactin cross-reactivity, and established pediatric reference ranges are available for age group and TANF stage for more accurate interpretation even of pediatric results. And we have a comprehensive menu for easy consolidation. Thank you.
Thank you, Dr. Debnani, for the elaboration of such important assays. And I think I can speak for everyone. We as histo and cytomorphologists, we tend to really neglect these, the importance of these assays, although we keep authorizing or signing on them every now and then. So the importance is well known. And I'll open the house or the floor for one or two questions. Any questions? No questions. If you don't have questions, do you have? I have a question. Like, it's very interesting to know that your equipment center has assays for HER2-neu. So what's the sensitivity and sensitivity of this test that we do? We usually do it on IHC, and we've been reporting on IHC, but I haven't heard of it being done as an assay. So can you just highlight on that?
Yes. So the specificity that we offer is to the tune of 95%, which is quite good. Sensitivity numbers, I don't remember at the top of my head, but I can come back to you. But the specificity is pretty brilliant.
95 is very good. Okay, thank you so much.
Thank you so much
for your talk.
Now we would like to invite Dr. Manor Pradhan. He will be presenting the paper from Oslo online. Dr. Manor, are you online? Dr. Manor, he did his medical school from Bangladesh, and he was second batch resident in IOM doing pathology, and also he did PhD in University of Oslo. At present, he is researcher in the Institute for Cancer Genomics and Informatics, Oslo University Hospital. He had done several research in gynecological pathology and also interested in AI application in histopathology, digital biomarkers, and computational pathology. He is also co-developer of CMark digital biomarker tool published in Lancet. He has several publications in international journals like Lancet, Annals of Oncology, and he had several papers presented in ECP, ESGO, and other international forum. Dr. Manor, are you online? Yes. हेलो त्यहाँ देखि त रहेछ है Dr. Manor, we cannot hear you. Hello, we can hear you. Namaste.
conversely, some high-grade features with introversion. Therefore, it is necessary to accurately clarify risk perception to ensure that patients at disease receive adequate treatment, while those risks avoid only. The research clinical protocols of these factors, such as engagement, peptide, and engagement, are imperfect critical conditions. Hence, there is a need for clinical constitutes, such as therapy and let's begin with the data. In line with the performance of this mathematical evaluation of based on 3 years experience and over 3 months. We propose that individual question is divided into 2 main tasks. By one user, our user is AC and children user. They are very not individual authority and have service. Now, two users, on the other hand, are not permanent. Typically high-grade users of the authority and have authority. This universal model was widely used in many ways. However, it has important limits. It is an oversimplification and fails to reflect the full biological and clinical diversity of the human customer. It does not account for modern differences in the treatment, which we know are important for prognosis and care. We all know the stories of carcinoma, which are the glory and carcinoma, which is the most common and great is in the common. So, very well as an area, with 54 area, with 3 more than 60%. All the types are this carcinoma, this carcinoma, mixed carcinoma, carcinoma, and in 2013, the Cancer Genome Research Network published a landmark study that introduced molecular practitioner in the later time based on genomic knowledge of 250. They identified 4 distinct molecular attacks. 4 key alternatives, and therefore this is involved in the relationship. We saw as 2 hydrogen alternatives. Next is myostatin insertion hydrogen. These features have effects in mismatched proteins, such as NF1, NF2, NF6, and NF6. They are also highly used for the and also as NSIP, no molecular provides these features as immunity and low cognitive often associated with low rate Cognitive also known as normal or serious. These features show extensive cognitive and are usually associated with commonly include the carcinomas and also the high-grade. These 4 molecular subgroups have clearly different results. 4 key alternatives have excellent in high-grade. NSI high-grade and community have injury. Often the high-grade have 4 alternatives and are associated with researchers propose a skateboard algorithm to classify the disease. First, check for community with negative information that identity relax. For the process, this is high There are five well-known hotspots. These are responsible for about 95% of all hospitals. In addition, there are 6 non-hotspot facilities in nutrition that are also classified as specific. Companies need to evaluate those are the non that need to be. Because of this complexity, accurate spacing and interpretation are difficult to avoid. This particularly right from an example of the possibility of these foreign and second and for mismatch behavior, the standard method is linear for and then one, two, and six. However, two answers for screening algorithm have also been proposed in platform. This can two and six it also is considered as an outcome. If there is law and this the procedure and there is one and this it was a sort of can be used for and cost and that. For example, the case that over here there is loss of the two and one, while I two actually and six are these people can about even the value and get them to know about themselves or the community is that identify communities. So it's really those that side from the diet or the normal or the activity. The white diet, normal is impacting. So that is when you can always only in a subject. There are three main abnormalities. Overexposure time, even about the people of our strong, old, reflect, and listening knowledge of complete action, observing about there is no set of very sacrificing here and seeing about what and the improvement in I'm going to go through this presentation activity. Individual personalized device will go to the according to the small individual guideline. This group guide is of activities. The reference is possibly different with the article from the Expo 2025. Those are the immediately I will here and the value graphic that I will review, I will Iris, I will more than clearly clear prognostic value across different clinical groups in our visit. As illustrated in these by the molecules are further defined in the following low and intermediate highest advanced molecular each group for immediate user non-specific development is also given highest molecular effect. In fact, these are more students photographs regarding the body and several for intermediate regarding actions, but candidates can be depending on competency. NSNP represent ability, making prognostication more challenging. We have this student dissatisfaction and rate items used to further stratify and human and people of the study. It is covered by the law of NSNP to go to 1,000 cases. The cases were grouped as follows. Those with one or two consciousness versus high, weekly, and or common. These strategies show they have a picture of each is complete part of how the system works together. We see that as a one controller from the image on the right shows an example of the key art of the student strong users the IC on the right shows an user operating based on these findings, a new risk certification approach was introduced as and necessity regarding use of non-structure, low rate and relationship, and high rate of the high rate of relationship, supposed down with high outcome similar to the anomaly. In contrast, low rate and low depending on the characteristics of the disease, such as the immunity, the vascular stability, or other things. Additionally, for these regardless of the rate, including services or the analysis of contact. In the operating model, is holding the disease, but the global original all of the uncertain to the process. While for healing diseases, then we have an accident policy. We matter that non-specificity of good less or less. On the other hand, all of the regional or economic include those that are weak, they are known as are poor for the are satisfied as higher, which is poor. Now let's move on to element and on the element then is the neural cancer over aggressive disease. Almost inferior to the ground system, specificating mutation and function. I am asked to reduce the survival of technology. In 2013, God analyzed 1,000 platforms in the department. We found that humans generally more efficient available than efficient at with C1, E, and 8E. There was a time for the zero seven and hazard ratio of each score overall death. These findings underscore the value of yellow death on the right of the region, these are the example zero ratio as shown. Zero ratio as more than zero ratio. Elbow can perform marble for the clinical. Today's study focuses on that using the energetic circle, which is a more capital human data, significantly important to each this is our unpublished data on cohort of 877. We show that what activity and energy students may outperform 30 kilometers by 8 times the lower unit interest, energy units was separated by near the north. In the lower right, same group was certified by Great and RC, because also multiplier active this slide shows the graphic abstract from our recent publication, where we have analyzed 400 highlights in the category. Finally, to complete the study part, we specifically among senior academic users, everyone can study or over the another argument for doing high and everyone can also actually as one of the data. So everyone can be very hard and everyone can currently, everyone can actually and we also need a now let's move to the student points of this course here. Here are organized activities which are formed after and are commonly found activities. So the first period is often associated with terrorism, and they are emerging as sensitive from markets, the responsibility. There are three streams of activity. First is the active, then the skill, and the L1 is very small. Well, because it's also the right, allowed identify both international and necessary. The excellence and the glory is the constitution for the good, the balance of each element being highlighted of the transforming incidents of failure. There are over 1,250 million here is the identified what when they analyze about one of the analyze, they really how to this,
Thank you, Dr. Manor, for excellent presentation and your experience in molecular classification of endometrial cancer. Now the floor is open for questions. 2 questions, please. No questions. I have a few questions.
Please ask at least 1, 2 questions.
Dr. Manor, I have few questions. Like we are getting more and more cases of endometrial carcinoma, but we don't do all those molecular testing here. How you do all this genomic typing in all cases of endometrial carcinoma? And also another question that do you do TLS in all the cases, and how do you do the grading? And also the test L1 camp, how often do you perform in the cases of endometrial carcinoma?
And now the pathology department in the victim of CPN started to do of the and next was ALM. This is also for the research. We don't do it for normal implementation. This is in the research area. And the GAS, there are two things. One is before language and the advantage of village language is that we can see and have a that are also because the creators of creators that is. And we have already said that that's and we have also gone here is also important for the medical system, so we did that with using we take the water, we are going to aggregate, and then 21, define nucleus and PCC. Then this is the research state, and I believe the founder is the SO meeting in February. Not noise, and the abstract is probably now in the cancer, and we are trying to make it to the right phase and we will hopefully get to that. So it says that this totally important structure is important because this is most investment to the human. And this is important because now we are using human responsibility. So this can also be a predictor for the rest of the therapy. And it has been shown in some significant using that study, only using that. So we are doing this in future and work with this opportunity that we can so that is our next stage. But for now, we are not sure whether it's going to use and CCTV and one. And I just want to be able to or not. So this is the have I answered all your questions or is there anything more?
I think most of them have been answered. Thank you.
Thank you. Thank you, Dr. Manor, for excellent presentation.
Any more questions? Any more suggestions? Any more doubts? To be clarified. Okay, so molecular classification of endometrial cancers, I think our oncogynecologists have started asking for them. I don't know about your experience, but once we report on endometrial carcinomas, besides the low-grade endometrial carcinomas, the high-grade, they have been asking whether we have started as pathologists our role in it. So I think like ours is a resource, we have resource constraints, but then the surrogate markers should be enough to some extent, I guess, at least the MMR proteins and the P53. And if I know correctly, these are mutually exclusive. Am I correct? They're mutually exclusive. First, you go for these two markers, and of course, a very friendly marker that is done in most of the setups, that is ER. So we can go by these three markers, and if something comes positive, it's okay. Otherwise, then we go for the pole mutation. So I think even in our country, we could start, if it's necessary, on high-grade tumors. What do you say, Dr. Manohar? We have these facilities. We are doing IHC for them. Only pole, I think it needs a little more expensive setup and a more sophisticated setup in the form of sequencing and all. But I think we can start with the other two markers first. But without having done these three markers, I don't think we can come to the next category, that is non-specific molecular profiling, because only after all three are negative, we can call it.
Let me add some comments on this, because in our setup, our gyne-oncologists, they ask to do in all cases of endometrial carcinoma this test. So we have started for the last 6 months. We are doing each and every cases of endometrial carcinoma, MSI, and also P53. Estrogen receptor may or may not be needed, but pole after that, yes. So we stage according to FIGO afterwards.
Yeah, because PIGO classification 2023 includes the molecular profiling. So I don't think they will agree on us not doing the molecular, and we can do it in our country. That's what I'm trying to emphasize on. And of course, it's very important to do the molecular. I slightly disagree with the concept that you should do it in also low-grade endometrioid carcinomas, provided the reporting is correct, because usually it's pole positive. But in the high grade, especially the high grade endometrioid carcinoma, which is considered it's considered a high grade tumor, but surprisingly, you can have a few percentage of these tumors that will show pole mutation. And that means although they are categorized morphologically into high grade, if they show a pole mutation, means they are of good prognosis. So the treatment is very different. I really feel we should start the molecular, but it may not be necessary on all cases. Morphology is very, very important. The molecular classifications do come, but it all depends, and you work ahead depending on the histomorphology, which is the ABCs, and please do not neglect it. And another thing that I want to say is it's not a substitute for the histomorphology. Where you have these molecular markers are done in very specific cases. Like sometimes you think it's an endometrial carcinoma. Sometimes it's very difficult to differentiate because it's got serous features, serous-like, and these are the cases. Even clear cell carcinomas of the endometrium, they are very rare, but they're very high-grade tumors. But after molecular classifications, it's seen that there is, if it may be just a little small percentage, but at least few of them have the pole mutation. So it's got a good prognosis, and you don't have to go for extensive surgery. So these are the take-home few points to everyone here.
Okay, thank you, Dr. Manor. Nice to see you after so long. Now,
So I have one question. I have seen the practice outside Nepal where they subject the tissue first to IHC and then go for the morphological thing and then report it. So I have seen or heard about the cases where IHC is reporting something else, but you get only a small sample where there is no consistency between the IHC and the reporting. How do you justify that? So can we be done, or if we are just reporting on the basis of IHC only, not looking at the morphology, do we justify it, or we need to do something else for that?
It's not justified, but I don't know
Yeah.
how they are doing that. But normally, people watch it, then only I. But it is information classification. If you don't have all the markers, it's basically a or we continue that or not. That's totally taken. Otherwise, you can do as the professor has already proved that like Neymar and three is enough. And PCR, that is right. So, as to all of this, I can never recommend going from where I see or any activity without no problem.
thank you.
Okay, thank you very much. Now I would like to invite the next speaker of the session, Dr. Rupanita Biswal, who will talk to us about real-world cases in ovarian tumor diagnosis. Dr. Rupanita Biswal is a pathologist and has done a fellowship in oncopathology from Tata Medical Center, Kolkata, with specialized training in urogenital, female genital, and breast pathology. with research focused on molecular classification of bladder and kidney tumors, pole mutations in endometrioid cancer, and low, ultra-low HER2 new breast cancer. And she's also an ISO 1518922 trained and has overseen NABL assessments for 4 years. She is passionate about quality-driven diagnostics and collaborative cancer care.
So, good afternoon, everyone. At the outset, I would like to thank the organizer and the team for this wonderful event and fabulous arrangements you have made. Um, so, when I saw this list and when I actually went through, I was literally thrilled because I found a place in the list. And especially why? Because it's like who's and who of this part of the region. Uh, so this is what I'm thrilled about. At the same time, I would like to thank my Nepali friend, Dr. Grishma, with whom I have worked a lot, and she has always been helpful. So thank you, Grishma. So coming to the topic, I have been asked to be very specific and stick to the time. So to start with, my topic will be from clues to diagnosis, case-based discussion, and assessment in ovarian tumors. So today's focus is just ovary. It can be perimenopausal ovary, it can be postmenopausal ovary, it can be young ovary. So let's start with it. So all of you must be knowing about the morphology, need not brush much on it, but we will do when we do the cases. To start with the WHO 2020 classification of ovarian neoplasm, we know all this, the low-grade serous, high-grade serous, mucinous, endometrioid, clear cell, malignant brainer, mesonephric, like carcinoma, undifferentiated, dedifferentiated, carcinosarcoma, mixed carcinoma. So what is out from the 2020 classification is the seromucinous carcinoma, which is now reported as under the category of endometrioid carcinoma. So this is something we should remember. So now, the straightforward adnexal mass. So when you see some case and you feel, is there such thing, do such thing exist? Yeah, there exist lot of cases which we don't know, I don't know, you don't know, but those are rare cases. So for those rare cases, definitely we will need help of our friends, our colleagues. But what about the bread and butter cases which we see on a regular basis? So I'll stick to those bread and butter cases today. And we must acknowledge that the bread and butter for me may not be the same bread and butter for you. But we should know that we cannot diagnose something which we have not heard of. So we should take help of others. We should ask to our colleagues before proceeding for any case if we are stuck. With this, morphologically, our tumors, our adnexal tumors, are divided based on the origin of the cells. It can be epithelial, germ cells, stromal, and others. Before starting any case on your table, please, I would request everyone, including the residents, to please go through the relevant history, which is very, very important before starting any case. So consider what is relevant for you for an ovarian tumor, any history of other gynae malignancy or other prior gynae malignancy. Is it the patient do have a history of endometriosis? Any abnormal pap smear if you know, any history of malignancy elsewhere in the body, and any blood test abnormalities like the serum markers. So please be ready with all this history before seeing any case of adnexal mass. So as I have told, the morphology is first, and first stick to the origin of the tumors. So focus on morphology first. Next, start exploring IHC for the ovarian lesion. Because my topic is ovary, I would concentrate on that. So to start with, always start with a PAX8 and WT1. PAX8 for Mullerian, and why WT1? Can I have an answer why I am expecting WT1? Because the serous is the most common tumor when we are dealing with the ovarian tumor.
which is followed by ER and PR. But sometimes one is done, sometimes both. It depends if endometrioid is a differential. Now, next, PAX8 WT1 ER/PR done. And since I have told the major bulk of our tumor is serous, so we should understand the pattern of P53. Dr. Manohar has very well explained the mutation pattern of P53, which equally applies to the ovary as well. So to call something, so in P53, we have two things, either mutant and other is wild. But to call something mutant, there are three patterns again. So something which is overexpressed, that is in more than 80% of the cells, you are getting nuclear expression, which is strong and diffuse. It has to be strong. It cannot be just weak and patchy. There is something called null pattern. There is absolute no expression, not in cytoplasm, not in nucleus. And there is something called cytoplasmic pattern. So you see either complete cytoplasmic pattern or including your nucleus, you will have a cytoplasmic pattern. Then for this three, only call it mutant. Rest all, when you're seeing a patchy, please limit your or report to consider it as a wild type. Do not consider mutant. So let's start with our case one. So case one is a 42-year female with a large abdominal mass and a history of endometriosis. CT abdomen reveals bilateral solid cystic adnexal mass and multiple peritoneal deposits and a raised serum CA125. So with this, probably we have made some diagnosis in our mind, and we got a core biopsy from the peritoneal deposits. What we are seeing is a solid pattern of tumor, hardly any papillae formation, and definitely the high-grade morphology. So as I have told, when we are seeing this case, before seeing, we need to know the relevant history. For this patient, what was relevant is history of endometriosis and a raised serum CA125. Rest everything was no for this patient. So any thought on this? We have a solid cystic ovarian lesion, high-grade cytology, solid architecture on microscopy, and non-mucinous loop definitely. So what do you think is the tumor? Okay, yes, serous. So serous is what we are thinking now. So if it is serous, what is the expected IHC pattern? It has to be PAX8 positive, definitely. Why? Because the biopsy was from peritoneal side. So first is the PAX8, then is the WT1. Once your WT1 is positive, then you are dealing with a family of tumor, which is from the serous family. Then ER and P53 in a high-grade tumor. What are we expecting the P53? Mutant, isn't it? So P53 mutant, high-grade ovarian tumor is what we are expecting right now. And P16 is diffuse block positive. So this is something, PAX8 is strong and diffuse, WT1 strong and diffuse, ER diffuse, but in little less in intensity. P53, what do you say about the P53 in this case? I want house to be involved so that, so P53, are we going to call it mutant? No, wild. So P53 is wild and P16 is diffuse block. So it is a hybrid series. How many will bet on it? It is a hybrid series. Yeah, okay. So we'll go ahead with the hybrid series. Okay, so we'll move on to next case and let's see what happens. So next case is a 32-year female with irregular menstrual history. USG abdomen shows a solid cystic lesion in the right side. So this is what we are seeing, more like small papillae, attempted acinar formation, low nuclear grade, we are not finding any mitosis. So basically this is a solid cystic ovarian tumor, low grade cytology, vague papillary and acinar pattern, and non-mucinous. Again, what is this?
Okay, serous. Okay, fine. We'll go ahead with the serous. So thoughts are serous again. Okay, great. So pack site is positive, WT1 is positive, ER is positive. Fine. And P53? What do you call the P53 in this? Patchy? It's strong and nuclear. The area which you are not seeing are not the tumor cells. And P16 is diffuse block, low grade cytology. So is it low grade serous carcinoma or high grade? So is your differential low grade or high grade? High grade. Based on, is it based on P53? Okay. So you are, can someone bet on low grade after P53 and P16? Okay, so let's see. So discussion for these two cases is like when to call something high-grade serous carcinoma on morphology. So there are two things we need to understand, architecture and cytology. So architecture, we can see a solid pattern, papillary pattern, labyrinthine, gangular, cribriform, whatnot. Cytology, there has to be pleomorphic, which is moderate to severe. Hyperchromasia, macronucleoli, mitosis, skin cytoplasm. So whether macronucleoli, mitosis were present in the previous case, just the one which I showed, no. So are we still going to call it high-grade serous? Okay, so let's see. Now, what would be that is the morphology which I was talking about. Now, let's see what about the immunophenotype. So immunophenotype, it has to be PAX8 positive to consider a Mullerian origin, WT1 positive to consider it as a pelvic serous differentiation, P53 has to be aberrant or it has to be a high-grade serous signature. Then only we can call it high-grade serous. Then what about the two cases which we saw just now? Is it really low-grade serous or high-grade serous for the first one and the low-grade serous for the second one, or vice versa, or nothing, it is something else we are dealing with? So, to understand this, we have to have an accurate diagnosis of P53 first. So, before considering something mutant or wild type, first check your control, internal control, external control, and then consider something mutant or wild type. After this, even after doing that, we need to have a knowledge of correct interpretation to when to call something P53 aberrant. Okay, so let's see about how to a practical approach for this interpretation. So that two things, we can have a nuclear expression, we can have a cytoplasmic expression. To call something nuclear expression or nuclear staining, it has to be diffuse and strong in more than 80% of the cells. Or there has to be complete absence. Or there has to be variable intensity in less than 80% of the cells. So you are seeing nuclear staining, but variable intensity. So when there is strong and diffuse in more than 80%, cytoplasmic staining may be present, may not be present, and you call it P53 overexpression. When there is complete cytoplasmic absence, then what do you call? Sorry, complete nuclear absent. And if cytoplasm is absent, then again you call it P53 mutant type. And when there is a variable intensity less than 80%, so remember the cutoff. So it is not just nuclear and strong diffuse, it has to be in 80% of the cells. So anything which is less than 80%, please rethink, please restain if possible, or at least convey this message to your clinician that we are dealing with a case like this, and this might turn out to be this, whatever you're thinking in your mind. When it is less than 80% nuclear staining, and you go for a cytoplasmic staining pattern. So when the cytoplasmic staining pattern is present in more than 50% of the tumor cells, consider this as a mutant pattern. When it is equivocal, you're not able to see, or maybe your I3 has not worked for some reason, then kindly do a mutational study if possible. I would suggest, if possible, kindly do, or at least write it in a note or a comment that this patient needs a mutational study for P53. And when there is complete absence of nuclear staining, there is nuclear staining in less than 80%, but there is complete absence of cytoplasmic staining, then we call it wild type again. Okay? So there is something called the emerging concepts about intermediate grade serous carcinoma and the low grade serous carcinoma, which is transforming into high grade. So if you remember the low grade serous carcinoma, if you remember the pathogenesis, the low grade serous carcinoma is not converted to high grade serous carcinoma. But there are emerging concepts now which is telling that the low grades are actually going into high grade. So the case number 1B, which I showed, probably is the low grade one, which is transferring into the high grade. Okay. Similarly, the case number 1A, the first case which I showed, it may be an intermediate grade, which they are talking about. So there is something called high grade, there is something called low grade, and they are working on intermediate grade. So probably it is the intermediate grade, the morphology is fitting into high grade, but the immunophenotype is not fitting. So probably these are the tumors which fit into intermediate grade, but these are all emerging concepts, and these are very good articles which I have found, and they are working on it, though it has not been accepted at WHO right now. Okay, so let's go to case number 2. It's a 48-year female, perimenopausal, heavy bleeding, and all evaluation were done outside. So we just had block to review. Hysteroscopy done outside showed thickened endometrium, and CCT abdomen, which was done, showed thickened endometrium with a fairly circumscribed lesion and myometrium, which they thought to be could be leiomyoma or could be a carcinoma of endometrium, which is extending into the myometrium. And we just had blocks for review. So this is the endometrial tumor, which we are seeing mostly in the SNR form. At nuclear grade, we cannot say on this power. And then this is the ovarian tumor. What about the nuclear grade here? Not very high, I would say. I'm not agreeing it to be a very high grade tumor right now. But along with that, the patient had this endometriosis in the myometrium. So the markers, PAX8 was patchy, but positive. ER was positive. WT1 was positive in one and was negative in other. So in the ovarian lesion, the WT1 was positive, and in the endometrial tumor, the WT1 was negative. So what do you think this tumor to be? Can we go back to history? We don't have any history actually, because the patient was evaluated outside, and it's not just patient was evaluated outside, patient was operated. So that they were evaluated thinking it to be just because of the leiomyoma, patient is having heavy perimenopausal bleeding. So they just went for a hysterectomy, and post-hysterectomy, they found all this. So we do not have a serum markers, we do not have a proper history, or we do not have a proper CCT abdomen, properly reported. So any take on this? What would we consider this? So if someone answers this, you have to tell why and when to tell this and why we are telling this. If not, we'll proceed. Let's see. So there is something called concurrent pelvic high-grade serous carcinoma and endometrial carcinoma. So does this tumor fit into that? And how to assign a primary site and stage to this patient? Because this patient now have an adnexal mass and also has an endometrial mass. And what is the immunophenotype, if you remember? PAX8 positive, ER positive, WT1 positive in one, WT1 negative in positive in ovary, negative in endometrioid one. So are we going to call this synchronous, or the same tumor involving the ovary and endometrium as well? Okay, let's move. So this is the challenging issue. So primary endometrial serous carcinoma, at least 20 to 30% of the time, they will involve the tubo-ovarian lesion and can even mimic the stick. So even if you are seeing a stick in the fallopian tube, irrespective of the stick, based on the stick, we cannot call it a same tumor or a different tumor. Okay. Similarly, the pelvic high-grade serous carcinoma, we mean to say the adnexal ones, 15% of them involve the endometrium as well. So we don't know whether this falls into those 25% or 15% of the tumor. So for that, the ESHAPE, the International Society of Gynecological Pathology, they have come to a consensus that when to assign what, this is the objective one, but can be used in our day-to-day practice. So most cases when they are presenting, when we are seeing are at the stage 3. So when WT1 is negative, we have to consider it as endometrioid serous, because it's not necessarily that an endometrioid serous will have a WT1 positivity. Most of the time, your endometrial serous carcinoma will be WT1 negative. HER2 overexpression. So HER2 overexpression, when you're seeing it is a stage 3 endometrial serous carcinoma. Is it I'm running short of time? Okay, let's see how far I can go. So when there is a discordance between WT1 and a P53 pattern, then suggest this could be a synchronous primary origin. So in this case, we saw a discordant pattern in WT1, isn't it? WT1 was positive in one and negative in other. So this is the synchronous tumor which was involving your ovary and endometrium. But we should understand that sometimes this is not going to help. This may not actually resolve at times, but at least we can give a try and help the patient if possible. So now, would you consider concurrent or synchronous? Just now I told. Synchronous, right? Because we are seeing a different WT1 pattern. Again, this is the same thing which I had told. Then something, concurrent pelvic hybrid serous carcinoma and endometrium, how to assign, I have mentioned. So this is a nice article, and it is an open article which you can use on when you're practicing on a day-to-day basis. This is a very, very nice article which has been given by the International Society of Gynec Pathology. Then we have completed the serous now. Now, what about the endometrioid? If you are seeing the endometrioid carcinoma in the ovary as well as in the endometrium, whether to call it synchronous or concurrent one. What do you think? So if you are telling that your endometrial tumor has involved the ovary, you are assigning this patient stage 3, isn't it? Straight away you are assigning stage 3. So what the ESHAPE is your International Society of Gynepathology. They, along with WHO, they have some recommendation. So they have called assign synchronous stage 1 endometrial and stage 1 ovarian if all these criteria are present. So ovarian tumor, if is unilateral, low grade, unifocal distribution, absence of surface or hilar tumor, absence of LVI, presence of endometriosis, then call it ovarian tumor. Similarly, and all the factors has to be present. Similarly, for the endometrial tumor, it has to be again low grade, more than superficial, myoinvasion should be present, absence of LVSI and presence of atypical hyperplasia. If we are seeing this, then we can call it primary endometrial. Okay, so but remember, all the criteria has to be present. Done? I'm moving on to case number 3. So it's a 51-year female with unilateral mass. USG abdomen shows a multilocular cystic lesion. Serum CA125 and CA are basically within normal limit. So what we are seeing is a tumor which has a mucinous lining, which is single layer, at least in this slide, and here also single layered. And what about this? They are showing some multi-layering and stratification. They have started showing multi-layering and stratification. Here also we can see they are showing stratification, and here the tumor is having a single line, just single line cells. Do you agree that this is a mucinous borderline tumor for us? Okay. So this is a cystic lesion, low-grade cytology, mucinous type. And when we call then focal, and we are also seeing focal epithelial hyperplasia at places. So there has to be differential. So let's see if this is a situation where we are only getting the lining, a single line cells and a focal area which is showing this stratification. So what are we going to call? Are we going to still call it mucinous borderline tumor? So this is situation 1. Same tumor, if has this kind of morphology. Do you agree to mucinous borderline tumor now? Sorry, ma'am. Yeah, Mets will be a differential, yeah. Situation 3. So something which I have not explained. So what, if you are seeing this situation, are you going to call this Mets or mucinous borderline or mucinous cystadenoma? Because we are seeing only 6 single cell lines, cystic areas. And what about this area which I have focused? What is this? This is a Brenner component. So even if we are seeing this mucinous, which is giving us a feeling that this can be metastatic, if we are seeing Brenner component or if you are seeing teratomatous component, please consider this as an ovarian primary mucinous tumor before considering it as a metastasis. So if you are seeing teratoma or Brenner component, stick to mixed epithelial tumor in the form of mucinous or with the other component which is present. Okay, so do not consider Mets for this case at least. CK720, I'm not talking on this because at any cost for mucinous tumor, whatever markers you're doing is not going to help at the end of the day. Case number 3B, in continuation with the previous case, it's a 48-year female with unilateral mass, USG abdomen shows multilocular cystic lesion, and there is raised serum CEA. So again, we are seeing a cystic area and more or less singly lined. Here you are seeing some kind of stratification, and here what you are seeing is there is stratification, no doubt, but the nuclear atypia has increased to a greater extent, isn't it? So the nuclear atypia, what we saw in the previous case was mild, not even moderate, but what we are seeing is moderate to severe, isn't it? So does this fit into mucinous borderline or mucinous carcinoma? These are the further, sections which are showing very stratification, complex architecture, high-grade nuclear features, 1 or 2 glands here and there. So thoughts on this? Cystic lesion, low-grade to high-grade cytology, mucinous, marked cytologic atypia also present. So, what will be this tumor? Okay, let's discuss. Any differential you have? So let's do a CK720 at least on this case because we don't know. So this is CK7, which was positive in those high-grade area which I showed, and also in the low-grade areas or the intermediate area. CK20 was negative. This was PAX8. So let's discuss the mucinous borderline tumor now. So usually the mucinous borderline tumors are those which are lined by columnar mucinous epithelium or gastric epithelium. There has to be nuclear stratification to call it mucinous borderline. If there is no stratification, we cannot call it borderline. It stays in the category of mucinous cystadenoma, isn't it? If mitosis is present, we still consider it as mucinous borderline tumor. We are not just based on mitosis, we cannot push it to mucinous carcinoma, okay? So at least 10% of epithelial volume must demonstrate all these features which I have told to call it mucinous borderline tumor. But what about those cases, this is a challenge one, where you are seeing those epithelial proliferation but in a less than 10% of the tumor cells. Are those mucinous borderline tumor? Then what is it? So it is called mucinous cystadenoma with focal epithelial proliferation. Only if you're seeing those things in more than 10% of the cells, then we would call it mucinous borderline tumor. Challenge number 2. What if the nuclear atypia is severe in the lining epithelium as we have seen in this case? Sorry, focal nuclear atypia? Okay, great thought. But it was not focal actually. Wherever there was proliferation, it was not focal. Okay, great. Yeah, that's a good thought. So When to call focal intraepithelial carcinoma, as you have said, when it is focal and patchy, call it intraepithelial carcinoma. If it is not focal and patchy, then what will be your thought? So when there is severe, diffuse severe nuclear atypia with brisk mitotic activity, so the term is brisk mitotic activity, consider mucinous carcinoma. But if you are seeing focal here and there nuclear atypia, then it is an intraepithelial carcinoma. Challenge number 3 is when to call mucinous borderline tumor with microinvasion. When do we call MBT with microinvasion? Sorry? I'm not able to hear. Okay, so to call something microinvasion, it has to be less than 5 mm. Okay, anything which is more than 5 mm, it falls into mucinous carcinoma directly. Regardless of the microinvasion foci, I mean the recurrence rate is just 5% and tumor-related death is less than 5%. Challenge number 4, what is microinvasive mucinous carcinoma? What we saw is mucinous borderline tumor with microinvasion. And there is something called, yes, it is there in the WHO, what is called microinvasive mucinous carcinoma. When do we call it microinvasive carcinoma? We can call microinvasive if it is less than 5 mm, the invasive component, but the nuclear atypia is more than what you are seeing on the lining epithelium. Your lining epithelium, suppose, will have a mild to moderate nuclear atypia. The invasive component, which is less than 5%, should have a higher nuclear grade than the one seen on the lining epithelium. Then those components are called microinvasive. Yeah. No, not. No, the nuclear atypia has to be real atypia. Like I showed, it has to be real atypia. It cannot be just, yeah, definitely. See, the severity is always a subjective term. But what I showed as an example where you're really, really convinced that, I mean, almost 90% of the people in the hall will agree to the fact that that was definitely severe nuclear atypia. So only in those cases considered to call it as a microinvasive carcinoma. So the situation number 1, now can you diagnose this after discussion? So what you are seeing is a lining epithelium with single line cells, and here you are seeing focal proliferation. So, which is less than 10% if it is. So, with focal epithelial proliferation. Okay. Now this, mucinous borderline, you all agreed to this. What about the situation 3? I have already told it. When you are seeing a Brenner component, please do not refrain yourself from calling it a mucinous mucinous tumor and ovarian primary. This one, which this is case number 3B, which we have already seen. So what are you going to call this? Just a revision. We have already seen this slide. We are seeing the mucinous borderline component here and some high focal area which is showing this high grade features. So what are we going to call? Focal area intraepithelial. So only when focal it has to be intraepithelial. Now we are seeing some glandular areas below. If it has a higher nuclear grade, then consider this to be microinvasion. So this is not my own case actually. I have just taken it from internet for your purpose to understand. There is some term called mural nodule. So mucinous MBT with mural nodule or mucinous carcinoma with mural nodules. So when to call this mural nodule? What are those mural nodules actually? They are like a sarcoma-like nodule you see apart from the mucinous component. And that can be foci of frank sarcoma, the foci of frank anaplastic carcinoma, and it is not necessary that the size should be less. So size can vary up to 10 centimeter when you're seeing this, but when you're seeing undifferentiated or anaplastic component or a sarcomatous component in a mucinous tumor, then please keep a differential of mural nodule in those cases. Okay, this is my last case. So this is a 59-year female with bleeding PV, slide for review. Biopsy was from cervix actually. So CCT abdomen showed only enlarged left ovary and PET-CT avid lesion in cervix and ovary, remaining all organs were unremarkable. So this is, we can see the cervical lining, and below is a very, very busy area. So on high power, we saw this. These are probably the atypical cells which are going in a probably cords, or if I say single file, you would agree to it, isn't it? So what is your take on this? Can it be adenocarcinoma cervix? Gastric type? Okay, let's see. So what happened when we got this slide, actually, it was a slide actually. We never got a block for this particular case, this particular cervix case. So the patient, we could not further proceed with the marker to call it ovarian primary or something else, sorry, the cervix primary or something else. So the patient had to undergo a lap and proceed procedure where they found some peritoneal nodules. And in peritoneal nodules also, we are finding similar those single file cells, isn't it? Are you able to appreciate these areas? So and this was a frozen for us. So when we saw this, we called it as a metastatic peritoneal deposit. And since we previously saw a cervical primary, we thought possibly a cervical primary, but we never agreed to the fact that it could be completely cervical primary on a frozen section. Since it was a peritoneal mets already, they also did a biopsy from the ovary, which we saw that there was some enlarged ovary, and we are also seeing those cells here in the ovary here and there. So is it a cervix primary which is going into peritoneum and to the ovary, or is it an ovarian primary which is coming to the peritoneum and cervix? So how would you sign out these cases? Suppose we don't have any IHC, how would you sign out these cases? So in those conditions, what we are going to do is, even if, because we really know there's something called cervix gastric type, isn't adenocarcinoma gastric type. So that will definitely be your differential first, because patient do not have any lesion anywhere else in the body apart from your cervix and ovary. And ovary, if I say, a signet ring component or a morphology on ovary is seen, but very, very rare. So either it is so the more convincing thing for us would be probably a cervix primary, which is going into the ovary, but at the same time, we should always keep a differential of metastasis. But this patient never had any, lesion on PET-CT, apart from cervical lesion and ovarian lesion. So we thought this to be cervix primary going into ovary, and then we gave a differential that please consider metastasis from others area before considering cervical primary. So that was our diagnosis initially. But we did attempt markers. CK was positive, 7 positive, 20 negative, PAX8 negative, GATA3 negative. I did a GATA3, the reason being, because I was seeing those single file pattern. Isn't it good female patient, could be from breast lobula. Then we did a CDX2. So this becomes now your probably a gastrointestinal primary, isn't it? But there was no lesion in the gastric per se. Then 3 months later, we got a biopsy from stomach, and we saw this tumor has plenty of those signet ring cells, probably which were missed at the PET, at the CT, and probably in the endoscopy as well. But the tumor was actually CK720 negative, though the primary was 7 positive. But CDX2 was strong. We attempted a P16 to rule out if it could be a cervical primary, but P16 was not diffuse block, so we did not consider this negative staining. Then again, we revisited the PET scan again and again, and we went to the PET scan person, sir, please try to find out if patient has one. And what to our surprise, we found that he missed this uptake initially, which was present. And for this, the patient had initially been treated as a cervical primary. So my request to all of us present here, please, 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 when you're seeing this signet ring cells, be very careful and guarded and think metastasis first, irrespective of what. whatever you think of it, irrespective of radiology, your clinician will try to convince you, will sit on your head, but please stick to whatever you're thinking. So final diagnosis was signet ring cell carcinoma of gastric, which was involving ovary and cervix. So with this, I would like to thank everyone for your kind attention. So
Thank
any
you,
questions?
Dr. Biswal, for such a wonderful presentation, very enlightening slides, very informative, and day-to-day, it solves problems of day-to-day reporting. Anyone has any questions on to the speaker?
Good afternoon, ma'am. First of all, I would like to thank you for the excellent presentation. My question is regarding the mural nodule that you mentioned. Is there any specific immunohistochemical staining pattern for the mural nodule, or it is just a morphological diagnosis?
No, it's totally a morphology diagnosis. Suppose you are getting a sarcoma component, it's not going to help you in any, whatever markers you put, it's going to be sarcoma anyway. But in those cases, you will have a differential of carcinosarcoma is one of the
Carcinosarcoma.
differential. But you have to see those nodules formation. It is not as a sarcoma infiltrating here and there. It has to be in the
Just
form
in the
of a
form of
nodule.
nodules, not continuous with the tissue.
Yes.
And any size
Now,
criteria as
I
such?
have mentioned it. So it can be very a small sub-centimetric to up to 10%. So size is not again a criteria to call.
Thank you, ma'am. Understood. Thank you.
Okay, thank you. We are running out of time. We still have two more speakers in very short time.
Thank you
very
so much.
Next, now I would like to invite Vinny Siang. I hope I got the name correct. General Manager, Shenzhen New Industries Biomedical Engineering Company from China, to deliver her talk on why Meglumi is the gold standard in immunoassays.
Okay, so why? Namaste. Namaste, everyone. I came to know that it's Mr. Biwal. It is his flight is delayed, and fortunately, I had to share one news for you. That is, my flight is landed on time last night, but my luggage is missing. It's still in Hong Kong, but luckily I'm here. And namaste, and I'm very happy to see you, everyone here. And it is also my great honor to introduce my company to all of you. So actually, this is me. I took this picture in the hotel. And let's see, that is our company. It is we have a long name of that is it is Shenzhen New Industry Biochemistry Engineering corporate. We call it STARP, and there's another meaning, that is start new innovation and be excellent. So SNAP has established itself as a leading company for more than 3 decades, and we are pioneer in chemiluminescence immunoassay technology, and having achieved numerous milestones over 3 decades. So let's, behind this gold standard of our legacy of excellence, let's explore the company driving those advancements. So our global footprint is impressive. That is with over 37,000 units installed across 116 countries. Snap has continued to expand its reach as well, and our rapid growth reflects the trust placed in us by the healthcare provider worldwide. And this growth would not be possible without our commitment to quality and innovations. So actually, the Mill State tells the stories, and founded in 1995, Snap launched its Chinese first fully automatic clear analyzer in 2010, and since then we have been at the forefront of innovations. In 2017, we became the first Chinese company to receive the FDA clearance of our clear products, as not only both the analyzer as well as the reagent. Additionally, in 2022, SNAP has recognized as the first Chinese clear manufacturer with all C list A marked for our HPV, HCV, and HIV assays.
So since SNAP has offered a diverse range of clear analyzer, including we can meet various laboratory needs from the large scale system like Maglumi X6, Maglumi X8, and Maglumi X10s. So and also we have the concise one that is the Maglumi X3 and M800. So we applied flexible options that simplify the lab operation while ensuring the high performance. SNAP is number one in China to get FDA clears with clear products, and our Maglumi X3 and the M2000. This is our Maglumi, who both of our analyzer, we have the FDA clears, and this is the Maglumi X3, and this is Maglumi X6, which we came in from last year. It's a newcomer in this country. And this is our new product, which will be coming in the end of this year. It's the Maglumi 10 with the throughput 1,000 tests per hour. It is the fast clear analyzer in the world. And we also we would like to, beside this, Biolumi CX8, CX10. It is also popular all over the world. Most noteworthy things that our TLA system, including, although this product has launched, this is our TLA system. Although this product is launched only last year, but right now we have more than 100 units has been installed worldwide. Our business segments are mainly about 6 parts, for covering various sections of clinic, lab, diagnostic, comprehensive, meeting different diagnostic needs. So actually, we are very proud to see that is our clear test manual includes very extensive list of more than 256 parameters. Those reagent kits are competitive with all of our analyzer and features integrated system designed for ease of use. And at SNAP, we continuously strive to improve our products as well. Our second generation's reagent offers superior performance compared to the first generations. Key improvements like more quality control level, extended stability, longer shelf life, and broader research on reference range, and reduced sample consumption for certain assays. And our reagent kits are compatible with all analyzers. No need to pause for the reagent loading and unloading. So to demonstrate that is the excellence of our new generation reagent compares to the competitive method, that is other brand used, our sandwich method could achieve results more sensitive and precise with a wider linear range. Here's the three, you can see there's 3 comparisons result with the golden standard LS and MS. And you can see that SNAP vitamin D result has a better relation than other brands. So also it is highly consistent with the DACRIS result, indicating that our RBD product has excellent performance. So quality is paramount, and since we are the first one in China to get FDA clear of our products, and furthermore, we have numerous certificates such as CE List A. You can see that is the CE List A for the HIV, HCV, and HPV, reinforce our delegation in delivering top-notch diagnostics. And we are happy to see that in 2023, we are the number 1 to get the first IVDR CE certificate in China, even in Asian countries. So this certificate underscore our adherence to international standards and position us as a leader in diagnostic innovations. SNAP focus on quality management system and receive ISO, CE, and EMS and free sales certificate. As well as we cooperate closely with third parties, organizations like Biorex, Brandux to validate our assays, being the first in China to offering assigned value in the official IFU demonstrate our commitments to transparency and reliability. And participating in external quality assessment program like DECAS to ensure our assay maintain a consistency and accuracies. So we have seen with patent acts exceeding 215 globally, SNIPE's innovation are protected and recognized international. Our cooperation with renowned doctors and publication of reference papers in top juries highlight our contribution of advancing medical service. In our country, also here comes the popular favorite part of me. In our country, so there's also 70 articles published since 2019. We also highly appreciate a lot of professors like Dr. Vijay, Dr. Robin, or Dr. Mathabs to work with us. And also SNIPE is welcome to work with all the professors with proposal for any research cooperations. We are welcome to. And you can link us at any times. And this is our project manager who can help you to have more cooperation with you. He can help you to have more cooperation chances with us. We are open to this kind of cooperations. And like we mentioned, there is SNIPE actively participate in global exhibitions and conference showing our products and expertise. From Euromed and IFCC and our presence spans continentals, reaching customers in diverse regions such as Pakistan, Dubai, Brazil, and Algeria. And our end user spans multiple countries with installation ranging from small clinic to large lab. For instance, we want to have one example that is we want there's 18.7 units of Meglumi X8 is working in this one lab. You can see that is how big this lab is. So also in Nepal, SNIPE has maintained a very strong presence for over 14 years. So highlights including launching fully automatic biochemistry system, appointing dedicated service engineer, and introducing our ultra-high throughput analyzer, our partnership with trusted installation like Lumbini, Yes, this is the milestone, or that is we enter in this market. And we like to say that this is our manager locally, Krishna. And I think a lot of you knew him. And this is our Mr. Mukesh, and there is our golden service engineering. And you can see that we have attended a lot of conference and as well as a workshop in this country as well. And this is some of our end users showing, like Lumbini, like Biraj, and like Hitoda and Kanti Children's Hospital. And in end, we want to have one conclusion that is, why should choose our SNIPE, our decades of experience, advanced separation and labeling technologies, powerful platform, and original manufacturing capacity set us apart. So backed by ISO certification, comprehensive service, and proof EQA results, SNIPE guarantee fast response to market feedback and maintain FDA clearance standards. So as we continue to innovation and lead in global diagnostic fields, SNIPE remain committed to being the pioneers in providing reliable and cutting-edge solutions. Together, let's shape the future of health diagnostic. Thank you a lot for your attention. Thank you. And actually, I have one small question. Do you know my company name and the motto of our name? Even the short name is also okay. My company name.
Thank you very much.
Anyone knows?
I think there'll be many doubts and questions to be asked, but due to constraints of time, maybe we'll keep it for the lunch hour.
Okay,
Thank you very
I have
much.
to say again, that is my company name. It is Knife. It is the short name. It is Knife. News. It is and also the motto of our company name. It is start new innovation. Be excellent, just like you. Thank you.
Thank you very much. Next, I would like to invite the final speaker of the session, Dr. Ankur Lat, who will be speaking on next generation morphological analysis in hematological malignancies. Dr. Lat has over 17 years of experience in various hospitals in India. He is also a technical support for Horiba India Airmed Pathology New Delhi, Must and More Diagnostics, and many, many more. His special areas of interest are hematology and cytopathology, and I think at present he is affiliated to JN Medical College, Wardha. Please.
Yeah. Uh, Thank you, ma'am. Thank you for the generous introduction. Good afternoon, all. I will not restricting myself to morphological analysis, but I will be also talking about AI and digital morphology, machine learning in the hematology and in the laboratory. So, if you see in every field, digitalization is going a big way, especially if you talk about the radiology. Most of the things are being done on digitalization, and AI is supporting in a big way. But as far as pathology is concerned, like some part of the pathology, maybe like breast, prostate, and all, digitalization is there, AI is there, but hematology still there is a lot of scope, and digitalization is, I will say, due in this field. So let me start with the analyzer. Analyzer has gone through a revolutionary change, right? From 3-part to 5-part, and nowadays we call it 9-part. And we will see in the coming slides how it helps in the hematological malignancy. Similarly, parameters of the retic or reticulocytes, RBC, microcytic percentage and macrocytic percentage, in platelet, optical platelet, IPF, LPF, these things have revolutionized the, I will say, laboratory or hematology. Yeah. So when I say 9-part, it means apart from normal parameters like, neutrophil, lymphocyte, monocyte, basophil, eosinophils, now analyzers also come with immature granulocyte, immature monocyte, immature lymphocytes, atypical lymphocytes. So all these conclusive make it 9-part. And these parameters to a great extent can help us in diagnosing many diseases and hematological malignancies also. So utility of MIC. So till now we know HB can be low or high, or MCV can give us some idea. But I just ask you a question. If they are like 10% microcytes, 10% macrocytes, then what will be the MCV? It won't give you exact idea about the type of anemia. But when you get to see the exact percentage of microcytic or macrocytic RBC, you know what kind of anemia is there. And it can directly tell you what treatment should be started. Yes. So in this case, I can clearly see there are all the parameters, and the monocyte percentage is 79% and immature monocyte is 16.6. So by just seeing the picture, and if you know how to see the scatter, you can clearly say that this is a case of acute leukemia and maybe monocytic type. So nowadays, an analyzer has come such a long way. They can also tell you the typing of hematological malignancy, or I will say the stage of grading of the malignancy. But if I talk about this thing, one thing has to be very clear. Apart from the number, we all have also to see scatter plots. Usually we don't give importance to the scatter plot, but let me tell you, scatter plots are very important. And once you are familiar with your analyzer with the scatter plots, most of the diagnosis won't go wrong with the number, whatever number is being shown. Similarly, if you know to see the scatter, you will see that all the cell lineages are increased. So we can say it's a case of maybe CML, right? Similarly, this is an area which is showing lymphocytes. So this area is scatter plots is increased. So it's a case of ATP, I say some kind of lymphoma, and lymphocyte percentage 87.6. Similarly, atypical lymphocytes are 10.2. So that was about the WBC. Now let me tell about the retic. You all will agree with me. Retic is the most important, but the least what's a privileged parameter in any laboratory. Due to inter-observers variation, due to poor staining, most of the time retic is not reported correctly, right, ma'am? It always happens with the retic. And we are, trust me, we are underutilizing this wonderful parameter called reticulocytes because we are restricting ourselves to reticulocyte percentage. But you will see nowadays retic comes with the retic low, retic medium, retic high, CRC, that is corrected reticulocyte count, MRV, immature reticulocyte fraction, RHCC, reticulocyte hemoglobin cellular concentration. These are such a wonderful parameters. This can give you result or this can give you idea about many diseases, even like how to monitor the diseases, what is the reaction, what is the, everything can be monitored by the reticulocyte if we know what are these parameters. I won't go in details due to the constraint of time, but you'll see that immature reticulocyte alone parameter has such a wonderful application. Like it can monitor anemia therapy, transfusion, EPO, bone marrow recovery. These all can be seen by this immature reticulocyte parameters. Yeah. Now the RHCC, many analyzers report it as a reticulocyte equivalent, but we call it reticulocyte hemoglobin cellular concentration. This gives you exact hemoglobin concentration of the reticulocyte. And this parameter can tell you anemia before anemia develops. That's the beauty of this parameter. If you know how to utilize, this can go to a long extent. Body fluids. Of course, you all know many body fluids demand a pathologist to report it immediately. But of course, pathologists can't be expected to be there in 24/7 in a laboratory. Parameters like CSF and all. So nowadays, analyzers are well equipped with these parameters. That they can tell you exactly like mononuclear cell count, polynuclear cell count. They can tell you the WBC percentage, and they can tell you the RBC count. So any body fluid can be reported immediately and with much more accuracy. So that was about the analyzer. What I was talking about the analyzer was Horiba YS2500, which comes with all these retic parameters, which come with LPF, which come with all the immature cells. Now coming to the digital morphology part. So first of all, why we need digital morphology in hematology? There is always a problem of inter-observers variability. Whenever we talk about the normal slide review, there is problem of traceability. We are not able to locate the cell many times. There is problem of storage, right? Sometimes it requires immediate reporting. Sometimes TAT is the problem. So all these parameters need digital morphology. And most important, when every field is going into digitalization AI, why not hematology or why not our hematology science? So these things, but when we talk about the digital morphology, there has to be many things associated with it. Like it has to be optimized algorithm, there has to be training, there has to be validation, slide image has to be proper. There are many requirements of the digital morphology system. But again, what's the clinical use? What's the application? And of course, ethic should be there because when you are reporting from distant digital morphology, many criteria are required which should be met. So as like we all have some slide review criteria in our laboratory, like for WBC, for platelets, for RBC. Same there has to be a proper criteria for the digital morphology system also. This criteria can vary according to the land, according to the area, according to the medical board. but some criteria are necessary for this system also. For example, selection of sample to be digitalized should be based on the rules. Always reconcile the flags of the automated analyzer when you are talking about the digital morphology system. Slide and staining should be proper, and in the presence of abnormal cells or in the pediatric sample of lymphocytes, size, thickness, color lead to incorrect identification. So of course, it's also not a perfect science. So these things should be kept in mind before going for the digital morphology system. So basically now, what is digital morphology system? We all talk about we want advances. So if I have to explain this in one line, it has to be digital microscopes built through scientific innovations and technological advancements and integrated with sophisticated algorithm used for interpretation of images. So this is the definition of digital morphology system. So there is a system called Lumisen D20, and I call it one of the most unique systems in the world. And why is it so? Because this system reports both hematology and urine on the same instrument without any reagent, and it's completely based on the AI. So you don't need anything apart from the slides or cartridge, no reagents, nothing is required, and you get the result of all kind of WBCs, complete lineage, RBCs, platelets, even malarial parasite and urine. So how does it work? So this is, first of all, let me tell you, this is a cloud-based. What's the advantage of being cloud-based? Cloud-based means you can report it anytime from anywhere in the world. That's the beauty of this system. And like half part of the work is done by the instrument and half part of the things are done by the cloud system. So when you put the slide, pre-scanning is done, image capturing is done, WBC, RBC, platelet extraction is done, and then the whole thing is sent to the cloud where the library is there, cell classification is done, reporting is done, and that's sent to your system. And you can report it within few minutes. You are sitting anywhere in the world. That's how it works. So this is first case. So let me tell, when I talk about the WBC, you have an option of, if you want to count 100 cells, you want to count 200 WBC, or you want to count complete 120 field of vision, you can choose those depending upon the number of the cells are present on the slide. And it gives you right from the like blast, promyelocyte, myelocyte, metamyelocyte, band cell, complete lineage of the WBC. So if you see this system, you can clearly see if they are blast. Let me tell you this case, 50-year-old male presented with bone pain and organomegaly. So analyzer gave 24% large undifferentiated cell, and D20. This system reported blast percentage maybe somewhere around 50 or 60%. So this case was given as a case of acute leukemia. So again, this is a beautiful case. I don't know. I'm sorry if you are not able to appreciate all rods, but these systems are so correct, so accurate. You can also appreciate all rod. And if you have seen the all rod cells on the slide, then I don't think there should be any hesitation in reporting like provisional diagnosis of acute leukemia or anything. So this is the beauty of this system. So again, it's a case of blast lymphocyte. So now we talk about the concept of CBC to CVP. Earlier we used to sell, we all know CBC, but what is CVP? It's complete blood picture. So now you can integrate your any analyzer with the digital morphology system, and apart from the routine parameters of the analyzer, I was just taking 1 minute more. Routine parameters of the analyzer, you will also get the complete differentiation of your WBC, what the manual reporting done, with the evidence-based reporting. All pictures you can have it here. All kind of WBC, RBC, platelet, or anything. So like when we talk about this integration, automation, so what's the advantage? And if I have to tell this in nutshell, it should be standardization, system automation and optimization for advanced hematology laboratory workflow, image incorporation, traceability will be there. You can store it for like indefinite period, cellular digital history. It can be used for the teaching purpose. You can send these images to any pathologist to just verify if the system has reported correctly. And the most important thing is the TAT. So we sometimes we fear isn't going to replace pathologist, but of course it's not. It's just a tool. You have to use it So it's always the man behind or woman behind the machine who matters most, not the instrument. So let's embrace automation and digitalization. Thank you.
Thank you, Dr. Ankur, for a nice presentation. Because of shortage of time, we won't have any questions. So with this, we'd like to conclude the scientific sessions and thank all the presenters for nice presentation. Thank you.
And with that, we bring this rich and insightful session to a close. A warm thank you to all the distinguished speakers for their valuable time, effort, and special thanks to our honorable chairpersons for an excellent moderation. Now, I would like to take a moment to recognize and thank our distinguished speakers for their valuable contribution. For that, I would like to invite our honorable chairpersons, Professor Dr. Geeta Sayami and Professor Dr. Mamta Lake, ma'am, to kindly come forward to present the certificate and token of appreciation to our distinguished speakers. May I call upon Dr. Rupanita Biswal on the stage, please? Please give her a big round of applause. Now, I would like to request Dr. Rosen Gimire, General Secretary of ACPN, to receive certificate and token of appreciation on behalf of Dr. Manohar Pradhan. Let's show our appreciation with warm round of applause. Now, I would like to call upon Professor Dr. Smriti Karki, Head of Department of Pathology Department in BPKIHS, to hand over token of love to our honorable chairpersons. Let's give a huge round of applause. Thank you, honorable dignities, for gracing us with your presence. Now, I would like to request President of ACPN, Professor Dr. Abhimanyu Jha, from the organizing committee to hand over the memento and certificate of appreciation to our speakers from the sponsor side. May I humbly invite Dr. Deepa Nevnani on the stage, please? Can we have Miss Winnie Jeong? Please give them big round of applause. Dr. Ankur Lath, can we have you on the stage, please? We want to extend our heartfelt gratitude to our sponsors for their valuable support. Your applause is a small token of our big appreciation, so let's hear it for them. If you stop learning, we are dying. So stay alive and keep learning. So enjoy your lunch, which is being served at the main hall. We will be rejoining in about 50 minutes. Please kindly collect your registration certificate from the registration desk. Thank you. Can we have Winnie Jeong on the stage? Somebody from the SNI? Sorry. On behalf of Winnie Jeong, representing SNI, please give them a big round of applause. Enjoy your lunch. Thank you.
Good afternoon, everyone. I hope you've all had an engaging and enlightening time so far and also a filling lunch. I'm Dr. Chetna Nihure, and it's my honor to welcome you to the third session of our day-long conference. We have already witnessed thought-provoking discussions and valuable insights throughout the day, and this next session promises to carry the momentum forward. So now, ladies and gentlemen, uh, it's my distinct honor to welcome our esteemed speaker to the stage. Please join me in welcoming Dr. Jeffrey Susilo, Senior Regional Medical Scientific Liaison at Sysmex Asia Pacific Private Limited. And also, I would also like to notify that this is going to be the virtual presentation since Dr. Susilo cannot make here today with us due to some reasons. So I would also like to invite Mr. Kusal Shrestha on behalf of Dr. Susilo and Sysmex Private Limited.
Thank you, ma'am. So I'm Kusal Shrestha from Chamunda Training House, and I'm here on behalf of Dr. Jeffrey Susilo. And my deep sincere apologies because he couldn't be here physically today, but he has sent his presentation, which will be played shortly. So after the session, if there is any question or queries, you can contact us so that we can deliver your questions to Dr. Jeffrey Susilo, and we'll address your questions. So thank you.
My name is Dr. Jeffrey and Senior Medical Scientific Liaison of Sysmex Singapore. Today, there is a pleasure of Sysmex and also better solutions on the problem. I do offer basically manual design around first kind of sequences. So this is a what we talk about the as a lot of you know, especially those who are users, the extent is the pros and cons. But the very least what we're looking for in terms of the cells that we use the response, cell complexity, as well as the content that are represented as stores and manufactured cells in the society. Apart from that, of course, we do have kind of solutions for people expand things and now, example, there's all some set which requires additional ingredients and kind of tell if you highly specific but driving results as well as the ability to identify and evaluate medical success. So today, I probably focus on the academic reason, which requires one, as well as the which is available. Now, the academic reason is quite important to support the critical innovation. Now, more and more patients are looking for medical capabilities now, the method is HPC, that is certainly faster, cheaper, and also less expensive than including central innovation within the and the principle by which HPC is graduated from the drug, we set stem cells with cells size again, certainly the language to take number of people within the cells individually as well. And Dr. Peter uses certainly using the saving on those. But as mentioned before, it is especially trading and one. Now, this is where the extended PC eventually comes in, because the quite a result in investment is exactly the results on with secret before information in the book. So once the platform for the series of these which should be used to do the and then for the institution, the patient that have the medical activities. The theory that is process, the level is separated and collected into a practice. And before the practice provides very much profit back to the patient across the certain sufficient number of the cells using everything that energy or energy. So we are currently on the friends of the TT and as you can see here, this is almost 250 times and some of these for clearly there's others very complex as you can see here, on the the second, the root exploration to XMPC and really cells where we can do all these those regions with the former to do for those who are put at the second, the process itself, there was also very and really to 7 years with an R value range from 0.93 milligrams to 0.95 all the samples during the consideration. Another international study was published next door to show that including the 7 activities NFPC had excellent relationship with secret site innovation with an R value of 0.96 when you can see very ours very much was allocated NFPC had also quite similar to the of the center, nonetheless, the secret pieces actually needed almost so we see it for 97, but that's the issue of the 8% and that's something else is done. You can see that the performance was really quite high. These are the support abilities that we
On behalf of On behalf of all the participants and organizing committee, I would like to extend our heartfelt thanks to Mr. Jeffrey Susilo and Mr. Kusal Shrestha for his engaging and insightful presentation on the work of Sysmex Asia Pacific Private Limited. And before commencing the session, I would also like to invite Professor Dr. Abhimanyu Jha sir to distribute the certificates of life members. Sorry. I would like to invite Dr. Rakesh Pathak sir to distribute the certificates of life members. And the members are Elena Bosnet, Kavita Devi Baral, Miss Elena Bosnet, Kavita Devi Baral, Safal Yadav, Srijana Khati, Pradipta Gautam, Anjani Sakhya, Arju Dio, Karisma Ghimire, Bipin Maharjan, Priyanka Kaistha, Supriya Shrestha, and Srijana Koirala. Last program. Thank you so much, sir. As we now are already on the third session of this enriching day-long conference, it gives me immense pleasure to formally commence this session by introducing and welcoming our highly esteemed session chairs, two individuals who have significantly shaped the field of pathology in Nepal and beyond. Please join me in welcoming Professor Dr. Abhimanyu Jha sir, currently serving as the Assistant Dean at Institute of Medicine, Tribhuvan University, and the reigning President of Association of Clinical Pathologists of Nepal. With a distinguished career spanning over 2 decades, Professor Jha has played pivotal roles in shaping pathology education and practice in Nepal. His past affiliations include serving as the head of Department of Pathology at TU Maharajganj, General Secretary of ACPN, Executive Member of SATS, and Joint Secretary of the Nepal Medical Association. He is particularly known for his expertise in musculoskeletal pathology, with a special focus on bone and soft tissue tumors, and has made the substantial contributions in cancer diagnosis and academic research. His impressive academic record includes over 50 publications in national and international journals and numerous specialized trainings in dermatopathology, immunohistochemistry, and multidisciplinary cancer management. He has also conducted and participated workshops like Train the Trainer for Multidisciplinary Cancer Management to practical training in Department of Molecular and Environmental Pathology, and it is truly a privilege to have such a distinguished academician and pathologist chair this session. So please join me in welcoming Professor Dr. Abhimanyu Jha sir. Ladies and gentlemen, it is now my immense pleasure to welcome our second chair for this session, a highly accomplished pathologist whose dedication to cancer diagnostics, molecular pathology, and research has made a profound impact in Nepal and beyond. Please join me in welcoming Dr. Hari Prasad Dhakal sir, currently serving as the Senior Consultant Pathologist and Head of Department of Pathology and Laboratory Medicine at Nepal Cancer Hospital, Harisidi Lalitpur, and Coordinator of IRC Accreditation Subcommittee, Nepal Health Research Council. With over 29 years of professional experience, Dr. Dhakal has esteemed positions including former head of department at BP Koirala Memorial Hospital, Bharatpur, and has worked internationally as a medical advisor and fellow at the Norwegian Radium Hospital. He has also completed a post-MD fellowship in pathology from the University of Granada and post-MD pathology fellow in Cleveland, and has also uh, earned his PhD in breast cancer from the University of Oslo, Norway. So Dr. Dhakal is leading expert in cancer diagnosis, molecular pathology, prognostic and predictive markers, tumor biology, and cancer prevention. He is also life member of Nepal Medical Association, Association of Clinical Pathologists of Nepal, and fellow and life member of Union for International Cancer Control. We are truly honored to have such a distinguished expert chair this session. So please join me in warmly welcoming Dr. Hari Prasad Dhakal sir to the stage as our chair.
Thank you very much for such a nice words. Actually, a student. Let me tell you, I'm still a student in biology and pathology. So I'm still learning. I'm here about the session, learn something. Yeah, I would like to thank ACPN to give me organizing committee to give me this opportunity to chair this session along with our esteemed Professor Dr. Abhinay Jha, our ACPN president currently. Thank you very much for for having me to chair this session along with Professor Dr. Abhimanyu. Without delay, I would like to, we have 5 case presentation speakers presenting here. I would like to invite first presenter, Dr. Srijana Khati, who will talk on a rare case of cavernous lymphangioma arising from uterine corpus and presenting as pelvic mass. Dr. Khati.
Good afternoon, respected chairperson, my professors, my colleagues, and my dear juniors. I am Dr. Srijana Khati, currently working as a pathologist in Pokhara Academy of Health Science. It's my privilege to present an extremely rare case in female genital tract, which we have encountered during clinical practice in Tribhuvan University Teaching Hospital. Hereby, we present a case of 55 years old postmenopausal woman who presented in gynecology OPD with complaints of intermittent dull abdominal pain for 5 years, increased urinary frequency for 2 years, and palpable abdominal mass for 1 year. For abdominal examination showed 12 into 10 centimeter mass extending from suprapubic region up to umbilicus. Ultrasonography revealed bulky uterus with a 9.2 into 8.5 centimeter lesions on the left lateral side, displacing the uterus superolaterally and suggesting a subserosal fibroid. Her other blood investigations and tumor markers were negative. Based on clinical findings, abdominal examination, and radiological findings, clinical diagnosis of uterine fibroid was made. Then she underwent total abdominal hysterectomy and bilateral salpingophorectomy, and the resected specimen was sent to our department for histopathological examination. This is what we have received in our department. It looks a bit different than the usual uterine fibroid. Uterus showed a large intramural mass. Cut section of that mass showed gray-white, soft, spongy area. There were no any other form areas or areas of hemorrhage or necrosis. So what is it? Is it fibroid with cystic degeneration? Or is it myxoid leiomyoma? Or is it something more dangerous like sarcoma? Then we observe the tumor under microscope. Okay, this is a low power view of the intramural mass. Here we can appreciate plenty of dilated cyst-like spaces. At 100x, we can say that cyst-like spaces are lined circumferentially by some kind of flattened cells with intervening septa composed of smooth muscles, fibrocollagenous tissue, and lymphoid aggregates. This is a high power view depicting the cystic spaces with flattened cells and intervening septa with dense lymphoid aggregates. So with these histomorphological features, we can say that this is some kind of vascular tumor. But is it lymphangioma or is it hemangioma? So morphologically, there are no RBCs present in the vascular lumen, and moreover, we can see the lymphoid aggregates in the intervening septa. So morphologically, it is favoring more towards lymphatic malformation. And we can see the flattened cells circumferentially lining the vascular space, plus there are smooth muscles in the wall. So it is favoring more towards lymphangioma than lymphangiectasia. For further confirmation, we performed immunohistochemistry with D240. This is a low power view of the IHC performed. Here we can appreciate positive immunostaining in cytoplasm and membrane. With this, we finally sign out the report as uterine cavernous lymphangioma, lymphatic malformation as new terminology suggested by ISSVA 2022. So I went back to the literature to find out the prevalence of this condition in female genital tract. There was this article published in International Journal of Gynecological Pathology in 2025, which studied the spectrum of vascular lesions of the upper female genital tract. Among the 55 cases studied, 42 cases were benign. Maximum cases were in ovary with 24 cases and 11 cases in uterine corpus. In uterine corpus, there were 6 cases of arteriovenous malformation, 3 cases of venous malformation, 2 cases of cavernous hemangioma, and 1 case of mixed venous cavernous hemangioma. Here I could not see a single case of lymphatic malformation. So I searched extensively in literature to find out the reported cases of uterine lymphatic malformation. And these are the 4 cases I could find from 1960 to till now. The first cases was reported in 1960 in England by R. Salem in a 55 years old female who presented with irregular uterine bleeding. Thereafter, cases were reported in 2003 in Japan, 2014 in Canada, and 2018 in Turkey. With this, we can say that vascular lesions is rare lesion in female genital tract with less than 50 cases being reported till now, and it is much more extremely rare in uterine corpus. So talking about lymphangioma, it is an extremely rare female benign tumor in female genital tract. It can range from small asymptomatic lesions to large lesions which can mimic malignancy. It do not metastasize, however, it can infiltrate into the surrounding tissue. Lymphangioma can be congenital due to developmental malformations of the lymphatic system, or it can be acquired due secondary to trauma, infection, surgery, or malignancy. Talking about management, complete surgical excision is a primary treatment of choice. As in our case, total abdominal hysterectomy was performed to remove the tumor completely. However, this case is very rare, So individualized management with multidisciplinary approach is done. With complete resection, it poses good prognosis with very low recurrence rate. So main objective of presenting this case here is to enhance awareness and understanding to secure the accurate diagnosis so that we can contribute to the limited literature of this rare entity. So these are my references. Thank you.
Thank you, Dr. Sejana. It was really very interesting case. So next case is a trophoblastic pseudotumor mimicking malignant tumor. I hope this is a placental site trophoblastic tumor. I request our junior colleague and resident to listen this case carefully. May I call Dr. Susil Adhikari?
Uh, Very good afternoon, everyone. Honorable chairpersons, respected professors, senior consultant, teachers, and my dear colleague, myself, Dr. Susila Adhikari. So I am so honored and privileged to present at this prestigious conference under an empowering theme, empowering the woman else. So without delay, I would like to move with the case and through the case, I hope to highlight how knowledge, vigilance, and correct diagnosis can prevent the unnecessary interventions and safeguard the human health. So this was the case of 33 years female with chief complaint of amenorrhea for 5 months and abdominal pain and poor vaginal bleeding with passage of clot for 1 day. USC abdomen and pelvis showed bulky uterus with minimal hypoequic collections likely clot. VTSCG was not done, and in poor vaginal examination, there was OSS open and product of conception was failed. So with the provisional diagnosis of the primary gravida at 17th week of gestation with incomplete abortions, she underwent evacuations. So if you see in the microscopic features, we can see there are a lot of mosa sponder where there is infiltrations of intermediate trophoblast deep down into the myometrium. And there are few multinucleated cells as well. And in few area we can see these trophoblast are surrounding the blood vessels as well without distorting. So in a high power view, we can see the individual morphology of the cells. They are quite large with amphiphilic cytoplasm, round vesicular nuclei with few showing the prominent nuclei as well. So at this point, what we thought was, and in the section examined, there was no chorionic villi, there was no mitotic activity as well, and there was no tumor necrosis. So at this point, what we thought was, this could be the lesion that is arising from the intermediate trophoblast. It could be the placental site trophoblastic tumor, or it could be the choriocarcinoma because there was no, it could be the choriocarcinoma because there was no chorionic villi, or it could be the tumor-like lesion. So we planned for the immunohistochemistry, and if we see in the immunohistochemistry, the beta-OCG was negative, so we rule out this is not the case of choriocarcinoma. So the remaining possibility was either this is the lesion either arising from the chorionic type or the implantation site trophoblastic tumor. So we did the P63 and it came out to be negative. So we rule out this is not the lesion that is arising from the chorionic type intermediate trophoblast. So then we have the remaining, that is the lesion that is arising from the implantation site intermediate trophoblast. Either it could be the placental site trophoblastic tumor or it could be the exaggerated placental site reactions. So if we see the Ki-67 is usually nearly zero. The background stain is lymphocytes. So we conclude to the final diagnosis of the exaggerated placental site reactions. So coming to the discussions, in the past it was called syncytial endometritis. Recently the WHO has introduced the term exaggerated placental site because the lesion is non-inflammatory, is not confined to the endometrium, and the constituent cells are not syncytial. If you see in the 5th edition of the WHO classification, it lies under the heading of tumor-like lesions. And if you see the cells of origin is the intermediate troplas, other entity implantation site intermediate troplas, and other entity that arises within the implantation site is the placental site troplastic tumor. If you see the entity that arises from the chorionic type intermediate troplas are the epithelial troplastic tumor and the placental site nodule, and the gestational choriocarcinoma arises from the villus intermediate troplast. Though the pathogenesis of this entity is not well known, it just represents the extreme end of physiological process rather than the true neoplasm. Clinical features usually patient present, they are asymptomatic, we present with vaginal bleeding as in our case, and it is associated with normal gestations as well as the identiform mode. Site is usually uterus. The diagnosis of this entity is usually based on the histopathological examination because this is the lesion that is non-mass forming lesion. So radiology and the microscopic features will not help out. If we see, these are the reference picture taken from the book. We can see the muscle fibers, and there are presence of multinucleated and the mononuclear intermediate tropoblasts. These multinucleated cells are the degenerative intermediate tropoblasts as well. High power view, you can see the individual morphology of the cells with many nuclear irregularity as well. However, there is no mitosis and the necrosis. So diagnosing this entity in curettes alone is quite challenging because there is the knowledge gap of tropoblastic invasions. Till now, there is no definitive data on extent of intermediate tropoblastic invasion. So histological thresholds are still not well established. If you come to see the differential diagnosis, the first one is the placental site troplastic tumor. It is the tumor that is arising from the implantation site. However, the pattern of invasion is confluent cysts with splaying of the muscle fiber, and there is increase in the mitotic activity as well as in the Ki67 proliferative index. If we see the choriocarcinoma, it is the biphasic tumor with mononuclear and the multinuclear syncytial troplast. However, there is presence of lot of mitosis, including atypical form, as well as the necrosis and the hemorrhage as well. If we see the ETT and the PSN, these are the tumors that are arising from the chorionic type. And the characteristic of this tumor are they are well circumscribed and with presence of the hyalinized extracellular matrix. And one characteristic features of ETT, epithelial troplastic tumor, is re-epithelializations of the endocervical and the endometrial surface. Sometimes can mimic the S-cells of the squamous cell carcinoma of the cervix as well. So there has been published cases. Absence of the chorionic villi in the histopathology sample does not rule out the diagnosis of the APS. So histopathology sometimes can be insufficient. So there is the three-triad stepwise algorithm. First, we have to confirm whether the lesion is tropoblastic or not with the help of HSD3B and the low molecular weight cytokeratin. Once it is confirmed that it is the tropoblastic lesion, we have to do with the beta SCG. If it came out to be positive, it is the case of the choriocarcinoma. If not, whether the lesion is either from the implantation site or the chorionic type, we have to differentiate it with the base of P63 and the non-placental lactogen. And ultimately, the benign entity can be differentiated with the malignant counterpart with the help of Ki67 proliferative index. Treatment of this entity is simple. Curettes and endometrial ablation is curative. No follow-up is required. Prognosis is excellent after the curettes. So coming to the conclusion, exaggerated placental site is a benign tropoblastic lesion without any risks of persistent gestational tropoblastic disease. However, the awareness of this rare entity is essential as it must be distinguished from other lesions because the management and the surveillance of this entity from the other two neoplasm is quite different. So more literature and the documentation of the cases are required as to establish the criteria for diagnosing this lesion confidently based on histology alone. So take home message from this case is reporting APS boost awareness among clinicians as well as among pathologists and prevent unnecessary intervention. So accurate diagnosis is essential. If I see this case, I have two scenarios. One is if I diagnose this case as the two neoplasms, patient would have to undergo unnecessary surgery for the PSTT, or patient would have to get unnecessary chemotherapy for the choriocarcinoma. So on the other hand, if it was a true neoplasms and I keep on wrongly reporting it as the benign entity, I am leaving the malignant cells inside our body, and this can risk our life. So today's theme is empowering human health. So it's our responsibility to protect it by giving the proper care and giving the safe result. So continuous case documentation help establish clear diagnosis and management guidelines. These are my reference, and thank you.
Thank you, Dr. Sushil. You have presented very nicely. So just I want to add to your conclusion that you must remember at least this entity. If you cannot diagnose, if you remember this name of this entity, you will not make a wrong diagnosis, because sometimes you get this lesion as an incidental finding at unusual site like fallopian tube, like yellowish nodule. And if you are not aware of this entity, you will make wrong diagnosis of malignancy. Right? Thank you.
Let me invite Dr. Sion H. Limbu, who will be presenting tall cell carcinoma of breast with reversed polarity, a rare case with IDH1 R132 mutation. Very interesting case, of course. It reminds a morning presentation also talk where it was mentioned briefly.
A very good afternoon to one and all present here. I'm Dr. Sion Limbu, a recent MD graduate in pathology from BP Koirala Institute of Health Sciences. On behalf of my co-authors, I'm extremely honored to present this case entitled Tall Cell Carcinoma of Breast with Reversed Polarity, a rare case with IDH1 R132 mutation. Starting off with a little bit on tall cell carcinoma with reverse polarity. This entity has been added in the recent most WHO classification 2019 of breast tumors under rare and salivary gland type tumors. The nuclear polarity is reversed, meaning the polarity is apical rather than the usual basal polarity, and the tumor cells are arranged in solid nests and papillae. The clinical course is indolent despite its usual triple negative status, and often it is IDH2, there is IDH2 R172 hotspot mutation, whose importance is linked to targeted therapies, an area being explored in medical research currently with regard to various solid and blood-related neoplasms. Now, the case presentation, it is a case of a 72-year-old female from eastern Nepal, presenting with a progressively enlarging painless lump in the left breast since 1 month, with purulent, foul-smelling nipple discharge, and no history of trauma, weight loss, cough, and other comorbidities, or positive family history. On examination, the left breast lump was in upper outer quadrant, approximately 2 by 2 centimeter, irregular, formed to hard, non-tender, and immobile. There was no swelling in the contralateral breast and bilateral axillae, and the routine blood tests were within normal limits. The ultrasonography showed a hypoechoic mass in the left upper outer quadrant, and mammography showed an ill-defined, irregular, lobulated, radio-opaque lesion approximately 1.8 by 1.6 centimeter, So this is a radiographic picture of CT scan chest where we can see heterogeneously enhancing irregular lobulated lesion in fibroglandular layer having hypoechoic content within. Um, this is the sagittal view, and the axial view shows the same lesion which is irregular and lobulated. So ultrasound guided fine needle aspiration and true cut biopsy were performed at an external center, which was diagnosed as infiltrating duct carcinoma of breast in the fine needle aspiration, whereas in true cut biopsy it was diagnosed as invasive carcinoma of no special type with Nottingham score of 5. Simple mastectomy and sentinel lymph node biopsy were performed, and we received the specimen in our histopathology lab where we found that the lesion was poorly defined, gray-white to yellowish solid, and approximately 2.2 by 1.5 by 1 centimeter. This is the histologic picture. The tumor cells we can see are arranged in glands and tubules, and also few papillary architecture can be observed. And these architecture are further arranged in solid nests and lobules, and they are embedded in dense fibrous stroma. So on higher magnification, we can see glands and tubules, and some of the glands containing colloidal eosinophilic material within the lumen. And the higher magnification shows the tumor cells which are cuboidal to tall columnar, and the reverse polarity of nuclei can be appreciated, which means that the nuclei are oriented away from the center of the architecture rather than towards the center. And we can also appreciate some nuclei with grooving. So the nuclei showed bland features and showed mild to moderate atypia. The final diagnosis was tall cell carcinoma with reverse polarity with the TNM staging of PT3, and IDH1 mutation was identified in codon 132 instead of IDH2 mutation in codon 172, which is the usual finding. This test was done at the external center using PCR and sequencing. Multidisciplinary board discussion was held and radiotherapy was recommended. After 15 cycles of radiotherapy and 3 months of follow-up, patient is currently doing well. This is, although this tumor is usually triple negative, our case showed strong 75% estrogen receptor positivity, and we can also appreciate the reverse polarity at the periphery of this lobule. The progesterone receptor showed 25% moderate positivity, nuclear positivity. GATA3 showed nuclear positivity. Ecadherin was also positive, and CK5 and 6 showed mosaic cytoplasmic expression. So HER2 was, however, negative. Proliferation index was 10%. IDH1 showed immunopositivity. Synaptophysin was negative. Calretinine weakly positive, and P63 showed mosaic expression. So comparing our case with the Lay et al.'s cohort study of 81 cases, the largest case series as of 2024 with regard to TCCRP, we found the similarities in age, clinical presentation of palpable mass, maximum dimension of the lesion, and however, an uncommon finding in our case was the lesion irregularity, clinically, radiologically, and grossly. And also, our case was similar in histopathology features like papillary and follicle-like architecture, columnar cells, nuclear grooves, and pseudo-inclusions. So we have listed out all the cases with IDH1 mutations of breast carcinoma, and there are 8 cases, and 2 of them are TCCRP, including our case. So Wiseman et al. In 2020 and our case have been able to establish IDH1 and IDH2 dichotomy. So out of 8 cases, 5 cases, including our case, showed hormonal positivity. Now, a little bit on isocitrate dehydrogenase. This is a metabolic enzyme that catalyzes the oxidative decarboxylation of isocitrate to 2-oxoglutarate. However, if one of these enzymes is mutant, it gives 2-hydroxyglutarate, which is an oncometabolite, and that ultimately leads to tumorigenesis. So Wang et al. Has established a postulated a difference between IDH1 and IDH2 mutation. They have mentioned that IDH1 mutation could actually be an early event that leads to cellular stress, and that ultimately contributes to the subsequent mutations. However, IDH2 mutation is mutually exclusive with other mutations like P53 mutation, and they do not lead to the same secondary mutations like that in the case of IDH1 mutation. To conclude my presentation, we hereby describe an intriguing case of IDH1 mutant hormone receptor positive TCCRP. This case establishes the equivalence of IDH1 and IDH2 as markers of TCCRPs in the same way as that of many other tumors like glioblastoma and acute myeloid leukemia. It represents the second TCCRP with IDH1 mutation case and the first one ever identified in Nepal. It provides valuable insights for diagnosing and treating this disease, and it is essential for the clinicians and pathologists to recognize unique clinical and pathologic features of TCCRP to develop a standardized management approach. So future research using molecular biology techniques is needed to further categorize this distinct entity. These are my references. Thank you very much for your attention.
कुन थियो सजना दाहाल थियो हो कि ए होइन सो ओके थ्याङ्क यू डक्टर सियोन लिम्बू for very nice management of the time. So it looks like a papillary carcinoma of the thyroid. Okay, so our next presenter is Dr. Sajana Dahal. She will be presenting incidence of SIL in cervical biopsy of high-risk SPP positive women.
A warm good afternoon to respected delegates, professors, pathologists, and my dear friends. I am Dr. Sajana Dahal, pathologist from Civil Service Hospital. I am here to present on behalf, along with my co-authors from Civil Service Hospital. The topic for today's original article presentation is Incidence of Squamous Intraepithelial Lesions in Cervical Biopsies of High-Risk HPV Positive Women in Various Metropolitan Wards of Kathmandu. Shortly describing the background, cervical cancer and HPV. The primary cause of lesion is HPV infection. There are various detection methods like HPV test, cytology, biopsy that leads to precursor lesions, that is low grade, high grade cervical lesion, and the ultimate health risk leading to cervical cancer. So briefly describing pathogenesis of HPV, HPV E6 and E7 is the primary determinant that causes the HPV E6. This causes increased telomerase expression and it inhibits P53 activity, whereas HPV E7 It causes inhibition of P21 and RB gene. So these ultimately, it causes immortalization, increased cell proliferation, and genomic instability. This ultimately leads to LCL scene 1, subsequently to scene 2, scene 3, and cervical carcinoma. Methodology. The study design was a retrospective cross-sectional study conducted at Civil Service Hospital, and the target were women from Kathmandu metropolitan wards. This study was conducted over a period of 3 months beginning from April to June 2024. So methodology, first of all, sample collection. Samples were collected from various metropolitan wards via health camps of Kathmandu metropolitan wards, and cervical fluids were collected as samples. All the samples that were collected were sent to Civil Service Hospital Molecular Lab for PCR test, and then high-risk HPV positive cases, those underwent biopsy in various metropolitan wards, and those biopsy samples were again sent to the pathology department of civil hospital. After that, data entry was entered in Microsoft Excel, and data analysis was done through SPSS software. So these are the various metropolitan wards, that is 32 metropolitan wards from which the cervical samples were collected from women. So why Kathmandu? There are exploring opportunities in Kathmandu because centralized healthcare services is present. A large Saudi population can be taken from Kathmandu. It integrates the study that is done in Kathmandu metropolitan wards can be integrated into public health strategies. And lack of this kind of ward studies it has not yet been conducted before. So Kathmandu is a site for study. Objectives, the general objective is incidence of squamous intraepithelial lesion in cervical biopsies of high-risk HPV positive women in various metropolitan wards of Kathmandu. And specific objective is to evaluate HPV is to SIL ratio, to categorize the biopsy samples as negative, LSIL, HSIL, and to categorize high-risk HPV types, and also to identify the demographic factor such as age associated with incidence of SIL among high-risk HPV positive women. The results, out of 6,700 HPV tests, the high-risk HPV test was found in 322, from which the cervical biopsies were taken over a 3-month period, and it was accordingly distributed. So firstly, distribution according to age. According to age, the commonest age group was 31 to 40 years of age, followed by 41 to 50, 51 to 60, and then 21 to 30 years. Distribution according to high-risk HPV. The predominant HPV high-risk types was other high-risk HPV types, followed by HPV 16, HPV 18, 16 and others, 18 and others, and lastly 16 and 18 HPV. Distribution according to SIL, squamous intraepithelial lesion. So the commonest lesion was SIN 1, that is LSIL, followed by benign lesion, followed by SIN 2 and SIN 3. Distribution according to the benign category. The commonest category was chronic cervicitis, followed by chronic cervicitis with squamous metaplasia and endocervical polyp. So distribution according to high-risk HPV is to SIL. So here we can see that SIN 1 or LSIL, it is most commonly associated with other high-risk HPV types. That is 65% is associated with other HPV types, followed by HPV 16, 18, and others. And then SIN 2, HSIL, is also commonly associated with other high-risk HPV types, followed by HPV 18 and others HPV 16. And SIN 3, HSIL, is most commonly associated with HPV 16, which is also followed by other high-risk HPV types. These are some of the histopathological pictures. So first picture, we can see this is the LSIL lesion. So there is dysplasia involving the lower 1/3 of the full thickness of epithelium. In SIN 2, there is dysplasia involving the lower two-thirds of the full thickness of epithelium, and scene 3, it involves the full thickness of the epithelium. So, discussion, our study, it concluded that scene 1, that is in L-seal was most commonly associated with other high-risk HPV types. Scene 2, H-seal, was also most commonly associated with other high-risk HPV types. And then scene 3 was commonly associated with HPV 16. However, it was also followed by other high-risk HPV types. So there are certain studies, there are very few studies that is correlated with our study. So a study in China, it suggested that non-16-18 HPV infection was more common than HPV 16-18, whereas most studies conducted throughout the world and Asia also showed that the commonest HPV type associated with seal was HPV 16 and 18. That is, one study, this is conducted in Nepal itself, it showed 16, 18 were the commonest types. And a study done in Turkey also showed that 16, 18 were the commonest types associated. And a study done in Seattle, it also showed that HPV 16 and 18 were the commonest types associated with seal. So in conclusion, we can say that from our study, HPV 16 and 18 can represent as a tip of iceberg. That is, 16, 18 are the predominant types in other studies. Whereas, in contrast, in our study, most common HPV type was other high-risk HPV types. So, broaden HPV surveillance is required, broaden HPV vaccination programs is required, specifying for other high-risk HPV types, and genotypic categorization, that is, further categorization of other high-risk HPV types into specific genotypes is required. So these are my references. Thank you.
Thank you, Dr. Dahal, for a nice presentation. And really, it's an important area of research in our context, HPV high risk and others. Very interesting relationship in our context. So further, maybe you are going to undertake further research on this in future to
Yes, sir. We can further do study in other geographical areas of Nepal as well, because we have done in various metropolitan wards of Kathmandu, but we have to see that what are the studies and what can be the results that we can see in other parts of Nepal as well, because we have conducted this in Kathmandu. So if there are in other geographical areas also the similar result occurs, then we can add the other HPV types in the vaccination programs, further supporting the government. So that we have kept in mind, sir.
do you have any specific other area, other viruses, other HPV,
Yes,
which
sir.
is the most common among others? Have you seen
Sir,
that or still?
yeah, that was a drawback of our study as well, because in our setting, the other HPV types was not further categorized further. So we could not classify which other types were causing those squamous intraepithelial lesion and carcinoma. So that was the drawback of our study, sir.
It may be important for vaccination purpose also.
Yes,
Thank
sir.
you very much for your nice work and presentation.
Thank you, sir.
Let me invite Dr. Vibhuti Dahal, who is presenting hydathiform invasive mole of uterus, a case report. Please, Dr. Vibhuti.
Good afternoon, everyone. Sorry for the technical glitch. I'm Dr. Bhuti Dahal, working as a consultant pathologist at Parapakar Maternity and Women's Hospital. Today, I'm going to present the case of hyatiform invasive mole of uterus, which falls within the spectrum of gestational trophoblastic disease. We present this case not because it is rare, but as total hysterectomy specimen sent in view of invasive mole is an infrequent occurrence in our hospital, as this is the only second documented case where hysterectomy specimen has been sent in view of invasive mole in last 5 years period. Other cases diagnosed radiologically and clinically are treated with chemotherapy alone or with no surgical intervention. To begin with brief introduction, invasive hyatiform mole is a subtype of gestational thoracic disease where molar villi invade the myometrium and the uterine vessels. It is a possible sequelae of molar pregnancy, which is virtually always a complete hyatiform mole. However, a small percentage of partial mole also progresses to invasive mole. Pathological diagnosis requires demonstration of molar villi, which invades the myometrium or deported to extrauterine sites. When deportation occurs, the invasive hyatiform moles generally are found in lungs, vagina, vulva, or broad ligament. Herein, you can see the WHO classification of gestational thoracic disease, where invasive hyatiform mole is headed under molar pregnancy with ICD code of 1. Here, we discuss a case of 44-year para-2, living-2, abortion-2 female whose last childbirth was 21 years, presented in the emergency department of our hospital with a chief complaint of pervaginal bleeding for 1.5 months. On her recent past history, she had history of MBA done 7 months back. However, the histopathological report of the same could not be traceable. Since then, she has been bleeding on and off. She also gave history of suction evacuation done 1 month back for the radiological suspicion of molar pregnancy, and the histopathological report revealed complete hyatiform mole. And USC abdomen and pelvis was also performed. We showed heterogeneous area of size 44 into 29 mm with cystic area within the myometrium in a known case of molar pregnancy. And chest X-ray was also performed, which revealed fibrotic changes in bilateral upper lungs. Upon analyzing the sputum beta ICG trends on chart, on the day of admission, her beta ICG level was 268,000. Then she was planned for suction evacuation. Post suction evacuation, her beta ICG level had dropped to 128,000. 2 weeks after, when her beta ICG level was performed, the value was progressively declining. However, it was still higher than what was expected. So, in view of persistent high beta ICG level, the clinical diagnosis of persistent gestational trophoblastic tumor was given. Taken into account her age, which is more than 40, her completed family status, and her no desire to preserve fertility, total abdominal hysterectomy with right salpingopectomy and left salpingectomy was performed. The specimen was then sent to the pathology department of our hospital. The specimen consisted of uterus with cervix, which measures 9 into 7 into 4 centimeter, which was already cut open anteriorly. The endometrial cavity was 3.5 centimeter in length, which was filled with friable backus material with 0.2 to 0.3 centimeter thickness. However, no grape-like vesicle was identified grossly. On serial sectioning, myometrium revealed cystic cavity which contained brownish and hemorrhagic area measuring 1.8 into 1.2 into 1 centimeter. However, the extension into the endometrium was not identified. The cavity was 1.5 centimeter away from the lower uterine segment and 0.3 centimeter away from the uterine serosa. Microscopically, myometrial cystic cavity contained large area of hemorrhage with multiple hydrophic villi. The villi displayed trophoblastic proliferation with some showing cystone formation. Focal area revealed hydrophic villi directly over the myometrium. The trophoblasts showed moderate to marked atypia, some of which were even seen infiltrating between the myometrial fibers. This is the histological picture within the myometrial cavity, where you can see a large hydrophic villi with cystone formation with circumferential trophoblastic proliferation. This is another picture within the myometrial cavity, where you can see areas of hemorrhage and moderate to marked proliferation of trophoblasts. These two pictures are from other areas of the cystic cavity within the myometrium, where you can see hydrophic villi over the myometrium without intervening decidua. Also, moderate trophoblastic proliferation can also be seen in both the pictures. Subsequently, immunohistochemistry was also performed for P57, where you can see that decidual cells and intermediate trophoblastic cells stained positive for P57, while the villus stromal cells and cytotrophoblastic cells stained negative, which confirmed the diagnosis of complete hyatiform mole. So with all these findings, The impression of hydathiform mole invasive was given with the tumor staging given as T1, where the tumor is confined within the uterus. The patient was called 2 weeks after for first cycle of chemotherapy. She was given 3 more cycles of chemotherapy, that is, she received 4 cycles of chemotherapy by single chemotherapy agent, that is methotrexate. Post chemotherapy, she was followed up with her beta ICC values. As you can see in the chart, the beta ICC value was progressively declining, and her last beta ICC level was done 1 week back, which had reached to the non-pregnant level. The patient is now on monthly follow-up for next 6 months, and the patient is clinically asymptomatic. Now, briefly discussing the incidence of gestational chloroblastic disease, it varies significantly across the world, with 0.4 per 1,000 births in the United States of America. In Nepal, the incidence of invasive mole varies across different studies, which ranges from 2.8 to 5.1 per 1,000 deliveries. A retrospective study was done in Dhulikhel Hospital, where 65 cases of gestational chloroblastic disease were identified, with majority being hydathiform mole. The study concluded that in their tertiary care center, the prevalence of gestational chloroblastic disease was 4 per 1,000 deliveries. However, the specific number of invasive moles was not detailed in the available data. Similarly, another study was conducted at Patna Hospital over 5 years, which reported 54 gestational chloroblastic cases, out of which 8 were invasive moles. The study also found out that the overall frequency of gestational chloroblastic disease was 1 per 769 pregnancies. And the study conducted in B.B. Koirala Memorial Cancer Hospital, Chitwan, also identified 45 cases of gestational chloroblastic disease, out of which 6 cases were of invasive mole. Thus, the overall exact incidence of invasive mole is not consistently reported. However, this study suggests that it constitutes a significant proportion of gestational chloroblastic cases with varying frequency across different regions and healthcare settings. Now, talking about the behavior and treatment, invasive hydathiform mole is the most common form of persistent or metastatic gestational chloroblastic disease after hydathiform mole. It occurs 6 to 10 times more frequently than choriocarcinoma. The lesion is mostly confined to uterus, with distant spread occurring in 20 to 40% of the cases. The risk factor for invasive mole includes prior molar pregnancy, persistently high level of beta ICC, uterine size larger than gestational age, extreme of maternal age, that is less than 15 years and more than 40 years, and fecalital cysts. Approximately 15 to 20% of the complete hydathiform moles progresses to invasive mole. But in contrast, partial hydathiform mole has significantly lower risk of progression, that is, only less than 5% of the partial hydathiform mole progresses to invasive mole. Suspicion should be raised if there is persistent elevation or increased serum beta ICC titer following evacuation. The risk of progression of invasive mole to choriocarcinoma is similar to that of complete hydathiform mole without invasion. Now, talking about the differential diagnosis, choriocarcinoma is the first important differential where the both diseases can present after molar evacuation. They both can present with peritoneal bleeding and or elevated beta ICC levels, and sometimes with extra antibodies. Chorionic villi are absent in choriocarcinoma with proliferation of seeds of fibroblasts with extensive areas of hemorrhage and necrosis. And the important differential is placenta afflita, which is usually seen in term placenta, whereas molar pregnancies are characteristically seen in first trimester. The villi in placenta afflita usually do not show hydropic changes. They also lack problastic hyperplasia and atypia. So to conclude, invasive mole is a rare gestational chloroblastic disease that can be life-threatening. Those women who are at reproductive age Those women at reproductive age who present with abnormal uterine bleeding after suction evacuation should raise suspicion for invasive mole and warrants for the diagnostic evaluation. Although radiological diagnosis is the gold standard, histological study also helps to establish the diagnosis and identification of the spectrum of the disease. Early diagnosis of the disease and proper management strongly influence the outcome. Effective treatment and close follow-up are crucial for managing invasive moles. Even in disseminated cases, GTD can be cured. The prognosis is generally favorable with high cure rate following appropriate therapy. These are my responses. Thank you.
Thank you, Dr. Vibhuti. So I must appreciate the time management of all of you. Okay, all of you actually. So nice case, especially the gross finding was actually very nice. So thank you so much.
We now open the floor for questions and answer sessions. So please feel free to raise your questions and share your thoughts on any of the topics discussed. Kindly indicate your wish to speak, and our moderators will floating the mic on the floors. So do we have any questions? No? Okay, so I'm taking this as a no. So I'm moving further. So on behalf of the organizing committee, I would like to extend our sincere gratitude to all the speakers and case presenters of this session. Your thoughtful presentations, in-depth analysis, and willingness to share your expertise have made this session truly valuable. From cutting-edge research to practical diagnostic insights, your contributors have enriched our understanding and sparked meaningful discussion among all participants, from seasoned professionals to aspiring pathologists. So we look forward to many more opportunities to learn from your work in the future. So now, ladies and gentlemen, as we come near the conclusion of this insightful session, now I would like to introduce and welcome Ms. Anisa Bhandari to present on behalf of Techno Biomed. Ms. Bhandari currently serves as a member of the Global Health Committee of the Non-Resident Nepali Association and also contributes meaningfully as Community Coordinator at Sunya Health Solutions Private Limited. So let us look forward to learning more about their innovative products and how these advancements can support our work in pathology, laboratory medicine, and more. Please join me in warmly welcoming Ms. Bhandari to the stage. The floor is yours.
Thank you. Good afternoon, esteemed guests, healthcare professionals. Good afternoon, esteemed guests, healthcare professionals. It's an honor to address you all and everyone present over here. This is Anisha Bhandari from Technobiomed Private Limited. We are driven by our tagline, quality with our competence, a vision set by our founders who bring deep expertise in medical laboratory technology and biomedical engineering. We aim to bring trusted, innovative diagnostic solutions to healthcare across Nepal. Since our establishment in 2012, Technobiomed has secured a position among the top 3 IVD channel partners in Nepal. Our extensive distribution network reaches all 7 provinces, serving more than 700 laboratories with trusted diagnostic solutions. With operational presence in over 70 districts, Technobiomed has achieved an impressive 90% geographic coverage across Nepal. We offer a diverse product portfolio including Randox, a global leader in biochemistry, third-party quality control, also an external quality assessment, widely trusted for maintaining laboratory standards and highly valued by the laboratories for those seeking ISO accreditation. Developed by Randox, we have an advanced 24/7 Acusera software for intra-laboratory data management. Similarly, Exis from Austria is a Cartier's-based electrolyte analyzer. Horiba, a global leader in hematology analyzer and AI-powered digital morphology. Alifax from Italy deals with 2 product lines. One is erythrocyte sedimentation rate, ESR, and the other is dedicated for automated microbial culture automation. ArcRay from Japan offers 2 key diagnostic platforms, high-performance liquid chromatography and automated urine analyzers. Werfren, a leading company, deals with 2 key diagnostic platforms specialized for coagulation and other for the autoimmunity diagnostic, supporting both routine and specialized testing. Goldsight, a reputed manufacturer of nephelometry-based system, Idan, known for compact Cartier's-based analyzers. Also, in line with evolving market needs, we have also launched several next-generation diagnostic solutions. Our next-generation diagnostic solution includes newborn screening platform from Fenghua, spatial protein analysis on immunoturbidic principle from the binding site, pneumatic tube system from Summitsburger, and Celnovate, offering advanced immunohistochemistry solution. Globally, a total of 40 AI-driven products were approved under the artificial intelligence machine learning category, and we are proud to have two featured. Horiba Umizane D20, a digital morphology system and analyzer to digitalize blood and urine. Similarly, the AI 4510 urine sediment analyzer, both showcasing our growing contribution in AI innovation journey. Now we have a market demanding futuristic product, Selnovate, a key contributor to advancement in the field of immunohistochemistry, which is also a US FDA listed. Selnovate offers a comprehensive range of IHC solution, including fully automated stainers like CNT 300, 330, and a proprietary detecting systems like microstacker and polystacker. We also have immunocytochemistry and in situ hybridization product. With over 460 primary antibodies and advanced multiplex IHC kit, Sunlovet supports complex diagnostic made in oncology and pathology. So if you have any IHC tailored solution, our team is standing right over there, and please do not hesitate to contact us. We also have FISH, fluorescent in situ hybridization. Another leading product in histopathology is DACV, where we have a ranges of histo setup from semi-automated microtom MT1 to tissue processor to cryostat to slide stainer, cover slipper, and cassette printer. This innovative technology features a non-contact UV system with intelligent laser-based technology that has minimized human hassle. Fenghua, a prominent player in neonatal diagnostics. Fenghua offers a comprehensive solution for both prenatal and neonatal screening, covering a panel of 8 markers. In the region like Europe, Asia, and Middle East, there is a mandatory regulation from the government for newborn screening, so we have come up with a solution. We also have a validated UPLC, ultra performance liquid chromatography, and mass spectrometry. Similarly, we have added a new and innovative product to our portfolio, the binding site, specializing in protein testing and measuring free light assays, and the assay menu like monogomial gammopathies to central nervous system disorder to immunoglobulin and subclasses and so on. Notably, it is the only FDA-approved product in the immunoturbidometric segment. Similarly, we have a leading company from US that is Wareframe that deals with 2 diagnostic platforms. So dealing with the first one, we have Wareframe Instrumentation Laboratory specialized for fully automated coagulation analyzer, supporting both coagulometric like PT, APTT, fibrinogen, and chromogenic like D-dimer, proteinase, protein C, and other specialty assay, thus making a streamlined and a complete comprehensive solution for hemostatus laboratory. Dealing with the second product line from the Wareframe, we have Wareframe Innova Diagnostic, where we offer IFA, Quantalight ELISA, having a unique autoimmune marker such as PSPT, HMGCR, and Wareframe is the only company that offers third generational anti-CCP. We also have BioFlash, CLIA for dedicated autoimmunity. At Technobiomed, our STP approach is rooted in delivering the value. We prioritize perception over market reality, emphasize benefit rather than feature. We are equipped with a skilled team to thoroughly evaluate product before launching the product in the market. Thus, we don't compete on price, we compete on clinical value and uptime service. Therefore, invest one, benefit every day. Here I present the overall portfolio of Technobiomed Private Limited, but due to the time constraints, I apologize for not being able to cover our full portfolio in detail. However, for further discussion, please feel free to reach out to me or any other member from the Technobiomed right after the session, or please do not hesitate to visit our booth to connect and discuss further. Thank you so much for your time.
Thank you, Ms. Mandari, for your insightful presentation. Now, I'd like to extend my deepest gratitude to our esteemed chairs for their exceptional humility, resilience, and patience throughout the session. Your calm guidance, thoughtful insights, and unwavering dedication have truly elevated the quality of our discussions and fostered a respectful and engaging learning environment for all. Thank you, sir, for leading with such grace and for your continued commitment to advancing the field of pathology. It has been an honor to have your wisdom and presence throughout the session. So, ladies and gentlemen, I now invite our honorable chairs, Professor Dr. Abhimanyu Jha sir and Dr. Hari Prasad Dhakal sir, to the stage to present a token of love and appreciation to our distinguished speakers and sponsors in recognition of their valuable time, knowledge, and gracious presence in today's session. I would like to invite our honorable chairs, Professor Dr. Abhimanyu Jha sir and Hari Prasad Dhakal sir, to the stage to present token of love and appreciation to our distinguished speakers and sponsors in recognition of their valuable time, knowledge, and gracious presence in today's session. So I would like to invite Dr. Srizana Khati to receive the token of love and certificate. Dr. Susil Adhikari, Dr. Sion Hangmalimbu, please join me in applauding them as the tokens are presented. Dr. Sajana Dahal, Dr. Bibhuti Dahal, Mr. Kusal Shrestha on behalf of Mr. Susilo and accompanying with Sysmex Private Limited, the sponsor. Ms. Anisa Bhandari representing Technobiomet Private Limited and accompanying sponsor. Please join us in applauding as the token of love are received. Please. Please join me in applauding. Mr. Kusal Shrestha on behalf of Ms. Anisha Bhandari, representing Technobiomet Private Limited. Mr. Susilo. Mr. Susilo. Token of. Mr. Susilo representing Sysmex Private Limited. Mr. Kusal Shrestha representing Susilo on behalf of Sysmex Private Limited. So please join us in applauding as the token of love is received. Thank you so much, sir. So now I would like to invite Honorable Professor Dr. Hari Govinda Shrestha, sir, to provide the token of love to our eminent scholars, our distinguished chairs for their unwavering support, perseverance, and golden time. Please welcome Dr. Hari Govinda Shrestha, sir. And please join us by applauding as the token of love and memento are received. So with this, we come to the end of the third session of our conference, almost an end actually. So a heartfelt thank you once again to all our chairs, speakers, participants, and delegates for making this session both enriching and engaging. So let us applaud as a photograph of life has been taken. So now, thank you so much, everyone. So now I would like to invite Honorable Professor Dr. Abhimanyu Jha, sir, to distribute the memento and token of love to the sponsors of the today's event. So I'd like to invite East West Concern Private Limited, title sponsor, to receive the token of love and the certificate. Please join us by applauding as the token of love is being received. Now I'd like to invite Snipe, the platinum sponsor, to receive the memento and the certificate. I would like to invite Horiba India Private Limited, our platinum sponsor. I would like to invite Snipe to receive the token of love, which is our platinum sponsor of today's event. Snipe platinum sponsor. Now I'd like to invite Horiba India Private Limited, the platinum sponsor of today's event, and please join us by applauding as the token of love is being received. So Horiba India Private Limited, the platinum sponsor of today's event. Now I would like to invite Sero Diagnostics Traders Private Limited, the platinum sponsor of today's event, and please join us by applauding as the token of love is being received. Sero Diagnostics Traders Nepal Private Limited, platinum sponsor. Sero Diagnostics Traders Nepal, platinum sponsor. Now I'd like to invite Chamunda Trading House, the gold sponsor, to receive the token of love. I'd like to invite Chamunda Trading House, the gold sponsor of today's event, to receive the token of love. I'd like to invite Chamunda Trading House, the gold sponsor of today's event.
Now, I would like to take a moment to thank all our poster presenters for their brilliant contribution. To present certificate of appreciation, I would like to invite Professor Dr. Eva Pia on the stage. Please welcome her with a huge round of applause.
Thank you so much, Professor Dr. Abhimanyu Jha, sir.
May I kindly request Professor Dr. Eva Pia on the stage, please? Now, I would like to request Vice President of ACPN, Dr. Rakesh Pathak, to please kindly come forward on the stage to present the certificate of appreciation to our poster presenters.
Dr. Grishma Shrestha, Dr. Sunisa Vaidya,
Dr. Nikshan Dongol, Dr. Yek Raz Gurung,
I would like to invite Professor Dr. Eva Pia ma'am and our Vice President of ACPN, Rakesh Pathak sir, to provide the certificates to the poster presenters of today's event.
May I kindly request each poster presenters to come forward to the stage one by one as the name is being announced. Can we have Dr. Grishma Shrestha? Sorry, ma'am. Dr. Sunisa Vaidya. On behalf of all. Dr. Nikshan Dongol. Dr. Yek Raz Gurung. Dr. Rita Nirola. Dr. Sisana Puyal. Dr. Swati Jha. Dr. Divesh Adhikari. Dr. Rita Gimire. Dr. Barsa Dio. Dr. Junu Bhatrai. Dr. Sadiksha Bosnet. Dr. Sindhu Gyamali. Dr. Aarti Adhikari. Please give a big round of applause. Dr. Nima Poon. Dr. Kobita Gimire. Dr. Nisha Das. Let's hear it for them. Dr. Suveksha Kanal. Dr. Isma Gimire.
So a round of applause to all the participants of today's event.
Dr. Shreya Shrestha. Dr. Abhinav Kumar Singh. Dr. Susan Adhikari. Dr. Nobina Guidel. Please give them a huge round of applause. Dr. Siksha Sapkota. Let's show our appreciation with huge round of applause, everyone. Give them a big round of hand. It would be unfair if I didn't thank our JAWS panel of poster presentation. Your thoughtful evaluations and encouraging feedback have been made this event more meaningful. As a small gesture of our gratitude, we would like to present token of love to each of our expected judges. May I kindly invite Professor Dr. Sivaraj KC, Head of Scientific Committee, to hand over token of appreciations to our poster judges. Can we have Dr. Sagar Raj Pandey on the stage, please? Can we have Dr. Keyur Gautam on the stage, please? Can we have Dr. Pratima Shrestha? Please give them big round of applause. Dr. Ranjan Raj Bhatta. Your applause is small token of our big appreciation. So let's hear it for them, everyone.
Thank you so much to the honorable judges of our posters presentation today, and thank you so much, Professor Dr. Siva sir. So now we will like to take a short tea break. Please take this time to relax, refresh, and connect with your fellow colleagues. We request you to kindly return on time, that is 15:25, for the next session as we continue with more insightful discussions. Thank you and enjoy your break. So since we're running short of little bit of time. So I think it would be better if we all come to the hall back with our tea in the cups right here on the seat. Thank you so much. And we will be rejoining in 5 minutes.
Good afternoon to all the delegates. I hope you had a refreshing short tea break and are feeling recharged for the upcoming session. I'm Dr. Kripa Adhikari and I'll be your host for this final session. We'll now begin the fourth and the final session of the event. So we'll first start with a short presentation from our valued sponsor. We are honored to introduce Mr. Shafakul Islam, Country Manager at Diamond Biotech with over 15 years of impactful experience across Bangladesh and Nepal. Throughout his career, he has held influential leadership positions at Merrill, Advanced Meditrade, Zetix, and Reliance Solutions, where he has led product rollouts, optimized operations, and strengthened market presence. He has played a pivotal role in transforming diagnostics through strategic partnerships, helping countless patients gain access to cutting-edge diagnostic technology and elevating healthcare standards. Today, he will present on the topic, what high-end hematology analyzers bring under the trend of AI technology. Please join me in welcoming our esteemed sponsor and speaker, Mr. Shafakul Islam, to the stage.
Which one? Already. Good afternoon, the all presented guests and pathologists, doctors, and the president of ACPN. Good afternoon. Thank you so much to ACPN to give me a chance to present the demand. And I am from Demand Shafiqul Islam. I am man of Bangladesh. Now I am presenting demand. This is demand we believe the simpler and the better. The next one. The next. This page. Yes, sir. Next, right? Okay. Thank you so much. Demand is dynamic mind. Demand is dynamic mind. We have vision, and D-heart gravity of demand. This is demand was founded in 2013. It is at Shenzhen in China. It is actually hematology based, R&D based manufacturing company. Demand have 1,300 employees globally. 14% of total employees are working in R&D team. And we have complex manufacturing company, 92,000 meter square. Our manufacturing unit, 17,000 meter square. We have patent application 1,600, and we are doing work in total 150 plus countries. Now, regarding hematology in China, we are ranking number 2. This is our product line. These are high-ended product, 6 part, 7 part, 8 part, and 9 part. These are for 5 part autoloader and without autoloader. These are for 3 part, and this one is special one UN73 3 part and 5 part combined. We have also workload station, we have coagulation analyzer, we have immunology, we have POCT, DS10, and we have semi-auto biochemistry analyzer. We have complete solution for veterinary also. This is our product plan station for high throughput and low throughput and medium throughput also. I would love to introduce AI technology for hematology analyzer to you. In our laboratory, we have some problem. We are facing always problem, and we have the solution already. This is goes for IBD laboratory. We want correct and we want faster reputation and faster result. Now we have another problem. We have abnormal sample. We are always missing abnormal sample result. Like now, the normal sample have no flag, but abnormal sample demand have multiple flag also. This is actually a special review for platelet, ALL, AML, RBC, microcyte, macrocyte, iron, thalassemia also. But another problem in our laboratory, we have a high workload and tired team. Now we need correct result and high speed. Another problem in our laboratory, time consuming and error prone. Now we will solve this. Another problem, mission impossible. Different analyzer have different technology. That's why so different disease and disorder disease that could change the pattern. This is our another problem in laboratory we are facing from long time back. Now is our solution AI. We push the data in the AI solution factory, and then we are getting the good result using the AI reading. This solution, another one is AI for IBD laboratory. We have one good quality model, big high-ended model, DIS 800 Demine. It has AI solution completely. The Demine AI report for this model, DIS 800, it is showing summary, detailed explanation, and scatter plot and comparison with template. We are already have 20 plus patents in using this model. Already explained this. Hematology AI, hot hematology AI, abnormal sample have multiple flag, but we are not getting multiple flag. Only demand is giving multiple flag for abnormalities, cells. But hematology AI, we can see only 2 dimension, but we cannot see 3 dimension. Only hematology analyzer AI analysis of our model can see 3-dimensional feature space and patterns. So by this way, we are getting accurate result from abnormal sample. One example for AI analysis report, it has AML, acute myeloid leukemia, acute monocyte leukemia. This is example 1. Number 2, example 2, acute lymphocytic leukemia. Example 2, Demine DIS 800 is giving this type of example by AI analysis. Example 3, Demine is showing the reactive lymphocytic flag very properly inside this active, and it is showing this technology using AI technology, Demine. Now we have another specialty of intelligent one-but technology for RBC. Everybody knows, every pathologist also knows that RBC can be aggregated inside the irritated tube in case of low temperature. When in case of low temperature, RBC can be aggregated, then we are getting less RBC and high MCHC. That time, what is the solution? We have this type of solution. In case of RBC aggregation, we are in case of RBC aggregation, we are getting RBC aggregation. The result is not good, not accurate. RBC result is very low, MCS is very high. That time, the sample is returned back off and using one bath procedure and giving the correct result. Demand have another comprehensive solution for platelet. You know that platelet clumping is very common issue in our laboratory. From last very many years, we are getting platelet clumping inside the irritate tube and we are not getting good result as well. So now, only demand DAS 800 have this type of solution. We have anti-clumping platelet anti-clumping antibody mixed in our diluent. When diluent mixed with the anti-clumping antibody with the sample, then it hitting the area of platelet clump, then platelet is getting back to separated declumping and giving the accurate result. Now, this is our model having this type of solution, including AI technology, one bud technology for RBC and platelet declumping technology. Get the newest and best now. Thank you so much. Thank you. In this, my presentation.
Thank you so much, Mr. Safakul Islam, for your insights into the intersection of artificial intelligence and hematology diagnostics. Now, I would like to request Dr. Rakesh Pathak, Vice President of ACPN, to give the token of love to our sponsors who have presented. I would like to request Dr. Rakesh Pathak, sir, to come to the stage to give token of love to our sponsors. So our first sponsor, Chamunda Trading House, our gold sponsor. Please give a round of applause to our sponsor. Our gold sponsor, Techno Biomed Private Limited. Our gold sponsor, BSR Biotech Private Limited. Let's give them a round of applause. Let's give them a round of applause. Applied Biotech Private Limited. I would like to also invite our speaker from BSR Biotech, Mr. Shafakul Islam, to come to the stage to receive the token of love. Mr. Shafakul Islam. Applied Biotech Private Limited, our silver sponsor. On behalf of our sponsor, BSR Biotech, Sudeep International, our silver sponsor, and Everest Trade Link, our bronze sponsor. Let's give them a round of applause. Sudeep International, BSR Biotech, Mr. Safakul Islam, our speaker and sponsor, please come to the stage to receive the token of love. Sudeep International, anyone on behalf of Sudeep International? Now it is my distinct honor to introduce the chairperson of today's session, a visionary in the field of pathology and medical education, Professor Dr. Ranga Bahadur Basnit. He currently serves as professor and senior consultant pathologist at Kathmandu Model Hospital, Annapurna Institute of Neuro and Allied Health Sciences and Civil Services. With over 18 published research articles, his work spans cancer, infectious disease, HIV, and has appeared in prestigious journals including JNMA, NJOG, CV, and PMJN. Dr. Basnit is not only a pathologist of national repute, but also a committed educator and trainer, having received specialized training from WHO, AIMS, the UK, Japan, and beyond. He is a life member of leading medical associations and founder of Himalayan Health and Environment Service, reflecting his dedication to both science and society. With deep respect for his contributions to medicine, research, and teaching, please join me in welcoming Professor Dr. Ranga Bahadur Basnit as chair of this session. Now it is my honor to introduce our second chairperson, Professor Dr. Rajendra Prasad Baral, Senior Consultant of Clinical Oncology at Norwich International Hospital and Om Hospital and Research Center. Dr. Baral brings over 2 decades of expertise in oncology and has pivotal roles both nationally and regionally. He currently serves as the regional representative for Asia Pacific Geriatric Oncology, the president of Binay Tara Foundation, executive board member of ANCA, chief of Cancer Awareness Program at Lion Club International. He is also the charter president, Rotary Club Dharmamart, and chairperson for Disease Prevention and Treatment Subcommittee. Previously, he has contributed as chairman of the SARC Federation of Oncologists and served as the vice president of NCRS. His leadership and dedication have significantly advanced cancer care and awareness in Nepal and broader South Asian region. Please join me in welcoming Professor Dr. Rajendra Prasad Baral as the chair of this session.
Very first of all, thank you very much, President of this ACPN, Professor Abhimanyu Jha, Vice President Dr. Rakesh Pathak, Secretary Dr. Rosen. I see many of the senior pathologists here, my friends Dr. Sailesh, Dr. Sivaraj sir, and very our senior most pathologists who are even my teacher, Hari sir, and entire team, Sujata and IC Charisma and Ibar, everybody else. First of all, thank you very much for inviting all of us, and especially not pathologist. I'm not pathologist, and my friend Dr. Ranga, very senior pathologist, is chairing with me, and it gives me immense pleasure to say that in every conference. I have attended more than 1,000 conferences in the universe. I always repeat and say that pathology and radiology is the backbone of oncology as an oncologist. So you have created history. I'm saying since morning that honestly telling every sessions, every academic sessions, even upcoming, I know panel discussion are of international standard. There is no doubt. Everything has some documentation. And this is a very, very great learning session, learning platform to young pathologists like you. And another important lesson which I have found today is that in नेपालको कानुनमा चाहिँ एक तिहाई महिला हुन्छ भनेको सुनेको थिएँ. आज मैले सोधेँ, I asked Dr. Abhimanyu, Professor Abhimanyu said that, sir, 70% are female pathologists here. So especially thanks to all young, eminent female pathologists, you are going to lead the country. So especially, यहाँबाट सिकेको कुरा, please share yourselves and update your friends and juniors. We were also junior, now we became senior. Now you are junior, you will become senior. This is the lifetime. Sir, most senior, Hari sir is there. So with this, I ask my friend, Dr. Professor Ranga, to invite the first speaker.
Thank you so much. May I call Dr. Ankita Simkhada to present our topic on classified mixed germ cell tumor of the ovary.
Good afternoon, distinguished guests. I am Dr. Ankita Simkhada, currently working at Province Public Health Laboratory, Bagmati, and I am going to discuss a case of unclassified mixed germ cell sex cord tumor of the ovary. Our patient was a 16-year female who presented with amenorrhea for 8 months and lower abdominal pain for 1 month. Her menarche began at the age of 13 and she had regular periods prior to this episode. On physical examination of the breast and external genitalia, her development was normal as per age, and this corresponded to a Tanner stage 5. Routine blood investigations, including CBC, RFT, blood glucose, liver function tests, as well as thyroid function tests, were all within normal limits. And an ultrasonography of the abdomen showed a heteroechoic lesion arising from the left adnexa. MRI similarly showed an abdominopelvic cavity mass measuring 12 into 6 into 15 centimeter without separate visualization of the left ovary. The right ovary was normal and there was associated moderate ascites along with peritoneal nodules in the left pelvis, suggestive of metastasis. So these are the MRI view. In the first axial view, we can see that the mass has completely displaced the urinary bladder. This here is the mass, and on coronal section, we can see that the mass is covering almost the entire abdominopelvic cavity. Her serum tumor markers were elevated, except CEA, which was within normal limits. With this, a provisional diagnosis of germ cell tumor of the left ovary was made, and she underwent staging laparotomy with left salpingo-oophorectomy, infracolic omentectomy, and bilateral lymph node sampling. On gross examination, we received an enlarged left ovary which measured 16 centimeter in the greatest dimension. It had a lobulated surface and the capsule was intact. On cut section, the ovarian parenchyma was entirely replaced by a gray-white form solid tumor with focal dark brown hemorrhagic areas. On microscopic examination, 70% of the tumor was composed of germ cells intimately admixed with sex cord cells. In addition, malignant germ cells elements, including dish germinoma, which comprised 20% of the tumor, and yolk sac tumor, which comprised 10% of the tumor volume, were also seen. On extensive grossing, areas of hyalinization, calcification, and areas showing regressive changes were not seen. The pelvic peritoneal tissue was positive for tumor cells, and the omental tissue and all excised lymph nodes were free of tumor. This is the first microscopic section. And this shows a dual cell population where the germ cells with clear abundant cytoplasm are intimately admixed, and the tumor cells are arranged in anastomosing trabeculae and cords. And there's a mixture of sex cord cells with the germ cells. The sex cord cells have scant cytoplasm and hyperchromatic nuclei. Similarly, a variable pattern was observed. The second pattern was where the tumor cells were forming these island-like structures with the sex cord cells arranged towards the periphery and around the eosinophilic hyaline material, and the germ cells were scattered in between. The immunohistochemistry very nicely highlights the nuclear positivity OCT34 for the germ cells. And the second figure here shows the cytoplasmic positivity for calretinine, which highlights the sex cord cells. Similarly, CD117 shows membranous and cytoplasmic positivity for the germ cells, and the sex cord cells are negative. So this was the second component where solid sheets of tumor cells were seen separated by fibrovascular stroma. This was the dysgerminoma component, and we can see a few scattered lymphocytes here. On immunohistochemistry, the dysgerminoma cells showed a diffuse positivity with CD117 and nuclear positivity for OCT34. This was the third component. A classic reticular microcystic pattern was observed in yolk sac tumor, and abundant hyaline globules can be observed here. This is the tumor interface showing the two different components within the tumor. A patchy cytoplasmic positivity was observed with alpha fetoprotein within the yolk sac tumor. So with this, we had two differential diagnoses at hand. The first one was mixed germ cell sex cord stromal tumor unclassified with associated malignant germ cell tumor. And the second one was gonadoblastoma with associated malignant germ cell tumor. Even with IHC, it only helped us delineate that there were different components and that there were dual components, germ cell as well as sex cord cells within the tumor. But it did not help us narrow down to one specific diagnosis. And the fifth edition of WHO also includes both of these entities within the germ cell sex cord stromal tumors. So, as recommended by most authors, what we had to do was go back to a few clinical as well as histomorphological differences between the two entities. Here we can see in the comparison chart that more often gonadoblastoma cases are seen in intersex patients who have 90% of which have Y chromosome, and they are usually seen in cases which have underlying dysgenetic gonads, and degenerative changes such as hyalinization and calcification, regressive changes and burnout areas are increasingly common in gonadoblastoma. However, the unclassified tumors, they occur in normal phenotypic patients who have a normal genotype, and they usually occur in a normal ovary or testis, and degenerative changes are absent. The frequency of malignant component being associated with an unclassified tumor is, however, only 10%, and most of these cases are seen in post-pubertal cases. So till now, we didn't know the karyotype of our patient. We sent a karyotype which showed a normal 46XX karyotype, and with this, our final diagnosis was mixed germ cell sex cord stromal tumor unclassified with dysgerminoma and yolk sac tumor. The pathological stage was PT2B and 0 because there was metastasis to the because there was spread to the pelvic peritoneum. She received adjuvant chemotherapy, 3 cycles of bleomycin, etoposide, and cisplatin regimen. So a brief introduction to the unclassified mixed germ cell sex cord stromal tumor. The term was first introduced in 1972 by Tallerman for neoplasms other than gonadoblastoma. Fewer than 100 cases have been reported till date, and thus the true incidence is unknown. Almost all cases are described in phenotypically and genotypically normal patients, except a single case which was described in association with monosomy 22.
Usually, these tumors do not show endocrine manifestations. However, a few cases have been reported in association with precocious puberty. In comparison, virilization occurs in almost 60% cases of gonadoblastoma in phenotypic females, and around 80% of the gonadoblastoma cases they occur in phenotypic females. Grossly, these are large, unilateral, solid tumors which occasionally show cystic spaces. In contrast, gonadoblastoma is bilateral in around 40% cases. Microscopically, there's intimately admixed germ cells and sex cord cells. Usually, more than one pattern is observed within a single tumor, like we saw with our case. And the patterns, they're variable, they're arranged in cords, trabeculae, solid tubules. They may be diffuse, and occasionally they can form annular tubules, like we saw with our case. A single population of germ cells with abundant cytoplasm, usually resembling those that we see in dish germinoma, can be seen in this case. And I'd like to highlight the fact that if it were a case of gonadoblastoma, in histomorphology, there would be a heterogeneous population of the other germ cells. And regressive changes, like I've already said, such as calcification and hyalinization, all those mulberry type of calcification are very common in gonadoblastoma, but conspicuously absent in cases of unclassified cells. Germ cells and sex cord cells are highlighted by IHC, showing dual components. Most tumors are clinically benign. However, metastasis can occur even without secondary malignant component. Prognosis is favorable, and platinum-based chemotherapy is effective when when secondary malignant tumors are present. Unlike gonadoblastoma, removing the normal appearing contralateral gonad is contraindicated. To conclude, I'd like to highlight that recognition of dual cellular elements is important, and history, physical examination, along with cytogenetic studies is important for the correct diagnosis. IHC can be a useful adjunct, especially in cases where either germ cells or sex cord cells are relatively scanty, and differentiating between the two entities is important because of the differences in management. These are my references. Thank you.
Thank you, Dr. Ankita. This is a very rare case, and there are few cases only reported in the literature also. And thank you so much. You shared this very rare tumor to all of us. Thank you so much. So, may I call Dipti Shrestha to present her. This is also a very rare case. And we hope you will mind your time.
Very good afternoon to everyone. I'm Dr. Dipti Seshra, consultant pathologist from Parapakar Maternity and Women's Hospital. And my topic for today's case presentation is about commonly heard genetic diseases, but which was presented to us at an uncommon site. Here, I present a rare case of hydatid cyst in adnexa, mimicking as an ovarian cyst. Briefly talking about hydatid cyst, human echinococcosis is caused by larval stage of cystode of genus Echinococcus. Among four species, Echinococcus granulosus and multilocularis are commonly seen, where Echinococcus granulosus causes cystic echinococcosis and multilocularis causes alveolar echinococcosis. Hydatid cyst is a parasitic disease caused by Echinococcus granulosus, found mainly in the region where there is livestock farming and dogs are raised, as dogs are the definite host and humans are the intermediate. According to most of the studies done, liver is considered to be the commonest site of the implantation, followed by lung, kidney, and spleen. But it is rarely seen in the female reproductive system, with ovary and uterus being commonly affected. But these are the highly unusual location for primary involvement. This case describes a rare presentation of primary left adnexal hydatid cyst, which was presented to us as an ovarian cyst, and also highlights the crucial role of histopathological and serological evaluation for the confirmation of diagnosis. On case history, a 40 years old female Parafour LIFO presented in our outpatient department with a complaint of pain abdomen since 5 years, on and off, without obvious tenderness, and also complaint of PV discharge and burning micturition. Among all the history given by the patient, the most significant history was of livestock farming. On general examination of the patient were normal. On abdominal examination revealed a firm, mobile, palpable mass corresponding to 21 to 24 weeks of gestation arising from the pelvis, whereas hepatosplenomegaly and ascites were absent. All the routine hematological and biochemical investigations were within normal range. The tumor markers were also within normal range. On radiological finding, ultrasound of abdomen and pelvis showed normal uterus with presence of cystic lesion in left para-ovarian region of size 10.4 by 10.1 centimeter. No any other lesions were identified in the abdomen. So the patient underwent laparoscopy converted to laparotomy for left salpingo-oophorectomy and right salpingectomy. Intraoperatively, an ovarian cyst originating from left adnexa was seen of size 10 by 10 centimeter, and dense adhesion between ovarian cyst and omentum was also seen. So because of the clinical suspicion and dense adhesion between ovarian cyst and omentum, it was planned for imprint cytology. On imprint cytology, as we can see in these pictures as well, as this is the PAP stain, we only found necroinflammatory debris, multinucleated giant cells, clusters of benign epithelial cells, and macrophages. Here in this PAP stain, we can see the macrophages, multinucleated giant cells. The GIMSA stain also showed the similar finding of necroinflammatory debris, sheets of benign-looking epithelial cells, and giant cells. However, scoliosis were not noted in the smears examined, so the final impression of negative for malignancy was given, but the clinician were suggested to rule out other infectious pathology. On gross examination, as we can see in this picture, a single cystic tissue of size 15 by 13 by 6.5 centimeter was received with intact capsule. The left ovarian tissue was also seen attached to the cyst of size 3 by 2 by 1 centimeter, and the bilateral fallopian tubes which received were grossly unremarkable. On sectioning, thick yellowish fluid with containing yellowish greasy necrotic material was expelled and shows uniloculated cyst, along with, as we can see in this picture, a collapsed thick pearly white membranous tissue was seen. Microscopic examination revealed acellular, as we can see in this picture, acellular laminated eosinophilic membrane structure was seen, which was also seen attached to the fibrotic cyst wall at focal areas. In this picture also we can see the laminated membrane and necrotic debris. However, germinal layer and protoscolices were not seen in the sections examined. The left ovary and bilateral fallopian tubes were histologically unremarkable. So with all the microscopic finding, the diagnosis of hydatid cyst was suggested in left adnexa, and the patient was advised for serological test for confirmation. On serological testing, as we can see in this picture, ELISA confirmed the presence of Echinococcus immunoglobulin G antibodies. On follow-up, and the final diagnosis of hydatid cyst was confirmed. On follow-up, the patient was managed with anti-helminthic drug for 1 month. Now the patient is clinically asymptomatic. On discussing the case, according to WHO, the incidence of hydatid cyst is considered 50 per 1 lakh person with prevalence rate of 5 to 10%, especially seen in endemic countries. And as I've already mentioned, the commonest site is considered to be liver, followed by lung, kidney, and spleen. However, its occurrence in the reproductive system is shallow, with an incidence of 0.5% only. One of the studies done in Nepal at the Institute of Tribhuvan University Teaching Hospital for the period of 7 years has shown that commonly affected site for hydatid cyst was lung, followed by liver, and female population was commonly affected than males. Hydatid cyst is rare in pelvic region, so it is usually confused with other ovarian cyst and tubo-ovarian abscess in young age and ovarian malignancy in advanced stage. Exact pathogenesis of primary involvement of other organ rather than liver and lung, as in this our case, pelvic involvement is not clear, but hematogenous or lymphatic dissemination bypassing the liver and lung can be considered. Pelvic echinococcus in women remains difficult to diagnose with sonography finding only because of its wide variety of ultrasonographic occurrence. So the key diagnostic challenge in this case were unusual adnexal location, lack of classical imaging features such as daughter cyst or internal septation, absence of hepatic or pulmonary involvement, and histologically absence of germinal layer and protosclerosis. Although imaging remains one of the valuable tools for diagnosing, serological assay has also played an important role for confirming the diagnosis, as most of the studies has shown its sensitivity to be 60 to 90%. The gold standard treatment for hydatid cyst is surgery, either radical or conservative, followed by medical therapy. On concluding my case, this case has pointed out the fact that pelvic hydatid disease resembles neoplastic ovarian cyst, either benign or malignant. Hence, gynecologists, radiologists, and pathologists should be aware about this entity and should consider it to be in differential. Most of the time, the diagnosis of the disease is not straightforward, as we have faced in our case. So further investigation like serological test should be considered for the confirmation of the diagnosis. So early suspicion, appropriate imaging and histopathological confirmation are essential for accurate diagnosis and optimal management. These are my references. Thank you.
Thank you, Dr. Depti. You are on time. Congratulations. Because of shortage of time, we are not accepting any questions. We can discuss later on. And thank you very much. Please take your seat. Before inviting the third speaker, let me say something about the third speaker's topic. We are practicing oncology more than 30 years. In lung cancer, Dr. Kapendra, you must be remembering, every lung cancer used to be treated by cisplatin etoposide. Every choriocarcinoma used to be treated by only methotrexate. Or in breast cancer, CMF, cyclophosphamide, methotrexate, and 5-fluorouracil was the standard of treatment. That vanished. Then came anthracycline-based chemotherapy, CAF, then taxane, XYZ. So my question, my focus is that now in oncology, this is the era of molecular biology. So every cancer treatment is individualized. Every treatment is personalized. So molecular testing is must in the field of oncology. So every lung cancer is not treated samely, or even breast cancer or any gynec cancer, Dr. Eliza is there. So all of us, you are pathologists. Yesterday we have one session in how to positive breast cancer. I was luckily chairing and Dr. Kapendra Arun were in the panelists. So every how to positive breast cancer are not treated equally. So all testings are must. So that test guidelines us. So this is the era of, again, I say molecular biology, and science is invention, science is never stops. Who knows, after a few years, something else comes. So what is the role of molecular testing in cancer, in oncology? For this, let me invite Dr. Arun Sai to talk about clinical perspectives of molecular testing. Dr. Arun is working at Patan Academy of Health Science as assistant professor.
Thank you, sir, for a lovely introduction and highlighting about the importance of molecular testing in cancer. So, honorable chairperson, respected seniors, teachers, and colleagues and juniors, good evening. So today I'll be talking about clinical perspective of molecular testing in cancer. So my goal of the presentation will be to explore the critical role of molecular testing in modern oncology and discuss its clinical application, challenges, and future direction. But before going into the topic, I want to share you one case that how this molecular testing changes the paradigm in treatment of cancer. So this is the case summary of one of the patient who is 61 years old gentleman with no comorbidities and no smoking history. Initially presented with complaints of cough on and off for 2 months, headache, nausea, and vomiting on and off for 15 days. No history of tuberculosis. On investigation, whole body PET CT scan showed that there was a 5 into 3 into 5 into 6.16 centimeter in left lung apical segment, medial basal segment, sub-centimeter size lymph node present in left hilar region, and all other areas were normal. So this is the PET CT scan of that patient. So since he has a headache, nausea, and also the few episodes of vomiting, so we also look for the MRI. On CT MRI, it showed that there was a well-defined solitary lesion, 20 millimeter in right hemisphere, parasagittal with mass effect was correlated and confirmed with MRI, and the radiological diagnosis was the brain metastasis. So we asked the interventional radiologist for the biopsy from the long mass. And we discussed with the pathologist after biopsy, it came out moderately differentiated adenocarcinoma. So when the adenocarcinoma comes, we oncologists become more positive. So we send that biopsy for the IHC and NGS, and EGFR, ROS, and BRAF came negative, but luckily, I would say ALK, that is anaplastic lymphoma kinase, came positive. So the final diagnosis was TNM stage 4 brain mets, and PDL1 was 10% of tumor cells. So I want to ask someone who is 61 years old male, he has a brain mets, हाम्रो सल्लाह के हुन्छ उपचार गर्ने कि नगर्ने would you recommend treatment के भन्नुहुन्छ yes तर मलाई लाग्छ कसैले नो पनि भन्नुहुन्छ there will be yes and no so if I ask in all the group your answer will be either yes or no but I want to show you the real world the power of molecular testing you can see this patient I think after this inspiring story, I think we all are energized. So let's go into the topic now. So introduction is like the evolving landscape of cancer care or disease of the genome. So traditionally, it was diagnosed by histology and anatomical site. Now the growing understanding is cancer is driven by specific genetic and molecular alteration, like our Professor Baral said. So precision oncology is transforming cancer care. So I would say like this also match with the theme of this conference that precision pathology. So now not only precision cancer care, we also have to say precision pathology. This is the era of precision pathology. So what is molecular testing? It is analysis of DNA, RNA, or proteins to identify specific alteration that might be mutation, rearrangement, or expression, or different patterns. It includes next generation sequencing, FISH, PCR, IHC, or Sanger sequencing, all are called the molecular testing. And it detects somatic or germline mutation, fusion, TMB, MSI, and PD-L1, all expression can be seen with this molecular testing. So why molecular testing matters in oncology, precision medicine paradigm? It helps us to tailor the treatment strategies to an individual patient's tumor molecular profile. So even in one cancer, there might be different subtypes. So one cancer, lung cancer patient might get different medicine. So we say like right treatment for the right patient at the right time. So this is the era of precision oncology as well as precision pathology. So what is the clinical application of molecular testing? We all know that it helps in the diagnosis. For example, BCR-ABL fusion gene in CML via PCR. So it can also help for the prognosis as well. So example, IDH1 or ID2 mutation. When these two mutations are found in the glioblastoma, the prognosis is better. It responds well with the drugs available, that is temozolomide. So we can find out like what is the prognosis of the patient. Then also it helps to select the therapy. Like for example, some patient is diagnosed with a lung cancer. If they have an EGFR mutation positive, we can give them the oral targeted therapy. They don't need the chemotherapy. The same like the previous patient, he was ALK positive, he doesn't need the chemotherapy. And even now we have a drug that if some patient has a brain mets, they don't need the radiation therapy as well. So these are the, I would say like the most penetrating or most practice changing discovery of this 21st century. And also the monitoring. Sometimes we also see the circulating tumor DNA for resistant mutation. For example, to some patients we are giving the chemo or some targeted therapy, but they don't respond. If we see after 1 or 2 cycles of chemo, the disease is progressing. In that case, we can see the circulating tumor DNA to look for the monitoring the treatment. So what are the types of molecular tests? So you know that PCR and digital PCR. What does it does? It amplifies specific DNA and RNA sequences like next generation sequencing, and it also provides comprehensive genomic profiling. So if we do comprehensive genomic profile for the whole body, it is very expensive. So we also have the test in a breakdown. For example, only lung panel or GI panel or breast panel that can be affordable and cheaper compared to comprehensive genomic profile. And we all know the role of the face in breast cancer. It visualizes the chromosomal abnormalities like gene amplification, translocation. Example is in HER2 amplification. Sometimes we do the IHC, and when it comes to 2+, we have to send for the FIS. So this FIS is also the type of the molecular test. Another is very common and very popular. I think everybody is familiar with this, immunohistochemistry. It detects specific proteins in tissue samples. Example, PD-L1 expression for immunotherapy and ERPR positive in breast cancer. So what are the major actionable biomarkers? We all know that there are so many actionable biomarkers, but what are the drug availability in Nepal? Sometimes we send a test, for example, comprehensive genomic profile, which costs around 1 to 2 lakhs. But when some test comes positive, but the drug is not available. So we also have to think like what test has to be sent. For example, in breast, we can say the HER2, in colon, RAS, BRAF, or MSI, in lung, ALK, ROS, EGFR, these kind of tests for whom drugs are easily available in our country and in affordable price. I think this has to be done mandatory for everyone. So what is the role of pathologists? I would say that there is an evolving role of pathologists in molecular testing. If you see the College of American Pathologists website, they have now focused that pathologists are at the forefront in shaping the future of cancer treatment with molecular tests. The first thing starts with the molecular tumor boards. So what the pathologist's role is, they interpret genomic reports with oncology teams. Sometimes some reports come, the pathologist gives the reports, and we oncologists also we cannot interpret. In that case, we need your help again. And many of the times, I call the pathologist, especially Shiv sir in Patan Hospital. He has been always very inspirational figure for me and my mentor as well. And he has great role in my career development as well. So thank you, sir, for the everything. And then again, the clarify actionable versus non-actionable variants. We, as a tumor board pathologist, can play that role. And also another role is a expanded diagnostic role from HNE to IHC, FIS, PCR, and GS interpretation. So you can also say that what treatment is needed for what kind of diagnosis. So even when we say send some reports, like there are confusing reports, so we need a pathologists help. So I can say that pathologists are also the gatekeeper of molecular testing. They decide appropriate test panels and they ensure the sample quality and the adequacy of the sample. And also sometimes quality assurance and standardization. Sometimes they to validate and monitor assays that PDL1 or TMB and participate in EQA programs. And they can also be educators and innovators. For example, they teach residents, fellows, and even sometimes oncologists, lead biomarker discovery and research. So this is the era of the AI now. We are also thinking about the AI. So embarrassing digital and AI tools is, I think, it will be a very knowledgeable and very smart ideas. So the better, the quicker we accept the AI. So use of digital scanners and AI platforms should be taught to all the pathologists and even to oncologists. So what is our experience at Patton Hospital? This is the very dynamic team of pathologists at Patton Hospital. They have been doing wonderful job. And I would say, like, because of them, now in Patton, we treat only in the solid tumor, 40 to 50 cancer patients, they are taking chemotherapy every day. And we also have hematological ward where I think 15 to 20 patients. And we also have pediatric oncology. So this is all the credit to this excellent pathology team of Patton Hospital under the leadership of Professor Shiv. So molecular oncology bridging hope and reality, what we are doing in Patton Hospital, sometimes EGFR, ROS1 testing via the Max Foundation. The Patton Hospital has the relation with the Max Foundation, and they have been providing 14 tests, drugs which are very expensive, and hormone receptor HER2 testing available, and immunohistochemistry for the soft tissue sarcomas, and even the BRCA test, PD-L1 testing, we often outsource this kind of tests. So what is the future direction in molecular testing? We know that we have not practicing, or it has not started, but future is liquid biopsy or whole genomic sequencing. And I am sure that in sometimes we have to be familiar with the AI integrated and personalized care. So what are the challenges in clinical implementation? You all know that these molecular testings are high cost of advanced molecular tests. Delays in obtaining results can impact timely treatment decision. Lack of national standards across laboratories for testing methodologies and reporting. Standards in quality control. Disparities in access to advanced molecular testing, especially in remote areas. So my take-home message is molecular testing improves cancer outcomes. I think you all agree on that. And the pathologists are key to precision care. And lower middle income country like Nepal must catch up via partnership and innovation to balance the science and cost, because when the science comes and they show so many good results, but again, we have to look for our pocket. So what I would like to say is, like, no tissue should be wasted. Every biopsy has a story hidden in its DNA. And we have, with the help of the Max Foundation, almost 2,500 patients surviving because of the molecular testing. So I would say where you live should not determine if you live. Every human being has an equal right to survive. So thank you very much.
Thank you so much, Dr. Arun Sai. Actually, already you have told us that every treatment is now individualized or personalized. So at a very right time, every case should do this molecular testing, because there are so many new theories I know it's coming. So thank you so much. You shared a very good, very good experience and theoretical knowledge to all of us. Thank you so much. Keep it up. Thank you.
I would like to extend our heartfelt thanks to our distinguished presenters for such thought-provoking session. Your insights and depth of knowledge have truly added value to today's program. We are grateful for the time and effort you dedicated to sharing your expertise with us. Now, as a gesture of gratitude and appreciation, I would like to kindly request our respected chairpersons to come forward and present a token of love and appreciation to our esteemed presenters. I would like to call upon the stage Dr. Ankita Simkhara, Dr. Dipti Shrestha, and Dr. Arun Shahi. Let's keep applauding them. I would like to kindly request Professor Dr. Rajesh Pant to come forward and present a token of love and appreciation to our respected chairpersons. This is a small gesture to express our sincere gratitude for their time, effort, and contribution to the success of this program. Thank you so much, sir. Now, I would like to invite Dr. Rakesh Pathak, Vice President of ACPN, to present a token of love to our sponsor, Sudeep International. Sudeep International, our silver sponsor, please come to the stage to receive the token of love. Now we move on to the last part of this session, the panel discussion. Now it is my pleasure to introduce our panel moderator, Professor Dr. Sujata Purasaini, Professor, Senior Consultant and Head of the Blood Bank of Nepal Medical College Teaching Hospital. Dr. Sujata Purasaini specializes in histopathology, including oncopathology, with focused expertise in dermatopathology and uropathology. She actively contributes to medical education through roles on the KU MBBS Committee, IRC NMC, and NCRS Tumor Board. An accomplished academic, she serves as an editor for both the Nepal Medical College Journal and Nepal Medical Journal, and is a reviewer for over 10 esteemed journals, including Journal of Pathology of Nepal, Journal of Oncology and Cancer Research. She has 50 published papers as first and second author in national and international journals. Please join me in welcoming Professor Dr. Sujata Purasaini to the stage to moderate this panel discussion.
Thank you, Kripa, for introducing me. Good evening and namaste to all. So let us settle the chairs first, and we will start shortly. Is it okay, the chair arrangement? Okay, that side, right. CV को folder खोल दो तो. Yeah. I want CV. Okay, but I need to see it here. खोइ त कता गयो. I'll start. खोइ त. खोइ त CV. CV खोइ. No, no. CV of panelist. उनीहरूले यो मिलाएको छ. So shall we start with the CVs? Okay, the introduction part, what happened? So, खै त. CV all मा हैन नि त. CV यसको छुट्टै छैन. Okay, okay, okay. Okay, okay, fine. Okay. Okay, fine. Okay, for today's panel discussion, we have two cases. So since we are already running behind the schedule, we will shortly discuss these cases. First, let us have our panelist here. It's not working. Okay, I have to go one by one. Okay. So may I welcome Dr. Kapendra Sekhar Amatya. Dr. Amatya, he is a consultant surgical oncologist and head of the department in Nepal Cancer Hospital and Research Center. His special area of interest, expertise in breast conservative surgery and GI surgery. Dr. Amatya has co-authored a number of these papers in national and international journal. He has addressed as faculty in numerous conferences, and his focus is in breast and GI cancer. Welcome, Dr. Kapendra Amatya. Next, we have we have Assistant Professor Dr. Arun Shahi. Dr. Sahi is Senior Consultant of Medical Oncology in Patan Academy of Health Sciences. His special areas of interest or expertise in medical oncology, as we just had his session just before starting this. He has authored books, presented number of research papers. He is a certified European medical oncologist and a very active member of ASCO, if I'm not wrong. So a few weeks back, he had gone for ASCO conference. We are very happy to have you here. Next, we have is Professor Dr. Rajendra Prasad Baral. Dr. Baral, his special areas, I don't think we need to tell. In oncology, he is a senior consultant working in Norvik International Hospital and Om Hospital and Research Center. Dr. Baral, he is SARC representative, Asia Pacific Geriatric Oncology. He is former medical director and former HOD in Bhaktapur Cancer Hospital. His contribution towards the papers publication is worth to know, and he has been involved in awareness program as well as different cancer foundation. We're happy to have you here, sir. From Gyne Onco, we have Associate Professor Dr. Eliza Shrestha. Dr. Shrestha is a consultant gynecologic oncologist working in Bhaktapur Cancer Hospital, Norvik International Hospital, and Kathmandu Cancer Center. She is been awarded, I think, number of awards, ASCO, from different parts of the world. She has also rewarded with Vidya Bhushan Award, and she is also involved in research work. And very interestingly, her ongoing study is on HPV-16 as prognostic factor. So we will be eagerly waiting for this research work to get published and share her views later in this discussion. Okay, the backbone of everything, backbone of disease, pathology, we have Dr. Bandana Satyal. Dr. Bandana, she is senior consultant pathologist and a gynecopathologist. She has been working in BNB Hospital for a long time. She has received her fellowship in Gynepath from UK. She is very much aware of immunohistochemistry, again, the must of this era. And she is also involved in this publication in different national and international journal. Thank you. From oncology part, we have Dr. Ujjwal Chalise. Dr. Chalise is director, consultant, clinical oncologist in Bhaktapur Cancer Hospital. Let us welcome Dr. Chalise. His special areas of interest, expertise is chemoradiation therapy, targeted therapy, immunotherapy, stem cell, bone marrow transplant, and hormone therapy. I think that's what we need in this 2025. And he has achieved his academic fellowship in oncology from NAMS. Thank you. Yes, pathology, we have Professor Dr. Suspana Hirachan. Dr. Hirachan, she is professor, head of the department, working in Kathmandu Medical College. She is an expert in histopathology. She has more than 40 plus publications in national and international journals. And we cannot deny that she is the most hardworking faculty in KMC. I know her personally. So whenever there is a diagnosis, I know pathologists, we are always behind the curtains, and there is one fraternity who is always walking hand in hand with us. Yes, that is radiology department. We have Lieutenant Colonel Assistant Professor Dr. Vivek Karki. He works in Sri Birendra Hospital, Nepalese Army Institute of Health Sciences. His special areas of interest, oncoradiology, and he's been trained in obstetric and fetal imaging. We welcome you, Dr. Vivek. So that was all about the introduction of our panelists. I think we should move ahead with the cases. Kripa, you have to help me with the PowerPoint. Yes, where is it? This one? Okay, okay, fine. So without delay, I would like to discuss very simple cases, daily routine cases, because we always get stuck up in simple cases. And I'm very bad in immunohistochemistry and genetic testing and all. So very simple cases we are going to discuss. So case 1. Okay. So is it okay for all the panelists? Is it? Yeah. So a 64 years old female, occasional smoker, drinker, presented with pain abdomen for 2 months. That was around 7.5 months ago. So ultrasound abdomen was sent and there was minimal ascites and no other positive finding. Okay, so with minimal ascites, this patient was sent for CT abdomen. CT abdomen shows mild loculated ascites. There is enhancing peritoneal lining and diffuse, mildly enhancing omental thickening in inframesocolic space. And the differential diagnosis given was peritoneal carcinomatosis, TB peritonitis, on the basis of this peritoneal thickening, I guess. And there was a minimal right pleural effusion, gallbladder, there was a mixed solid cystic nodule, so differential diagnosis of a neoplastic lesion was given. Bilateral ovaries were bulky and showing heterogeneous enhancements. However, there was no obvious lesion in the bilateral ovaries. Tumor markers were sent, and all the tumor markers, as you can see here, CA125, CEA, CA19.9, all of them is increased. Acidic free cytology was positive for malignant cells with metastatic carcinoma. That was the report dispatched from pathology. We'll come back to the cytology a little later. So this was the picture. We got it from the fluid cytology, quite cellular, 3D clusters, okay, of all these atypical cells. And interestingly, this patient, okay, went for, I think, second opinion to the second center, where again, there was a diffuse omental thickening, same site, and gallbladder, it was a different diagnosis, little bit different. Adenomyomatosis was given. And bilateral ovaries were bulky, but one plus point is they have written whether it's a metastasis, query cause. Ascites was minimal, and pleural effusion right-sided was also minimal. Very interesting. I think the same thing happens to all of us, especially Dr. Vivek. Again, they went to the third center. Okay, so the patient must have spent a lot. CT abdomen, pelvis in the third center. No doubt in the peritoneum, again, there is omental caking and nodularity, suggestive of peritoneal carcinomatosis. And again, mild bulky ovaries, where neoplastic lesion could not be totally ruled out. GB, it's again adenomyomatosis and right pleural effusion. So, yes, at this point, I want to ask Dr. Vivek. So, like we have seen all these differences in CT finding, okay, in 3 different sites. When it comes to the omental node, at 2 places it was just the thickening, whereas in the third center they had mentioned about the nodularity and caking. So I want, because to us it seems different. So I want you to clarify that, number 1. And number 2, about the bilateral bulky ovaries. So with this CD finding, normally, should we be able to pick up the metastasis, primary, or it would be just the other pathology?
Thank you for the question, ma'am. This peritoneal thickening is, common finding in CT whenever there is ascites. So whenever there is irregular thickening of peritoneum and subsequently omental thickening present, the first 2 diagnoses will be tubercular and the peritoneal metastasis. Since in this case, since it was irregular thickening with enhancing thickening, and the impression was that of omental kicking, where when omentum is thickened, it appears like a cake. That is common called as omental kicking. So in this case, the most likely is peritoneal metastasis.
So you think it's a peritoneal metastasis,
All
not
right.
primary peritoneal lesion?
Right, ma'am.
So I'm just not talking about the case, just looking at the CT findings.
Right. So whenever whenever peritoneal carcinomatosis features are present, the causes are, again, most common is colorectal cancer. Then second, it is usually ovarian cancer. And third most common is actually unknown cause.
Unknown, right,
Unknown cause.
right.
Then other differential will be pseudomyxoma peritoni, in which case there will be some myxomatous fluid that will cause mass effect, which is unlikely in this case. Again, there can be primary tumor of the peritoneum itself, peritoneal mesothelioma as well.
So here, do you agree to keep the primary as ovarian with omental mets as the differential diagnosis? Is it okay?
Since CT is not the best modality to evaluate ovary as such, and they have commented the ovaries are bulky. However, they haven't commented on any ovarian lesion. So by this CT finding only, it is not, I mean, you cannot say definitely it is from ovary.
Okay, okay, thank you. So since he has mentioned about the biopsy, CT guided omental biopsy was done. So for all the pathologists present here, we can see tumor infiltrating the omental tissue here. So the biopsy was sent for immunohistochemistry, which shows positive for PAX8, WT1, P53, and ER. I think that is the must in IHC if we are thinking of ovarian cancer, okay, with mets in the peritoneum. Negative for CDX2, and Ki67 proliferation index is 80%. And this was the picture. So it has taken the stain, PAX8 and WT1. So the final diagnosis was metastatic high-grade serous carcinoma of Mullerian origin. So looking at this biopsy report and the immunohistochemistry, I would like to ask Dr. Bandana, do you think is it okay to pass on this report to the clinician so that they can go ahead with the treatment, or would you recommend something else for the final diagnosis of high-grade serous carcinoma?
I think it is okay because the diagnosis of high-grade serous carcinoma, because PAX8 and WT1 are positive, and they are Mullerian markers, and WT1 is the simple, reliable marker for positivity for high-grade serous carcinoma, and P53 positivity is there, which is also universal in case of high-grade serous carcinoma in ERS positive. Just with the cytology and the biopsy, core biopsy of the omental nodule, there would be possibility of metastasis from GI tract also, but CDX2 is negative, so it excludes GI possibility of GI metastasis, and Ki67 index is also really high, 80%, so it comes down to a diagnosis of high-grade serous carcinoma of Mullerian origin.
So we can rely on this, right?
Yeah.
So it's a high-grade serous carcinoma. Okay, but okay, with this diagnosis of high-grade serous carcinoma, patient was given 3 cycles of neoadjuvant chemotherapy, that is paclitaxel plus carboplatin. So 3 cycles on day 1, day 8, day 15, 2 weeks apart. So 3 cycles were given and it was uneventful. And the response evaluation was done after the 3rd cycle with repeat CT scan. So there were enhancing omental deposits, which was similar to previous scan. And GB, same, adenomyomatosis was there. I know chemotherapy is not going to work here. So bilateral ovaries were still bulky. And this response evaluation criteria, if I'm not wrong, no, it's for the solid tumors. It was given as stable disease. So is it okay, Dr. Vivek, this stable disease, this criteria?
What we call as RECIST criteria, that is a response evaluation criteria for solid tumors. It is a systematic way to measure the response of a solid tumor to treatment. So in this case, it is given as stable disease, which means that neither the disease has criteria to call for progression, neither for regression.
Yes, because earlier we were seeing the omental thickening. Now,
Right.
to me, it's quite interesting. We are seeing the omental deposits.
So how we do is we observe all the tumor-related, malignancy-related findings, and differentiate them, divide them into target and non-target lesions. So target lesions are those which can be measured, Non-target lesions are those which cannot be measured, just like omental thickening, ascites. These are non-measurable. Another example is miliary nodules. These are non-measurable, so these are non-target lesions. So to call disease progression, the target lesion has to increase by 20%. To call is regression, it has to decrease by 30%. If neither of those criteria are met, it will be labeled as stable disease. So any new lesion or any new finding will make the disease progressive. So in this case, there were no new findings. The findings were, though the non-target lesions were reduced in size, they were not completely disappeared. So this is a stable disease.
So we can say that disease has not progressed, and I don't think like there is regression of the tumor as well.
Right.
Right? So with this, the surgery was done in the patient, that is interval cytoreductive surgery, TH with bilateral salpingo-oophorectomy with supracolic omentectomy with appendectomy, very long. I think Dr. Eliza, she would be able to explain about this. So grossly, when the specimen was sent, there was no tumor detected in the bilateral ovaries. Microscopically, there were sheets, nets, and singly dispersed cells arranged in gland and cribriform pattern. Pleomorphism was marked, and diagnosis was given as high-grade serous carcinoma. So treatment associated, this classification was used, YPT1, phygostaging 1, and chemotherapy, this score changes was 3, which means marked response with no or minimal residual tumor. Right ovary and bilateral tubes unremarkable. Now omentum, it is also negative for malignancy. Okay. So with this, let me ask Dr. Eliza, what would you like to say about the management in this case? Like, is it enough interval cytoreductive surgery, or as Dr. Sahi was saying, everything has to be precise when it comes to oncology, right? So the time was precise, the treatment was like the same treatment you would recommend. What would you like to say?
Thank you so much, Sujata ma'am. Regarding the management of this ovarian CA, actually this patient present with a very late presentation, as there is a ascitic fluid is positive, and also the CA 1 to 5 is more than 1000. And when we did the omental biopsy, that was already positive. That means it is already stage 3 disease, 3C disease. So when the disease burden is very high, we actually choose the patients to be sent first as a neoadjuvant chemotherapy. Then we do an interval cytoreductive surgery, and that includes to be THBSO, transabdominal hysterectomy with bilateral salpingo-oophorectomy with supracolic omentectomy, and sometimes appendectomy. If there is a disease present in appendix, then we do appendectomy. Otherwise, we avoid doing appendectomy. Then again, we do an adjuvant chemotherapy. Thank you.
Okay, after this, you want to continue chemotherapy. Okay, I think
Shall-
Dr. Kapendra, he
sorry.
wants to add something to this.
I think I'd like to add something in this. I'm very happy with what has happened, and I call it lucky. Because whenever we see a patient with bilateral ovarian mass, I think we should always suspect Kuchenberg's disease. And in this patient, scope is very necessary, which has not been done in this case. We have to scope the patient. Endoscopy, colonoscopy is a must in these kind of cases.
Okay, we
We
missed that.
cannot rule out, and again, we have a CEA is high. We have one tumor marker which is ruling it out, that's good. But again, in these cases, there is always a chance that there is a latent tumor in the GI tract. So we have to rule this out. And that is for everyone. Here, we are lucky that it has come out like this, but it is very necessary. And even in the surgery that has been done, it's been done wonderful. I agree with that. But in this case, we have to see where the primary tumors were. In these cases, peritonectomy or selective peritonectomy is very much necessary in these kind of cases.
Yeah.
We have to do, at least if not, we have to do a 4-quadrant peritoneal biopsy to rule out if it has been there or not. That is very, very necessary in these kind of surgeries. Because once you've done neoadjuvant chemotherapy, there is very less chance that you will find disease inside. And it's a very clean case here which has happened. But apart from that also, we have to choose the peritoneum at least from 4 quadrants. If possible, in these cases, we have to take the pelvic peritoneum out, and we have to take the, what we say, pouch of Douglas out in these kind of cases. So that is very necessary in this.
Thank you. So I think that is very important. Like whenever any case comes, I think we should discuss among ourselves, and we should always come up with the good management. It's always beneficial for the patient, and the outcome is going to be very fantastic. So here from Dr. Eliza also, I was thinking she's not very happy with stage 1 because it is post-chemo, right? The histopathology diagnosis, let's say. And these were the slides from the ovary, that left ovary. Here, maybe I told you when I start early that I'm not very good in ISC, but when I look at these histopathology slides, it seems to me that there is infiltrating tumor. Okay, here we can see the infiltrating tumor. So I was just wondering why this, like CRS scoring 3 was given with no or minimal residual tumor. I think we should give that scoring to the ovaries, right? We say that right ovary and bilateral tubes were normal. So it should correspond to the left ovary. That is my understanding. So why is it score 3? I think it should be either 2 or something like that.
This chemotherapy response score 3 may be in the momentum. There was no tumor, residual tumor at all. Just there was fibrosis and necrosis and inflammatory reaction and maybe calcification. And in the ovary, there was no gross tumor at all. And microscopically, it was less than 2 millimeters.
Okay.
Even it was a very tiny microscopic focus only. Although in the picture it looks distinct, but it was just a tiny microscopic focus only. So that's why, since there was a marked response to chemotherapy, maybe it was labeled as chemotherapy response score 3.
Okay, so what I was thinking, like, had it been no chemotherapy in this patient, the staging would have been like a little bit more than what we have it here now. And so keeping this in mind, I would like to ask my next questions to Professor Baral. So since after 3rd cycle, surgery was done, repeat CT was done, and patient was planned for 4th to 6th cycle, the same chemotherapy, paclitaxel and carboplatin, okay? And patient, after that, patient is asked for next follow-up, thinking we might need to continue chemotherapy. So in that situation, okay, patient has now already completed 6th cycle, is about to come for the follow-up. So what would you suggest? Is it okay, whatever the investigation we have done so far, the treatment, or would you like to add some more?
Thank you, Sujata. Let me summarize this. Definitely, this is locally advanced cancer. We don't know it is primary GI or ovary. I'm very happy to share with Dr. Eliza and Dr. Kopindra. We should investigate further, as mentioned by Dr. Kopindra. So we should do whatever test we need, we should do test. There is test when garnu bhayena, garnai parne test chhodnu bhayena. I think all of you agree. Now there are 3 pictures here. CA 125 is high, CA high, CA 19.9 high. Markers, these are the only prognostic markers. CA 125 बढ्यो भन्दैमा क्यान्सर भनेर हुँदैन. Smokerलाई पनि बढ्छ, menarche-मा बढ्छ. There are a lot of things, but as mentioned by Dr. Eliza, 1000 is significantly high. Even CA and this also. On the basis of CA 125 raised, we cannot treat. But she has some pictures going in favor of ovary, like omental caking, ascites the GI ma pani huncha. Okay. So whatever the chemotherapy was given, drug was good because that drug covers both GI or ovary cancer.
So that was proven, ISC proven.
Paclitaxel, carboplatin was given,
Yes.
standard.
Apart from those.
No, see. But
my reservation, I may be wrong. Day 1, day 15. This is weekly chemotherapy. बिरामीलाई अप्ठ्यारो मान्छ एक एक हप्तामा भन्छ हामीलाई गाह्रो मान्छ. For me, if this patient has come to me, I used to give day 1, day 2, or day 1, 21 days.
Okay, 3
That
weeks
is
apart.
more comfortable to the patients. And ovary cancer is such a cancer. There are 3 cancers in oncology. Just saying relapse rate or recurrent. What is relapse? What is recurrent? Local recurrence, tongue, local recurrence. Cheek, buccal mucosa, local recurrence. Relapse NHL, relapse ALL. So there are technical terms, recurrent and relapse. So ovary cancer, colon cancer, and bladder, urinary bladder cancer are most frequently recurring cancers. So ovary cancer mata duitinta diyo thikka huncha feri again came back. I should say or not, my phupu was treated at DNB, Dr. Bandana Menos, 118 chemo diएको, still she's surviving.
So what you suggest, what
So
next?
the question is that day 1, day 15, N is not mentioned here, as mentioned by Dr. Eliza. पहिला त 3C को अवस्थामा छ, that was. So N is not clear. For us, that is NX. Maybe node is not dissected or not mentioned. And very unlikely SIT is having T1
so
only.
Dr. Bara, let's assume N is X. Okay, no lymph nodes.
After giving neoadjuvant surgery done and again adjuvant day 1, day different, fully agreed. Now these patients should be in very, very close observation compared to other patients because relapse is there is high chances of relapse. Every cancer has relapse chance. You say especially more close follow-up.
Okay, so you're saying that relapse is like very, very, like we are very near to relapse. It's we can think of relapse anytime in this case, right?
The beauty of ovary is again it comes, again you give chemo, maybe second line, again it goes down, again may come back.
So why do you think, like, why not biomarkers as Dr. Arun, he was mentioning about, right? In this case, we are saying high-grade serous carcinoma. So why we missed this BRCA1, BRCA2, like?
Logically, in this case also, you should have done PDL1 testing, maybe pembrolizumab or immunotherapy has high role or other testing. Testing is important in all cancers.
Okay, I think Dr. Dr. Arun, right? He wants to add in something.
So far, seeing the case summary, I think all the process and treatment has gone in a very good direction. I totally agree with the treatment and even the pathologist report after the neoadjuvant. What, like Sir said, high-grade serous carcinoma is a very sensitive with the chemo. And for the ovarian cancer or any other cancer, why we give neoadjuvant? Neoadjuvant, the idea of giving neoadjuvant is also to test whether that chemo works or not.
Yes.
Whether that the diagnosis given by a pathologist is right or wrong. So in this case, after giving paclitaxel and carboplatin, which is till now standard of care for the ovarian cancer, so it shows like very good response, almost complete response. So I would say that after 3 cycles of chemo, and we have to remember that the Ki67 is 80%. So it is a proliferation marker. So there is a high chance of recurrence. And all the phase 3 trials, that GOG and other trials, they say that standard of care for the locally advanced ovarian cancer is 6 cycles. We have to complete. But what should we do after the 6 cycle and whether we need other tests or not? So for all the ovarian, breast cancer, prostate, pancreatic cancer, we need to do the BRCA test. There's a direct and strong association with the BRCA.
So it's a must.
Yeah. So if after 6 cycle, if BRCA1 and BRCA2 come positives, we can give the PARP inhibitor, that is olaparib. In this case, we have to give at least for 2 years olaparib. But also there is another test we call HRD test.
Yes.
If we give a HRD test, what does that show? If HRD comes positive, that means there is a good response with the treatment. So for this reason, we can do. But again, we have to think about, we are in Nepal. How can we bring the balance between science and cost? विज्ञानले त के भन्छ तर हाम्रो खल्तीमा कति पैसा छ त्यो कुरा पनि हामीले बुझ्नु पर्यो.
Exactly. I'm not talking about, the homologous HRR somatic mutation and all, but at least what I was thinking, BRCA1, 2,
So
and
even
it's easily available.
Yeah. I mean, this is good idea to do for a BRCA test after that, but the drug, that olaparib, how much it costs? एक महिनाको 50-60 हजार पर्छ. हाम्रो तलब 30-40 हजार हुन्छ, कसरी 60 हजार हामीले एक्सपेक्ट गर्ने, त्यो पनि गाउँको बिरामीलाई. त्यही भएर
seeing the patient's financial condition, because before going to the treatment, we also ask like, what is your financial condition? That's what I'm saying. Before going for the test, we counsel with the patient. We say that this is the test required, this is the science says, whether you can do it or not. And we have an experience that beside the science, many patients who have or who are not getting chemo after the 6th cycle, they are in complete response for 3 years, 4 years, 5 years. For them, we call them for a regular follow-up. Like first year, we call them every 3 years, 3 months. Then in second year, 4 to 6 months. Then after third year, 6 months to 1 year. This is how we do the follow-up.
Okay.
So this patient needs next chemotherapy, that is Paclitaxel and Carbo. We can give 3 weekly, day 1, day 15 also is okay. But if the patient can afford, also what we can do is like we can give a 1 year of maintenance bevacizumab, that is VEGF receptor
So 1
blocker.
year.
Yeah,
Okay.
bevacizumab, that also we can give. That is indicated.
Okay, so that was about chemo and all. I would like to ask our Dr. Ujwal, since he's been practicing a lot on radio oncology. So in this case, high grade, like I have seen in so many this ovarian carcinoma, radiotherapy also we do give, right? So is there a role of radiotherapy in this case, high grade? I'm just like interested to ask, like either before surgery or after surgery, or there's no role at all.
Generally, there is no role of radiation therapy in any neoadjuvant or definitive or adjuvant setting in ovarian cancer.
Okay.
There is generally no any role of radiation therapy. It's purely surgical and medical management, as Dr. Eliza and Dr. Arun and Dr. Baral had said. And the case seems to...
Okay, if radiotherapy has no role, Dr. Arun, you was talking about PARP inhibitors, no? Like, it must be very expensive, isn't it?
Yeah.
Like, is per month. So financially also, it's a burden for the
Let
patient.
me add one thing. Right now, we are doing one study in Nepal in association with Mayo's Clinic of US. And in that, we are doing this HRR test for free to Nepali patients. And I think it's high time, no, let's not talk about the cost. We are talking about the patient's disease.
Okay.
And what we have seen initial data of the ovarian cancer is nearly around 50% of our patients have BRCA positive. And that's alarming. That means 50% of our patients will or might recur after a few years of therapy. So this we should take into account. We have the drugs, we do not have the drugs, expensive, not expensive, that's another thing. But what it says is that we have a lot of patients with ovarian cancer who might relapse. 50% is not a small number. So from now, what we have to do is, if possible, we have to tell these patients that you need to do this test.
Okay.
And this is very necessary. And drug, let me tell you, I think Dr. Baral will say much better. The drug that is using right now, paclitaxel, about 10, 15 years ago, it was nearly around 80, 90,000 per patient we had
So
to
the
give
price
them.
has reduced.
The price.
Yeah.
And the more we use it, the more it comes down. It will come down.
Okay.
But what we have to do is we have to see these patients, we have to screen these patients for this genetic condition, and we have to give them option about this treatment.
Okay.
That is very necessary.
So we can conclude that in this case, we can go ahead with the chemotherapy. I think the best thing is we have to counsel the patient for a regular follow-up. At least 1 year she has to be in a very close follow-up, right? Then I think repeat CT after each cycle.
Can I add one more thing
Sure.
in contrast with what Professor Kapendra said? Because I think, because I work in Patan Hospital, I think somebody who is working in maternity hospital, beer hospital, teaching hospital, they know the pain of the patient. So, for example, sometimes overdiagnosis is also the problem, I think. For example, Sir said the HRR test is doing it in free. That's excellent, we know that. But यदि त्यो जाँच गरेर कसैको पोजिटिभ आयो भने के गर्छ? उसले त मिटर ब्याज पैसा खोज्न जान्छ. We have seen some cases that. So त्यो कुरा पनि हामीले ध्यानमा राख्नुपर्छ जस्तो लाग्छ. तर yes, we have to go with the science. तर at the same time,
Hopefully there is no overdiagnosis in this case. Yes, exactly.
Diagnosis of these patients, what is happening is we are not only diagnosing this patient, we are even giving them the problem might come in their family. That is another thing we need to give them.
That's
Because
why
that means
genetic
that
testing,
which is very
no?
necessary. We are not only treating one patient. We have to see that we have to treat the whole family. It might come. And we have to make them aware of this condition. Of course, treatment and not, and if these patients are BRCA positive and if they do not get the olaparib-PARP inhibitor treatment, what next best thing we can do is we can call them more frequently, we can screen them more rigorously. That is another thing we can do. Thank you.
Okay, I think with this, I think we had a nice discussion with high-grade serous carcinoma. Let us move on to second case, as again we are running out of time. Wait a second. Yes. Hey-ho. Okay, case 2, we have, yes, 47 years old female, unmarried, presented to OPD with complaints of lump in the right breast just for 1 week. Okay, that was last April only, this year. So there were no positive history, no pain, no comorbidities, no past history of surgery. On examination, there was an ill-defined, hard-fixed, non-tender mass measuring 2 by 2 centimeter in the upper outer quadrant of the right breast. Bilateral axillary lymph nodes not palpable. With this examination find, investigation was sent. Blood investigation, to me, everything looks normal. CBC normal, RFT, LFT, blood sugar, PT, INR. These are all the routine tests, everything's normal. And ultrasound of right breast was done. On ultrasound, there was a solid mass, 21 by 33 millimeters. It's almost corresponding the clinical examination finding. It was 2 by 2. Here it's almost 2 by 3. And microcalcification in the superolateral part of the right breast. Impression in the ultrasound was strong possibility of carcinoma right breast, and FNAC was advised. Okay, since it involves the this ultrasound, I would like to ask the question to Dr. Vivek, but after mammo. Okay, so the mammogram of bilateral breast was done. The impression of mammogram, the report was small, benign, calcific spot seen in superolateral part of the right breast, BIRADS 2, breast composition B, that is only the areas of fibroglandular density. So these were the pictures, right and left and bilateral. So if somebody asks me, it's very difficult. Ultrasound, it says almost positive, let's say 95, 98%. Mammo, it seems negative. Looking at the report, I don't know how to read the slides. So what would you say, Dr. Vivek, in this case?
Thank you for the question, ma'am. We need to understand the imaging modalities here. Mammography is a special form of X-ray, which is fine-tuned for imaging of breast tissues. As we know, breast is composed of fibroglandular tissues and fatty tissue. Fibroglandular tissue is predominantly present in younger breast and pregnant and lactating breast. So this fibroglandular tissue will cast a dense shadow on mammogram. So as we see in images, this breast is actually dense breast.
So you think it's dense, the areas of denser areas are there.
So denser areas are whiter, brighter image, part of the images. So this means the breast has predominantly fibroglandular tissue. The problem with dense breast is that soft tissue masses can be obscured.
Okay.
So if I check retrospectively, there is actually a area of high density. Can you go back, ma'am,
Okay, so
images?
if you think that those are the breast density, and let's say you assume that those are density only, denser area, so what would you go for these BIRADS? Would you like to change the category here?
Yes, ma'am, I would like to change the category of breast composition to C, which is heterogeneously dense breast, which can obscure masses.
Okay.
Again, if I go back to images, I can see a area of added density in outer side of the right breast, ma'am.
So
Upper outer quadrant.
that will make BIRADS 3 or 4?
BIRADS 4, ma'am.
BIRADS 4. So that makes sense.
Right, ma'am.
Ultrasound report and BIRADS 4. But what about this ultrasound report? Why BIRADS not given in this case? What would you think?
In this case, unfortunately, BIRAD category has not been kept. Ideally, the mammography image and the ultrasound image should have been done in same setting, which is actually the purpose of having these two complementing imaging together. So if it would have been done together, it would have been a better to categorize it. So I go for BIRADS 4 in this case, which is suspicious of malignancy.
Okay. So normally also if we come across these type of cases, patient will come for FNAC, okay, after ultrasound, after mammogrammy. So what should we do? Like whenever we are in confusion in cytology, shall we go ahead with discussing with the radiologist and clinician, or at this point, would you advise to go for other imaging modalities? Is there any other imaging modality to detect those denser areas in the breast?
Yes, ma'am. MRI breast can be done for denser, denser breast. It has more sensitivity than both sonography and mammography. However, in this case, that is not required to make diagnosis because ultrasound has nicely depicted the findings, and the patient can then go for biopsy or FNC.
So we should have gone like one option is MRI in this case, right?
Right, ma'am. The role of MRI is in the high risk cases for screening and for local extension of the disease and to rule out multifocal diseases.
Okay. So after this ultrasound and mammogram, patient was sent for FNAC of the right breast. So actually, you know, like this FNAC of the breast was reported prior to this one, mammogram. And impression was IAC Yokohama system for reporting breast. It was the highest category, 5, right? Malignant ductal carcinoma of the breast. So these were the FNAC slides. I think the cellularity was quite less. We'll come to discussion of this part little later. So with this FNAC finding, surgery was done in this patient. It was right breast conservative surgery with level 2 lymph node dissection. And intraoperative and postoperative period was uneventful. So looking at the cytology FNAC findings, okay, the patient was sent for the surgery. And I would like to ask Dr. Kapendra, so is it okay just to go ahead with the FNAC, no true cut biopsy?
No, a complete no. What I really want to highlight on this occasion is to the pathologist here, please, 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 FNAC is not enough to diagnose breast cancer. It does not show the infiltration. It does not show the invasiveness of the disease. And that is very much necessary. As you all pathologists all know that
Yes,
very well.
yes, we are aware, but
Very
I was,
necessary. And the second thing is, for any lesion, if like this patient who has come with a lump in the breast and done a mammogram and done an ultrasound, of course, it is very difficult for the ultrasounds and the radiologist to tell you everything. Best thing you can do is do the mammogram and ultrasound in the same sitting. That helps a lot. We are not asking the radiologist, we are not quizzing the radiologist. We are asking them for the help to diagnose the patient. So again, in these cases, if there is a lump and mammogram says differently and ultrasound says differently also, we do not jump into other tests. We go for a biopsy. And a core biopsy is the first thing you do in these kind of patients. It helps in diagnosing the invasiveness of the patient. And again, the second thing is, the main important thing is doing the IHC. IHC is must before any treatment of breast cancer. Right now, just diagnosing breast cancer and jumping into the surgery is the worst thing we can do to a patient right now. Because breast cancer is not a singular disease, it is a multiple group of disease. And for each of these disease, each group, the treatment is different. A lot, right now, nearly 70% of our cases of breast cancer go into neoadjuvant chemotherapy. And
Yes.
that not only helps in treating the patient, but it really improves the survival of the patient.
Yes, that
That is
is
the
more
main thing.
important, no? Survival
Yes.
of the patient, outcome.
That's why,
we are
no, we should not
we are
go
worried.
into surgery based on FNAC. We need a core biopsy. We need to see the IHC of this patient, and it determines the further treatment of the patient.
Yes, I
Thank
do
you.
agree with you. That's what I was also wondering, why no true cut biopsy in this case. So after the surgical procedure, the specimen was received, which, which was showing a gray-white irregular mass. It was measuring 2.6 by 2.2 centimeter, and grossly all the margins were free. Histology, histopathological report. It was invasive carcinoma, no special type, ductal. When going for the histological grade, Nottingham histological grading, it was 8. So high grade, 8 out of 9, 3 plus total makes 9. So it is almost 3 nuclear pleomorphism, 2 mitotic rate 3. So 8. I think it's a high grade tumor. Then the other positive finding is DCIS component. It was present. Architectural pattern solid, and it is of intermediate grade. And I don't see any other findings, which is going to be helpful for the management. Uh, then IHC was done. I think it should have been little earlier with true cut biopsy, but IHC was sent. I think it's must for any breast carcinoma. ER positive, 45% of the cell with nuclear staining. Intensity strong, AL rate 7, quite high out of 8. So PR also 2% of the cell with nuclear staining. Positive intensity, again here also strong, and AL rate score 5. HER2, oops, it's HER3. It's not a new gene, it's HER2 new. It's also positive here. And percentage of cells with uniform intense complete membrane staining is 50. Ki 67, 20% of the positive nuclei. So looking at all this report, histopathological report and the IHC report, Dr. Suspana, what would you like to comment? Like the looking at this, the surgical report and IHC, does it make a one, let's say, a full workup to go ahead with the treatment or in this case?
So thank you, Dr. Sujata, for your question. So I like to, first of all, as Dr. Kapindra said, that's after the FNAC direct biopsy, excision biopsy is not recommended. So first, initially, true cut biopsy should be done. And in this case, I like to take the history of the patient. If there is a positive history of family history of carcinoma breast, then further investigation, which would I like to ask patient, is the BRCA status. Because I think you all people know there's BRCA mutate cancer, they well respond to PrEP rather than chemotherapy and the HER2 targeted therapy. And because this BRCA mutate cancer are well response to PrEP as well, and they also decide in true cut biopsy, also decide for the surgical decision and to assess the risk of risk of recurrence rate as well for the treatment choice of treatment. So in this case, all the 3 panel ISC panel shows that it is the triple positive, and this is a high grade tumor and high grade tumor. So if it is like that, and I'll say that we can further go with this biopsy report and we can treat. But although true cut biopsy was not done, so, and we don't know the patient history, family history. First, I like to ask the family history. If it is a true cut biopsy, then I like to do BRCA also and the BRCA status.
Okay, so not true cut biopsy. In this also, we can go ahead with the BRCA.
Yeah,
because
we
it might
can
run in families and
yeah, we can go, but already the biopsy has been excised, that tumor has been excised. So accordingly, we can also plan for the BRCA mutant
response
Yes,
for
and
the PrEP.
taking all these ISC everything into consideration, we can subclassify like what we do nowadays,
Yeah.
luminal type A, type B. That is also not done in this case.
No.
With that also, it's going to, I think, make a little change in the management.
So I think in this case, if it is a triple positive case with high grade, and then further we can go for the treatment. I think so. I think Dr. Kapindra will be better explain for the chemotherapy or whether HER2 targeted therapy or
Okay,
if it is a
okay.
BRCA positive.
Okay,
then
I'll come to Dr. Kapendra. So let me just show you because after this, the patient went for CT, okay, check CT. And CT was, I think, there was no positive finding except for this, some collection there, query seroma, lymphocyte, no residual or recurrent lesion, and no suspicious lesion in other solid organs. So chemotherapy is planned for 4 cycles. Okay, so soon after the surgery, this chemotherapy, 4 cycles of chemotherapy with adriamycin and cyclophosphamide was planned. 2 cycles already given. Now patient is there to receive the 3rd cycle. So my question goes to both Dr. Kapendra and Dr. Arun. You can do one, okay, or Dr. Baral. In the management at this point.
If this patient has come to me for the first time as a doctor, Siddha Maile patient Lajay, Dr. Kapendra, he will not do, I know, no FNAC, do biopsy. Because see, in this case, you have not done, even though HER2 is positive.
So whatever we have done, it's
positive
gone.
But
That is not
chemotherapy,
in our hand.
that is planned. So in now, the first concept of neoadjuvant came for breast cancer, then for ovary cancer. And now in our practice, in many cancers, we deliver neoadjuvant setup. So see, in this case, HER2 is positive, ER positive, PR positive. So first May, I think Dr. Kapendra may say, sir, please give 2-3 cycles of chemotherapy, then I will operate. That may be the scenario.
Neoadjuvant.
Neoadjuvant.
Yes.
That he will decide, we will decide. So tumor board discussion is important. In this case, definitely, HER2 positive, now roll up trastuzumab, now coming new drug, pertuzumab is very effective.
Yes.
So that is given in neoadjuvant setup also.
So if we, because this is ER, PR positive, and I think we can plan for Herceptin also in this case, like when to start, we have to be prepared for the future. Yes, Dr. Arun.
I think till now, I would say like surgeon, but they are also our colleague, he has already done a blunder. यसलाई त गल्ती भन्न मिल्दैन, ब्लन्डर भन्नुपर्छ किनकि अब I mean, like when some cases come, we don't need to go directly jump into the surgery. We need to look for the ISC. Then when it comes ERPR positive, then we have to do first surgery. If it is HER2 positive or triple negative, first we have to do the neoadjuvant. But some cases, like for example, HER2 is positive, but tumor size is very low, less than 2 centimeter, the grade is 1 or 2, and there is no axillary lymph nodes. In that case, we can go to surgery plus minus.
So we can say we missed it here.
Yeah.
Yeah, that
But
was bad.
in this case, it's a high grade and tumor size is more than 2 centimeter. So I think the standard of care for this patient is neoadjuvant chemotherapy. But again, regarding this, अब operation त भइसक्यो. अब यो भइसक्यो कुरालाई हामीले कुरा नगरेर हाम्रै साथीभाइले भएको. अब how we can correct this? So this chemo, usually we for the HER2 positive, we go with the Herceptin. Now TCH or TCHP regimen is the standard of care. But this regimen is also good because this is very cheap. This cost adriamycin and cyclophosphamide cost maybe 2,500, maybe 3,000 per cycle. So now she has completed 4 cycle. Now the time for the Herceptin. Or if she can afford, we can also advise for the pertuzumab and trastuzumab with taxane. So this is the standard of care. Yeah.
Standard protocol, let's say.
Standard protocol.
Okay, so whatever we have missed it, we can't get it back. So we should follow that. Yes, Dr. Kapendra?
I think there are a few places where we missed here. First thing is, we have not done the enough basic pathological workup, true cut biopsy and IHC. Second thing we missed is we did not do a full preoperative metastatic workup.
Yes.
We did not do that. We did the CT only after doing the surgery.
Yes.
That was another thing where we went wrong. And whenever we see a patient with breast cancer, I usually ask 2 questions. First, wo hoina. Simple. Is it cancer or not?
Not.
Second question I ask is, what type of cancer it is? Kosto ho. And this is determined with IHC. And the third question I ask is, kaha samma cha staging?
Yes, localized
Okay?
or
So
yeah.
these are the three questions which are very important before treating any breast cancer. That is the key to treating breast cancer.
Exactly.
After that, then we go for treatment, कसरी treat गर्ने. And in that, for this case, it's a high grade case with ERPR positive. It's a moderate positive, 45% is a moderate positive, and we have HER2 positive.
Yes.
In these cases, we usually go for neoadjuvant therapy. And in this therapy also, right now, what we are trying to do is trying to minimize the patient's toxicity.
Okay.
And in this, we try to avoid adriamycin. We try to avoid adriamycin, then we go for, we say, like Dr. Arun has already said, we go for TCHP. We go for Taxol, carboplatin, and we go for trastuzumab and pertuzumab. And that's the best combination right now for this case, the kind of cases. Of course, there are so few patients. In this case, especially where ERPR is positive, in this case, we might go for, like what has been done, adriamycin cyclophosphamide, and then go for Taxol and HP also. That is another thing. But another important thing that we have to do is, whenever we start with neoadjuvant treatment, or target treatment, we finish the chemotherapy first. After that, we go for the other mode of treatment, surgery. We just don't say, okay, let's give 2 cycles, then we see. We have to complete the chemotherapy first. That is another thing which is very necessary.
And in this case, hormonal therapy has not been prescribed so far.
And again,
Yes.
like Dr.
Maybe plant little later.
And another thing is, like, if he has a family history, and again, in this case, how it helps is if we send for the genetic test, if it comes positive, then we not only have to treat this big breast, we have to treat the another breast, and we have to treat the ovary also. So we do not have to do multiple surgery in these patients. In one time, we can treat all this at once. So this, if we integrate everything beautifully, then we give less problem to the patient.
To the patient, right.
Yes.
I
Thank
do
you.
agree with you. So Dr. Ujjwal, okay.
One point.
Yeah.
Can I add one point? Like sometimes I would say, like being an oncologist, कहिलेकाहीँ हामीलाई पनि थाहा हुँदैन के टेस्ट गर्ने. But pathology, you see the real specimen. So when you see the real specimen, you feel that that patient might need other tests. At that time, you can recommend.
Exactly.
We
That's why I
positively
always say, no,
accept that.
do not hesitate.
Yeah.
Do not hesitate to ring your friend, colleagues. Please let us talk with our clinicians, surgeons, like whoever you feel like talking. I think we should talk. That is very beneficial for the patient, because whatever we've done, like we cannot get it back. So it should be, treatment has to be very precise whenever it comes to any oncology case. So in this case, what I've noticed is there were DCIS component. So I would like to ask Dr. Ujjwal, again, because I have seen many DCIS case, we go for radiotherapy. Is there a role here? Just a query.
You're asking the role of radiotherapy in this case? Before talking about that, we should all remember.
It's in the history report, this DCIS component.
We all should remember that management of cancer is a multimodality treatment. Like in this case, you have portrayed the best picture that we do encounter every day in Nepal. There has been not complete staging and multimodality discussion before the treatment. And the multimodality involves the pathologist as well, radiologist, and the surgeon, and the medical oncologist, radiation oncologist. So it is better if we could all sit together and plan for the treatment. So luckily this patient was hormone positive, but if she was a triple negative case, then it is grossly mismanagement, as Dr. Arun has said. Talking about role of radiotherapy in this case, yes, definitely. When the breast has been not totally removed, there will be always role of radiation therapy.
It's a conservative surgery, right?
Yeah.
Right. So I think we can go ahead with that. And with these two cases, the discussion is almost over. So with these two cases, what we have concluded is it's always better to discuss before. Whenever it's any cancer case, oncology related case, discussion is very important before jumping into the management. Okay. And once we decide everything, like stepwise, we can go for the surgical procedure, followed by medical oncology, whether it is chemotherapy or radiotherapy, and the genetic testing. Okay, whenever or wherever it is feasible, that is a must, because we are dealing with all the new cases. We want a good outcome, we want quality of life in patient. It's not like that, okay, somebody died because of cancer. We don't want patient to die because of cancer. So I think with this we had quite good discussion in both the cases. I would like to thank all the panelists. We look forward to have more of this discussion in the coming days. Thank you so much. Thank you.
Thank you so much to our esteemed panelists for your valuable insights and engaging discussion. Your expertise has truly enriched this session. A special thanks to our moderator for skillfully stirring the conversation and keeping it focused and dynamic. We are grateful for your time and contribution. Please join me in giving them a big round of applause. Now, I would like to request President of NME, Dr. Anil Bikram Karki, to come to the stage and give the token of love to the panelists. Dr. Kapendra Shekhar Amatya.